μικρόφωνο είναι ανοιχτό. Εντάξει. Good morning, everyone, and welcome to our first roundtable discussion of CAMeSM 2026. We're honored to begin with an important and deeply relevant topic in oncology, beyond cancer treatment, a roundtable on holistic oncology care for adolescents and young adults. Adolescents and young adults, defined as patients between 15 and 39 years of age, represent a unique group in cancer care. Their needs often extend far beyond diagnosis, chemotherapy, radiotherapy, or surgery. They may face challenges involving fertility, mental health, education, career development, body image, relationships, family support, and long-term survivorship. Today's roundtable will explore how oncology care can move beyond treating the disease alone, and instead address the patient as a whole person, with medical, psychological, social, and personal needs. This session will be led by Dr. Valentinos Kounis, Director of the Medical Oncology Department at the German Oncology Center in Limassol, Cyprus, who will lead the discussion along our student participants. Alexia Theophanaki, Lucia Pandeli, Dimitra Papala, and Tala El Ghazawi. We invite you to listen actively, reflect on the perspectives shared, and consider how future doctors can contribute to more compassionate, multidisciplinary, and patient-centered cancer care. Please join me in welcoming Dr. Kounis and our student speakers. Thank you.
Good morning, everyone. You are quite away. I did really hate every time people tell us to come forward, but you are quite away. Anyway, thank you for coming. My name is Valentinos Kounis. I'm an oncologist, and I had the pleasure and the blessing to work with these lovely guys here to present you something really exciting today, on something in oncology, dealing with young people. It might sound heavy initially, but it isn't. And as future colleagues, I think we all need to be mindful about what we may come across, whether you become GPs, gynecologists, pediatricians, whatever your specialties are. We do need to have oncology in the young adults in mind. I will not say any more, so we're ready to start. Thank you.
Yes. Good morning, everyone. My name is Dimitra Papala. I'm a fifth-year medical student, and today we will present to you a roundtable discussion on holistic oncology care in adolescents and young group, focusing on key challenges that extend beyond cancer treatment. Adolescents and young adults are defined as individuals between the ages of 15 to 29 years old, representing a young group between pediatric and adult oncology care. These populations face many challenges due to ongoing physical, psychological, and social development. So a holistic oncology care focuses not only on treating the disease, but also improving long-term outcomes such as quality of life and mental well-being. An important but overlooked aspect of this care is pain. So now I will focus on pain in young adults, specifically how it is recognized and how we can manage pain. So as I said, pain is under-recognized. Why is this happening? This is usually because patients underreport symptoms due to perceived stigma or concerns about how they will be viewed. Usually, patients want to be independent, especially at that age, so that's why they don't express their symptom, especially pain. In addition, pain is not always expressed clearly as it is influenced by emotional and social factors. For example, patients may minimize their pain because they don't want to worry their family. Social influence, like peer pressure or family expectation, may further affect how openly patients communicate their symptoms. And on the other hand, clinicians may underestimate the pain that the patients have. So, pain in this group is more complex than it appears. Pain in this age group is not only a physical symptom, but a biopsychosocial experience. It is influenced by biological factors, psychological state, and social environment. Changes in the nervous system can increase pain sensitivity, while anxiety, depression, and emotional distress can affect how pain is expressed and reported. Developmental factors such as growing independence and identity formation may also influence how young people communicate or sometimes minimize their symptoms. Because of this, pain should be assessed using a holistic biopsychosocial approach rather than focusing only on physical cause. Before discussing management, it's important to understand why pain awareness actually matters. Pain is not only, as I said, a physical symptom, but it affects every aspect of patient's life. Firstly, pain can significantly impact treatment. Patients who experience persistent or severe pain may avoid medication, physiotherapy, or follow-up appointments because the process being overwhelming. Chronic pain is strongly linked with anxiety, depression, and emotional distress, as I already said. And this creates a cycle where psychological stress can worsen the perception of pain. It also affects the quality of life and the long-term outcomes. As it's shown on the diagram, it influences mobility, daily activities, relationship, and mental health and overall well-being. Finally, early recognition is essential. Identify pain early allows earlier intervention, better symptom control, and ultimately improves prognosis and patient's outcome. There are multiple barriers to effect pain management in this age group. Firstly, fragmentation between pediatric and adult healthcare services can lead to discontinuity of care and inconsistent management approaches. Secondly, clinician-related factors like implicit bias may contribute to underestimation of pain severity. So that's why patient-related stigma can result in underreporting symptoms. And all this can cause lack of communication between patients and healthcare providers. How we assess pain? Effective pain management begins with a comprehensive assessment. Pain assessment should not only focus how strong the pain is, it also need to be considered how long the pain lasts, when it occurs, and how it affects patients' daily life and activities. Psychological factors, as I already mentioned, are also important because they can influence how patients experience and describe the pain. And finally, pain assessment should use a communication method that appropriate for the patient's age and level of understanding. So patients can describe their symptoms more accurately, and this has to be done regularly. So pain management in this age group should follow a multidisciplinary approach. This means different healthcare professionals, including oncology, psychiatrists, pain specialists, and supportive care teams should work together to provide the best care. Management should be individualized based on the patient's medical condition, age, and psychological needs. treatment usually includes both pharmaceutical and non-pharmaceutical approaches. The overall goal is not only to reduce pain, but to improve daily function and mental well-being, and in general, quality of life. Pharmacological pain management usually follows the analgesic ladder. Treatment often starts with non-opioid medications such as paracetamol or NSAIDs, and opioids are used when stronger pain relief is needed. Other medications like antidepressants may also help, especially in nerve-related pain. Overall treatment should be safe, individual, and regularly reviewed based on the patient response, and we have to consider side effects and the risk of dependency, particularly with long-term opioid use. Non-pharmaceutical management is also important in pain treatment and help improve overall well-being. Psychological support as counseling and therapy can help patients deal with stress and anxiety related to the pain. Physical therapy and rehabilitation help improve movement and daily activities. Relaxation techniques like breathing exercises and mindfulness can also help reduce pain. But most importantly, family and peer support are important because they can help the patient cope better and feel supported. Overall, these approaches help manage not only the physical pain, but also the emotional and social effects of pain. In conclusion, pain in adolescents and young adults patients is complex and often under-recognized and under-treated. Because of this, pain management should not focus only on physical symptoms. Instead, it should follow a holistic biopsychosocial approach that also considers psychological, emotional, and social factors. And early recognition and individual management can improve not only pain control, but also the treatment, mental well-being, and in general quality of life. So, now.
Good morning, everyone. My name is Stefanaki Alexia, and I will present about the rhabdomyosarcoma in adolescents and young adults, focusing on recent scientific insights, biological differences, and clinical challenges. But first, what is rhabdomyosarcoma? It is a rare malignant soft tissue sarcoma that originates from skeletal muscle precursor cells. It is most commonly diagnosed in children and adolescents, but it can also occur in young adults. There are two main subtypes: embryonal rhabdomyosarcoma, which is more common and usually has better prognosis, and the alveolar, which is more aggressive and is often associated with a specific genetic fusion. Rhabdomyosarcoma represents only a small percentage of pediatric cancer, but is the most common soft tissue sarcoma in childhood. Recent research has shown that rhabdomyosarcoma is not a single disease, but rather a heterogeneous group of tumors with different biological behaviors. Because of this, molecular classification has become very important. Now we divide tumors into fusion-positive tumors, which are generally more aggressive and have a worse prognosis, and the fusion-negative tumors, which show more variability in behavior and outcomes. Several genetic drivers are currently being studied, especially PAX3 and PAX7 FOXO1 gene fusions, which are strongly linked to aggressive disease, and other regulators such as epigenetic modifiers and RNA helicases like the DX5. Because of these findings, molecular stratification is now increasingly guiding treatment decisions, rather than relying only on histology. Fusion-positive tumors are usually seen in the alveolar subtype, and they are characterized by specific gene fusions. These fusion genes act as abnormal transcription factors, meaning they disrupt normal gene regulation. As a result, they promote tumor growth and prevent normal muscle cell differentiation. Clinically, these tumors are more aggressive and associated with worse outcomes. In contrast, fusion-negative tumors, which are more common in the embryonal subtype, do not have a single dominant mutation. Instead, they show multiple genetic alterations. These tumors are more heterogeneous, meaning their behavior can vary between patients. Beyond genetic mutations, rhabdomyosarcoma is also driven by changes in cellular pathways and gene regulation. Epigenetic mechanisms such as DNA methylation and histomodification can alter gene expression without changing the DNA sequence. Proteins like RNA helicases, including DX5, are also involved in regulating these processes and may contribute to tumor progression. In addition, several key signaling pathways are activated in rhabdomyosarcoma. Together, these pathways promote cell growth, survival, and resistance to therapy. Now, focusing on adolescents and young adults, this group is usually defined as patients between 15 and 39 years of age. Rhabdomyosarcoma in this age group is rare, but more aggressive and clinically very important because outcomes are generally worse compared to children. Both biological and clinical factors contribute to poorer outcomes in this group. In AYA patients, rhabdomyosarcoma is less common than in children, but it still represents one of the more frequent soft tissue sarcomas. Compared to pediatric patients, AYA individuals are more likely to present with advanced disease, metastatic spread diagnosis, and larger tumors. In some studies, a significant proportion of AYA patients already have metastasis at the time of diagnosis, which immediately places them in a high-risk category. One of the most important findings in recent years is that rhabdomyosarcoma in AYA patients is biologically distinct. There is a higher frequency of fusion-positive tumors, particularly those involving these specific rearrangements. These fusion-positive tumors are strongly associated with more aggressive behavior, higher risk of metastasis, and worse overall prognosis. This suggests that age is not just a clinical factor, but may also influence tumor biology itself. In practice, AYA patients often present with more advanced disease than children. They are more likely to have large primary tumors, lymph node involvement, less histology distribution, and lot metastasis, especially to lung, bone, or bone marrow. Because of this, many AYA patients are already classified as high risk at diagnosis. Also, there are several reasons for poorer outcomes in this group. First, tumor biology tends to be more aggressive, especially in fusion-positive disease. Second, diagnosis is sometimes delayed because early symptoms may be overlooked. Third, AYA patients are less frequently enrolled in pediatric clinical trials, which often provide the most standardized treatment approaches. Finally, treatment intensity and approach may vary between pediatric and adult oncology systems. Treatment remains based on a multimodal approach, including combination chemotherapy using established regimens, surgery when possible for local tumor control, and radiotherapy to reduce local recurrence risk. Important studies show that AYA patients tend to have better outcomes when treated with pediatric-style treatment protocols. Recent research has focused strongly on improving understanding of the disease at the molecular level. Key developments include increasing use of genomic profiling to identify tumor mutations, improved risk stratification models combining age, biology, and disease states, and growing recognition of the need of AYA-specific clinical trials. These trials are important because AYA patients do not fit perfectly into either pediatric or adult oncology categories. Although chemotherapy remains the main treatment, new approaches are being studied. These include targeted therapies aimed at specific signaling pathways, epigenetic drugs that modify gene expression, and early-stage research into immunotherapy combinations. However, it is important to note that none of these are yet standard treatment for rhabdomyosarcoma. Despite progress, several major challenges remain. The disease is rare, making large studies difficult. There is a lack of dedicated AYA-specific treatment guidelines. Tumor heterogeneity complicates treatment standardization, and relapse remains difficult to treat effectively. The future of treatment is moving towards precision oncology. This includes integration of genomic and clinical data, use of AI-based risk prediction models, stronger international collaboration in AYA research, and development of fusion-targeted therapies. The goal is to move away from one-size-fits-all chemotherapy towards more personalized treatment strategies. To conclude, Rhabdomyosarcoma in adolescents and young adults is a rare but highly important disease. Compared to children, AYA patients tend to have more aggressive tumor biology, more advanced disease at diagnosis, and poorer survival outcomes. However, recent advances in molecular biology, genomic profiling, and clinical research are improving our understanding and opening new treatment possibilities. The future lies in personalized, biology-driven therapy and dedicated AYA-focused research. Thank you.
Hello everybody, my name is Tala Al-Ghazawi. I'm a second-year medical student, and today I'll be presenting a case study on perimeningeal rhabdomyosarcoma to show how this case presents clinically. So first of all, what is rhabdomyosarcoma? Rhabdomyosarcoma is a rare type of cancer that develops in the soft tissues. It is most commonly found in children and adolescents, and it often arises in the head and the neck region. One important feature is that it tends to grow very rapidly and to spread nearby structures. In our case, the tumor originated at the base of the skull in what we call the perimeningeal region. Perimeningeal region refers to areas that are close to the meninges. And what are meninges? They are the surrounding layers, the protective layers surrounding the base, the brain, and the spinal cord. Now let's have a closer look at our patient. This case involved a pediatric patient diagnosed with perimeningeal rhabdomyosarcoma, and as we said, the tumor originated at the base of the skull, placing it in a very high-risk anatomical location because of its close proximity to critical neurovascular structures. From the beginning, the tumor showed an extension beyond its primary site, and importantly, there was a very high risk of spread along nearby nerves and into the central nervous system, in which we will be discussing in the further slides. But first, to visualize this more clearly, imaging was performed. And as we do not have access to the original imaging, here are representative imaging demonstrating similar findings. So the tumor here is indicated by the white arrows as a large mass in the nasopharyngeal region. And it is extending towards the base of the skull. So we can see that the tumor is spreading into the surrounding areas rather than staying in one place, which explains the aggressive behavior we have just talked about. As a result of tumor spread, there was involvement of nearby cranial nerves, specifically the 5th and the 7th cranial nerve, so the trigeminal and the facial nerve. Firstly, the 5th cranial nerve, so the trigeminal nerve, is responsible for facial sensation and chewing, and its involvement would lead to reduced corneal reflex and facial numbness. And the 7th cranial nerve, so the facial nerve, is responsible for facial expressions, and its involvement would lead to difficulty in closing the eye, in facial weakness, facial asymmetry, so similar to a Bell's-like palsy presentation, as we can see on this image. Now, clinically, the patient presented with symptoms that involve the cranial nerves we have just spoken about, so facial numbness, facial weakness, and reduced corneal reflex. However, in other cases, patients may experience other symptoms, such as headaches, hearing loss, visual disturbances, and in more severe cases, the patient can experience seizures. Now, in terms of disease progression, the patient was initially treated with chemotherapy and proton beam therapy. This led to a partial improvement. And however, this was quickly followed by a relapse where the disease came back. And not only did it come back, but it has now spread into the central nervous system and into the spinal region. So this led to advanced disease characterized by treatment-resistant and an extensive tumor burden. So again, these are representative MRIs. And these images show the disease after relapse. So on the left, we have a coronal view, and on the right, we have an axial view. And we can see the red circles here highlight that there's a large mass in the nasopharyngeal region. And we can see now that the tumor has spread, and it has spread into the nervous system. This is what we call a leptomeningeal involvement. This means that the tumor is now spreading along the lining around the brain and the spinal cord. We also now have a spinal dissemination, where the tumor is traveling further down along the spine. So again, this leads to a more widespread stage of the disease. And again, why is this clinically important? Because of its location near the base of the skull, the tumor can invade early and spread along the nearby nerves, and this actually creates a pathway for it to reach the central nervous system, which makes it a very aggressive disease with a rapid progression. So now we have a high-risk condition with poor prognosis. Now, in terms of treatments and challenges, so the patient was initially treated with chemotherapy and proton beam therapy. This led to initial improvement with a partial response to therapy. However, this was quickly followed by a relapse, and unfortunately, the patient became resistant to any kind of therapy, and this has led the disease to spread all over the central nervous system, making it extremely difficult, if not impossible, to manage. So to conclude, this case study shows how aggressive perimeningeal rhabdomyosarcoma can be. Because of where it's located near very important structures, it makes it very difficult to manage. And even with treatment, the disease can relapse and continue to progress. And I think the key takeaway of this presentation here is that rhabdomyosarcoma is extremely difficult on patients, and early diagnosis is very important, and we need to continue research to improve the outcomes for these patients. Thank you.
Good morning. My name is Lucia Panteli, and I'm also a medical student. So, in oncology, we're trained to save lives. But for the adolescent and young adult patient, saving the life is only half the battle. Today, we're looking at the invisible side of survival. Our goal is to shift the clinical perspective from disease-free survival to holistic survivorship, protecting the person they intended to become. Okay. Who is the AY patient? They are the 15 to 39-year-olds caught in the treatment gap between pediatric playrooms and geriatric wards. When we treat a 20-year-old, we're managing a 50-year survivorship trajectory. A diagnosis here causes a developmental freeze, shattering milestones like graduation and career building. We aren't just treating a tumor, we're managing a life interrupted. For a young person, a cure resulting in permanent infertility is often experienced as a profound loss. Oncofertility is not an elective. It's a day-one medical emergency. The golden window exists only between diagnosis and the first dose of treatment. We must weigh the risk of high-dose alkylating agents, which carry an 80% fertility rate, against the 10 to 14 days needed for egg harvesting. This is a critical ethical trade-off. The tragedy is the 80% gap. 80% of AYAs want to this discussion, yet 65% of providers fail to initiate a referral. As the frontline medical students and residents, we own this. If the treatment is gonadotoxic, a reproductive specialist should be paged as automatically as a surgical consult. Silence today is a closed door for a patient's future. Directly linked to fertility is the most ignored topic in rounds: sexual health. Early menopause, surgical scars, and PORTS fundamentally change a young person's self-schema. Patients often wait for us to give permission to discuss those topics. If we stay silent, we validate their shame. Sexual health is a vital sign of AY quality of life. It belongs in our clinical notes, not just our side conversations. Biologically, the AY brain is still maturing. A diagnosis triggers identity foreclosure. Sorry. The trauma of losing independence and returning to a dependent role with parents. While their peers hit milestones on social media, the AY patient is stuck in an infusion chair. This social comparison trap leads to high rates of clinical depression that geriatric models simply aren't designed to catch. Even in remission, the shadow remains. No, it's not choking, it's just dizziness. Sorry. Even in remission, the shadow remains. Damocles syndrome is the chronic fear of recurrence. For a young person, every minor headache is perceived as a terminal return. This isn't just anxiety, it's a lifelong burden of hypervigilance. Our job is to provide the psychological tools to manage this sort for the 5 or 6 decades of life they have ahead. AY patients have distinct psychological and support needs. So in Cyprus, no established AOA rhabdomyosarcoma support groups. They are not established, and support is mainly general cancer groups. Globally, sarcoma-specific groups exist, but not disease-specific. Best current approach is to combine the AOA communities and sarcoma support groups and use online and virtual platforms to connect internationally. This matters because peer support helps reduce isolation and improves coping and emotional well-being. To conclude, clinical success is measured by the quality of life saved, not just the absence of cells in a scan. We're here to protect the future self, and I'll leave you with this. If a tumor requires immediate treatment, but harvesting takes 10 days, where do you draw the line? Thank you. There are references, and thank you.
Thank you, everyone. Before we go into questions and discussion, allow me to go back to the opening, and I would like to say thank you to the organizing committee and to the European University for giving us the opportunity to be here. So that's the opening done. Now, I would like to thank you all 4 of you, and for you guys, lesson number 1 is teamwork. Always, wherever you may be, whether you're a lab clinician, whether you're a lab scientist or a clinician, you will need to have a team. And if you learn to work within a team as a member, then everything will be easier in your life and in your careers. So now we've got 4 students. Everyone had different ideas about today, and they managed to combine everything and form a nice presentation. For that alone, I'm very, very proud of you guys. So well done. Now, questions from you. Yes, please.
Hi, I have a question for the penultimate speaker. Sorry, I don't remember your name. But a lot of what I've heard you talking about, the symptoms, could also be epilepsy or a brain lesion. How would one differentiate that? Should I say it again? Yes. Sorry. Question for the penultimate speaker. A lot of what I heard you talk about, the symptoms, could be a brain lesion or epilepsy. how do you differentiate that and make the cancer diagnosis?
Tala, you might need to.
Thank you.
Yeah. Again? Yeah.
So the symptoms differ with which cranial nerves are involved. So for example, as we said, the 5th and the 7th cranial nerves here were involved, and this led to more of facial symptoms. But however, in other cases, it can be, so it's mainly where the tumor is located and where it's spreading and what it's affecting. Hope this was clear.
I think that's a great question, and I think the importance of your presentation, Tala, the part of your presentation was to highlight the importance of all of us to be at least aware of the basics of where a tumor might be and what structures it might affect. So if it was near the structure of the brain that controls the hand, the fine movements, then you lose that, then you start thinking, is it something acute, i.e. a stroke? Is it something that happened over a period of time? Then we start thinking about neoplasias and cancer, or epilepsy in that sense. Where is it coming from and why? And I think epilepsy is one of the common clinical signs in children. It does not mean that everyone has cancer, but then if we know the structures, then we need to know when to start investigating more and more. Thank you for the great question. Next, please. Any questions? Theo Harris.
Yes, I
Yes,
also
thank you.
have a question. First of all, let me congratulate you on your excellent and very insightful presentations. You've done a terrific job. I have a bit of an open-ended question, actually. You've mentioned how, looking on the future, we should expect a lot of AI use in oncology. My question is actually, and this is either directed to you, Dr. Kounis, or to everyone, how would you guys believe we should use AI, and what are the potential use cases of AI? For example, like in the rhabdomyosarcoma cases, how would you approach them? Do you think there are any particular use cases for AI in that context? Thank you.
I don't know any specific.
No. Yes.
Yep.
I don't know any specific use for AI in rhabdomyosarcoma, but definitely may exist in the future with the symptoms, with every specific patient, any use. I'm not.
Also for that, I know that there are some cases that already, or AI was already implemented in the medical field for massively studying scans and finding a specific pattern that many doctors might lose a bit more easily, and trying to find the most common, at least, patterns, and maybe detect cancer a bit more earlier than a doctor would, let's say. But it has to be used in a moderation, obviously, and it has to be trained to do exactly that.
Again, another great question, and thank you. I think AI is everywhere, and one of our tasks when we started this process was to brainstorm and start making our presentation without using AI, and then obviously use it if we had to. But you can ask AI about what kind of pasta you're going to have tonight. You're going to ask AI where you're going to go on holidays in Greece, and it will give you 1,000 answers. So it's a great tool, and it's everywhere, and we don't need to hide that it is everywhere. Now, in practice in oncology, how things are changing is the complexity of the disease is very, very demanding. The needs of the patients increase rapidly, and we do need to use any tool we have to get the optimal result. And the optimal result, obviously, is for people to live healthy, live longer, and live well. So exactly, I'm taking from Lugia where you left, early diagnosis, accurate diagnosis, and optimal treatment. And AI can help there, but if we do lose our criticism and able to criticize every question and second guess even AI, then we've lost the game. So unless all of you guys, learn to use your minds, then that's absolutely perfect. If you rely on AI from now until the end of your careers, you're just going to be speaking about AI decisions to your patients, which is not going to be of any satisfaction to you. So please, I'm talking to you as a person who lived before the era of AI, and I'm seeing the transition now. I'm not claiming that I have any superpowers or I know how to, give any better answers than AI or ChatGPT, but at least I have the basics to second guess any answer I get in front of me. So please, trick yourselves, wonder if this is what I'm reading is correct, and then use it for your essays, your assessments, or your patients in the future. So AI is here, but we have to be here as well. Next question, please. Right, Harris, do we have time? Yes. All right, can I just reverse the question now to the audience? Okay. Now, do we have anyone out there that wants to do oncology as a career? I'm not going to ask you a question, don't worry. Excellent, well done. You, sir? Maybe? Okay. Now, to all of us, why do you think, so there is a lot of discussion about increasing number of cancer these days, and younger patients come up as patients with cancer. Do you have any idea why? We'll give you a microphone, please.
Maybe. Hello?
Yeah, hello.
Okay. Hi. I'm not sure. I'm just going to try and answer. For sure, environmental factors play a huge role, like nowadays. And maybe because now we can actually diagnose it more, maybe. We have more advanced testing and stuff because, yeah.
Absolutely.
Something like that. Thank you.
Do you want to add anything, please? That was a good answer, by the way. Well done.
Also, because of the excessive chemical use of the younger generation, such as nicotine and other factors regarding smoking, may increase certain types of cancer.
Okay, good. Thank you. I think we've got one more. I'm sorry, Dimitra. Bit more steps for you. No worries.
And I also think that radiation plays a key role. Like kids nowadays grow up with smartphones, tablets in their homes. They spend too much time compared to the previous years. And I think this radiation plays a role in causing mutations in patients.
Okay, so you mean less physical activity? Is that? Sorry.
No, I mean that kids and younger adults spend more time with electronic devices than all the previous years. They have more devices, which cause radiation,
okay,
causing mutations.
Yeah, could be
cancers.
Thank you. Anything else?
Also, a wild guess, the quality of the food we eat, it's gotten much worse in the last century.
And also we're living longer, so more chance for bad genetic mutations?
Thank you all for your answers. That was a trick question because anything you said, it was going to be correct. So environmental, genetics, radiation, what we eat, that's all examples of cancer increasing in our generation. But the most important thing of everything is what we first heard, that we overdiagnose. So we've got the means now, we've got easy access to CTs, to MRIs. Now we have the technology, you have the knowledge, it's just we need to apply the knowledge in our everyday practice, and this is where this presentation comes to play a role. So unless if we know to assess the pain in a young person, then we wouldn't know. If a patient comes and they're 18, they've been to the gym a couple of times this week and they have a new pain that does not go away, that's important, okay? If we do not know that there are rare diseases like rhabdomyosarcoma, it doesn't mean that everyone is going to have rhabdomyosarcoma, but we have to have that in mind. But most importantly, when we're dealing with young people with cancer, is what Lugia said, that we need to think about fertility. And many of us do not even know whether we want to have kids when we grow up or whether we're going to have kids at all. But we have to have the chance to decide that maybe now or later in life. So everything is important, and this is why we named the presentation as a holistic approach to oncology. Genetics, treatments, clinical trials, that's great, but you guys, as future doctors, need to have an open mind. What we want to get out of this presentation and hopefully take it a step further is whether we can help in any way form a national network of support for our younger patients, whether we can help form a network that they can talk to people about their fertility, they can have psychological input for them and their families. So hopefully this may be the start of something that's going to help people in the near future. I would like to thank you again. Well done.
Thank you.
Before anyone leaves, as you may know, we have awards for the roundtables. So if you like this roundtable, you can scan this QR code and vote. It will be up for a minute approximately. Yes. And thank you everyone for attending. And of course the presenters and our doctor.
Σου δούλεψε? Ούτε στα κορίτσια.
Thank you. Γιατί μου λέει όχι να το φοράσει είμαι γραμμένη γιατί βάλα να ξανακάνω register τα δόμπα και μου λέει ότι έκαμες register, οπότε... Τι? Ναι, γι' αυτόν το λέω όμως. Εγώ έκανα ήδη register, οπότε είμαι στο CAMeSM. Οπότε μου έβγαζε και μου έλεγε ότι... Πώς το λέμε? Το required ότι σου δεν δουλεύει, τι ήταν. The registration ID is not authorized for voting. Πρέπει να κάνω check-in για να κάνω. Πρέπει να κάνω check-in, δηλαδή σκάνε το έξω για να...
Τι είναι, πώς είσαι, καλά? Τι εννοείς? Α. Λογικό ρε φίλε, λογικό. Εντάξει. Τι είπες? Έγινες Κύπριος ρε φίλε. Με προσβάλλεις τώρα. Εντάξει. Εγώ φτιάχνω τις τράπεζες, οπότε δεν κάνω άλλο. Έτσι. Α, όπως ήμουν. Περίμενε, τι. Πες μου, τι είναι. Ναι, όχι, ευχαριστώ πολύ, πες μου. Θεματολογία έχει. Θεματολογία έχει. Τώρα είναι. Όχι τώρα,
Όχι, αυτό είναι για το organizing committee. Ναι, με την κυρία Ζαμπέκου μιλάω. Ναι, η Έλληνα είμαι, από το Round Table. Ναι, ξεκινάμε 2 η ώρα. Ωραία, τέλεια, ωραία, ευχαριστώ πολύ.
Είναι οκ, ήταν που το έβαλα. Ναι. Ευχαριστώ. Τι. Να τα βάλουμε εδώ, ναι.
Λοιπόν. Εδώ. Θυμάστε που κάθεστε.
Ναι, εγώ κάθομαι μετά τη γιατρό. Άννα, κάτσε εδώ. Ναι.
Ο Θεοχάρης πού είναι?
Έκαμε στο να μην κλείνει, ναι.
Πώς το κάνω αυτό, Ρίζο?
Στα settings.
Φτιάξτε.
Σίγουρα, ναι.
Απλά χρειαζόμαστε κάποιον να το δει.
Ναι. Πού σε βολεύει?
Να το έχω εδώ για να μην...
Ναι.
Θες να τα βάλεις κάτω από το δικά μου? Ή εδώ?
Όπου θέλετε.
Εδώ.
Να το βάλω.
Απλά πρέπει να μείνουν καθαρά τούτα απλά για να αλλάζουμε τα...
Ναι, άμα το κάνουμε λίγο έτσι.
Μπορείτε έτσι εδώ.
Εγώ εδώ.
Οκ, μια χαρά.
Ή εκεί.
Να δούμε πώς φαίνεται.
Εντάξει, δεν είναι.
Ναι.
Ναι.
Ιδανικά θα το ήθελα εδώ, αλλά anyway.
Ναι, βασικά όπως. Τι τσάντα μου.
Δεν θα τα αφήσεις εσύ. Ναι, εντάξει.
Το κεντρικές προτείνεις.
Σου κάνω παραπέζι. Ναι.
Εντάξει, έφυγε.
Θα το αφήσουμε να δούμε μήπως και κλείνει.
Το έφτιαξες?
Ναι.
Τέλεια.
Να κλείσω και το Wi-Fi. Χαρά.
Κάτσε εδώ και να μην έχω ειδοποιήσεις και κλήσεις.
Να δω, να δω πώς φαίνεται κάτω-κάτω δικό μου.
Ναι, φυσικά.
Εντάξει, έχουν περαστεί οι αλλαγές, δηλαδή είναι thanks. Ναι. Και αυτό κάνει έτσι. Ακουγόμαστε. Πώς θα... Αυτό με άγχωνε και χθες.
Ακούγεσαι όμως.
Και εδώ, ακούγομαι.
Πού θα τα αλλάζουμε από εκεί? Ναι, από εκεί θα τα αλλάζουμε.
Δεν έχει το remote.
Επειδή είπες ότι θα έχουμε το remote. Δεν, σας είπα χθες ότι δεν το έχουμε τελικά. Δυστυχώς δεν έχουμε. Ούτε laser έχουμε. Εκεί είπα κοντά στο laser. Γιατί πάνε και το βάζουν στα μάτια τους. Χριστός και το σάικο θα το έκανε αυτό. Την έχουμε βάλει στη μέση για να είμαστε... Εσύ?
Ό,τι θες. Ό,τι θέλεις, προφανώς. Αν γίνεται να είναι... να είναι στο... ξέρεις. Να μην χτυπήσει, θέλω να πω, κατάλαβες. Δεν είναι στην...
Απλά μην μπορείς βάλει το μου και σε presenter.
Έτσι είναι πάντα, δεν μπορεί να πούμε κάτι. Πώς είναι? Πώς είναι? Ρωτήσουμε το νεράκι.
Λοιπόν, είμαστε. Ναι, είναι μαζί με το τρέξι.
6, θα σκεφτεί. Μετά, τέλεια, και το discussion της έχεις πει περίπου αισθάνομαι ότι ήταν λιγάκι μετά εντάξει. Εν ανάγκη θα σε κάνει κάποιος, θα είναι διαδραστικό το κοινό, οπότε αν δεν αποδέχει κανένας θα προσπαθήσει να το κάνει με ύφος. Προφανώς θα με κοιτάζεις, θα είμαι κοντά εδώ, οπότε αν είναι να πω κάτι να ακούσουμε. Είναι και τα μικρόφωνα του μπορούν να πατήσετε το κουμπάκι. Πάει από τώρα.
Καλά, ναι. Στο πατάμε, δεν πες.
Ο βολοντής θα στέλνει, αλλά ενώ και σε αυτά εκεί πέρα τα στάση.
Είναι κοντό. Μπορείς να κάνεις έτσι.
ανοιχτό, μπαταρία έχει. 63%. Να το βάλω στην battery safe, όχι να κλείσει. Να κλείσει. Εντάξει.
Good afternoon, everyone, and welcome to the CAMeSM Roundtable discussion in dermatology, titled Dermatological Manifestation of Sexually Transmitted Infections. Sexually transmitted infections remain an important area of clinical practice, not only because of their infectious and public health implications, but also because they often present with visible dermatological signs. For many patients, skin and mucosal findings may be the first indication of an underlying infection, making dermatological recognition essential for timely diagnosis, appropriate treatment, partner notification, and prevention of further transmission. Today's discussion will be led by Dr. Athanasia Zampeta, consultant dermatologist, venereologist at American Medical Center, together with our student presenters, Eleni Zguanelli, Rafaelos Harilaou, Malvina Neofitou, Maria Papavasiliou, and Penelope Siru. We invite you to follow the discussion actively and reflect on the role of careful clinical examination, patient-centered communication, and interdisciplinary care in this field. Please join me in welcoming Dr. Zampeta and our student presenters.
Good afternoon. Hello, everyone. Hi. Today we will discuss a very important medical issue, especially in young adults, sexually transmitted infections. That's why we decided in this year's medical student conference to discuss this issue. Actually, today we aspire to aware all of you and because you're young adults, about the importance of getting protected and not spreading the infections. So we will start with, we will discuss the most important sexually transmitted infections. And we will start with syphilis. Okay, let's start.
So, good afternoon, guys. My name is Malvina Neofitou. I'm a fourth-year medical student, and today I'll be presenting syphilis, its clinical and dermatological perspectives. This topic is important because syphilis remains a major global health concern with increasing incidence. Syphilis is a chronic systemic sexually transmitted infection caused by Treponema pallidum, a tissue-specific spirochete. It is often called the great imitator because it can mimic many other diseases, making diagnosis difficult, and so it can progress to severe complications and even death. Transmission occurs mainly through sexual contact and from mother to fetus during pregnancy. High-risk groups include men who have sex with men, individuals with multiple sexual partners, and patients with HIV co-infection. So identifying these groups is important for screening and prevention. Globally, syphilis remains a significant burden. There are approximately 8 million new cases annually and 700,000 congenital cases worldwide. The incidence has been increasing since 2016, with serious outcomes including adverse pregnancy complications, especially in low and middle-income countries. In Europe, over 41,000 cases were reported in 2023. This represents a 13% increase from 2022 and nearly a doubling since 2014. Around 72% of cases occur in men who have sex with men, showing a consistent upward trend. As illustrated in the graph, Cyprus held the third highest position in reported syphilis cases in 2023. Syphilis progresses through three main stages: primary, secondary, and tertiary. It can also be classified as early disease within the first 2 years and late disease after 2 years. Each stage has different clinical features and levels of infectivity. So starting with primary syphilis, presents as painless as ulcer known as a chancre at the site of the infection. It typically appears about 3 weeks after exposure, and it is often associated with bilateral lymphadenopathy. This stage is highly infectious. So the images behind me show examples of chancras in different anatomical locations. Because these lesions are painless, they might go unnoticed, especially if they are internal. Secondary syphilis is the most important dermatological stage, and it is also highly infectious. It is called the great imitator because it resembles many other diseases. This stage presents with a diffuse maculopapular rash, often involving the palms and soles. Other features include mucus patches, condylomata lata, and systemic symptoms such as fever and malaise. So as you can see from the pictures behind me, the maculopapular rash on palms and soles, which is pathognomonic, and on other areas of the body. So this rash is usually non-itchy and may be subtle, so it can go unnoticed. However, lesions contain a high bacterial load, making this stage very infectious. A characteristic variant of secondary syphilis is Biet's cholerae, a ring of scale around lesions. And there's also a rare variant, which is called ulcerative syphilis or malignant syphilis, that contains severe ulceration and necrotic lesions, especially in immunocompromised patients. So why is it called a great imitator then? Secondary syphilis can mimic conditions such as lichen planus. However, differences in distribution, color, and associated symptoms help distinguish them. Also, alopecia syphilitica presents with a moth-eaten pattern of hair loss, unlike alopecia areata, which shows smooth, well-defined patches of hair loss. Condylomata lata are flat, moist, highly infectious lesions of syphilis, while condylomata acuminata, which we are going to see later, are caused by HPV and are raised and have a cauliflower-like appearance. Last but not least, tertiary syphilis occurs years after untreated infection. It is less infectious but much more severe, causing gummatous lesions and affecting organs such as the heart and the nervous system. So moving on to the diagnosis, it involves clinical recognition and laboratory testing. Non-treponemal tests such as the RPR and VDRL are used for screening, while treponemal tests confirm the diagnosis. First-line treatment is intramuscular benzathine penicillin G, and early disease requires a single dose, while late disease requires 3 doses weekly. And there's also no reported resistance to penicillin. But of course, for patients who are allergic to penicillin, they can use doxycycline or tetracycline, with an exception in pregnancy. And neurosyphilis requires a more aggressive approach, which will be intravenous treatment. So in conclusion, we have seen that syphilis is a great imitator of diseases, so test when in doubt. Early diagnosis and treatment are essential, and partner notification is also important, while recognizing dermatological features early helps prevent complications and transmission. Thank you for your attention.
So, hello everyone. My name is Eleni Zganelli, and I'm a third-year medical student at EUC. And I'm also the coordinator of this roundtable. Today, I will be presenting the human papillomavirus. So, we've just seen how infections like syphilis can present with very characteristic dermatological findings. But not all STIs behave like this. Some of them are completely silent until they're not. So, let's do a quick quiz together. Can someone please tell me what are those lesions? Those lesions are characteristic of the human papillomavirus. So, what is human papillomavirus? Human papillomavirus, or HPV, is a DNA virus that primarily affects epithelial tissues. It is the most common sexually transmitted infection worldwide, and up to 80 to 90% of sexually active individuals will get infected by this virus. It's usually asymptomatic, and depending on the HPV type, it can actually progress to cancer. So, what makes HPV particularly important clinically is that it often, and actually almost always, begins silently. Most patients have no symptoms, no pain, and no visible lesions, meaning they may carry and actually transmit the virus completely unknowingly and thus infecting other people. But over time, this silent infection can become clinically visible through dermatological lesions, such as the words Malvina mentioned. And in persistent high-risk infections, it may eventually progress to malignancy. So, HPV is not simply a world-causing virus. It's a potentially oncogenic infection that often hides before it appears. So, why HPV matters? HPV includes over 200 genotypes, with transmission occurring very easily through skin-to-skin contact. Most infections are transient, but persistent infection, particularly with high-risk types, is what leads to cancer. So, a great question is, Elena, which are the high-risk types and the low-risk types? The high-risk types are HPV 16 and 18, which cause cancer, and the low-risk types are 6 and 11, which are often associated with condylomata. So, here, in this slide, we have the clinical behavior of HPV, and we have 3 really beautiful images. So, as we can see here, the majority of infections are transient, and they are cleaned naturally by the immune system. As you can see in the middle figure, a small proportion persists over time instead of regressing. On the right figure on the screen, this persistent infection is the key problem, because persistence, not simple exposure, is what increases the risk of visible lesions and malignant transformation. So, in HPV, absence of symptoms does not mean absence of disease. Now, moving on to the most important part of these presentations, the dermatological manifestations of HPV. We have 3 characteristic images. First of all, the most characteristic one is the condyloma acuminata, which are soft papillomatous warts, flesh-colored, often coalescing into cauliflower warts. So imagine you have on your skin warts that look like tiny cauliflowers. Then we have the cutaneous warts, which are hyperkeratotic papules with a rough surface, usually appearing on the hands and your feet. And lastly, we have the flat warts, which are flat and smooth and usually appear on the face and the hands of the patient. But remember, most infections are subclinical, meaning that there are no lesions at all. So, clinically, these lesions can mimic other conditions. For example, HPV lesions can mimic the molluscum contagiosum, secondary syphilis with a very characteristic condylomata lata, and benign skin tags. So, what's the diagnosis of HPV? In dermatology, diagnosis is primarily clinical, based on lesion recognition. We can use dermoscopy when needed, and tests like HPV DNA testing or biopsy in atypical cases. Management. Management is lesion-directed. Options include cryotherapy, topical agents like imiquimod, or surgical removal. But importantly, and I want you to remember this, no treatment eradicates the virus, and which is why recurrence is very, very common. So, let's do a quick question. Up to what age can HPV vaccination be given? Yes? That's correct. The answer is up to 45 years. And I want you to listen to me right now. Most people think that HPV vaccination is limited to adolescents, in which they're wrong. But even up to the age of 45 years old, vaccination may still provide protection against high-risk HPV types not previously acquired, including in sexually active individuals. So even if you're sexually active, you can still get the vaccine. What is the standard vaccination schedule? Does anybody know? It is 0,
2 and 6 months. Do you know why? I will tell you why. The spacing between doses allows progressing immune stimulation and development of durable immunological memory. So, prevention. Prevention operates on 2 levels. First of all, vaccination and then screening. Vaccination reduces the risk of infection and malignancy, while screening allows detection of precancerous changes. And remember, screening prevents cancer, not the infection. And I want you to remember one thing from this presentation, particularly from HPV. Risk reduction includes condom use. Using a condom and protection is really, really important, but that doesn't mean that you're fully protected. HPV is a virus that transmits very, very easily through skin-to-skin contact and even with a condom. So, take-at-home message. HPV is usually silent, but clinically important. The words that we saw earlier are only the tip of the iceberg. Persistent, not infection, is what drives cancer risk, and most importantly, HPV-related cancers are totally, totally preventable. Thank you very much.
Hello everyone, my name is Penelope Siru. I'm a 5th year medical student, and today I will be presenting herpes simplex virus, also known as HSV. What is HSV? HSV is a very common viral infection. There are 2 main types. We have HSV1, which is mainly affects the oral area, and HSV2, which is mainly associated with genital tract infection. Transmission occurs through direct skin-to-skin contact, and importantly, any part of the body can be affected. HPV infection is extremely common worldwide. HSV1 is more common, is usually acquired in childhood, and affects a large proportion of population. While, on the other hand, HSV2, it is sexually transmitted and more common in sexually active individuals. Many patients remain asymptomatic but can still transmit the virus, so we need to be very cautious. A key feature of HSV is its ability to cause recurrent infection due to viral latency. Now, let's talk about the pathophysiology of the disease. The virus enters the body through a mucosal surface or damaged skin, then establishes latency into the sensory nerve ganglia, which means that the virus remains in the body but in an inactive state. Reactivation can occur later, leading to recurrent infection. Common triggers of reactivation include illness, stress, and immunosuppression. Moving on to one of the most important parts of this presentation, which is the clinical manifestation of the disease. The typical presentation of HSV include grouped vesicles on an erythromatous base, which is very important to remember. These lesions are usually painful and follow characteristic progression, from vesicles to ulcers and then crusting. Common locations that can appear in lips in HSV1 and in genital area in HSV2. Less commonly can also affect the fingers, known as herpetic whitlow, or the eye, causing herpes keratitis. As shown in this image, HSV lesions follow a typical progression. They begin with a prodrome, which is such as a tight tingling or burning sensation of the skin. They followed by vesicles, which then rupture to form ulcers and eventually crust. HSV can also appear in atypical ways. Some patients may have a mild symptom or even be asymptomatic. Instead of classic vesicles, they may present with small erosion or fissures. In immunocompromised patients, the infection can be more severe. Recurrent infections are usually more localized, shorter in duration, and often precipitated by a prodrome. In this slide, we can see the different sites where HSV can affect the body. As I mentioned before, and I want you to remember it, HSV1 affects mainly the lips, the oral area, and especially the lips, while HSV2 affects the genital area. However, it is important to remember that HSV it is not limited to these areas. It can also affect other sites. So the location depends mainly on the site of contact and transmission. In this slide, we can see different clinical presentation of HSV. The most typical presentation is grouped vesicles, as shown in all these images. In lips, as we can see, we have the herpes labialis. In the finger, we have the whitlow, the herpetic whitlow, and in the eye, the herpes keratitis. Also, in the genital area, we have the characteristic vesicles caused by HSV-2. This example shows that HSV can have different appearance depending on the location, but the underlying pattern of the vesicles is usually present. This is why it is important to recognize HSV even when it does not appear in a classic way. Diagnosis is mainly clinical, based on the characteristic appearance of the lesions. However, PCR testing is considered as the gold standard and can be used when confirmation is needed. Also, we can use viral culture, but less commonly. Now, how we are going to manage a patient with HSV? Management includes antiviral therapy, such as acyclovir or valacyclovir. These medications help to reduce duration and severity of symptoms, but they do not eliminate the virus, which remains latent in the body. Patient education is very important. Patients should avoid contact during active lesions and practice safe sexual behaviors. In case of genital HSV, it is also important to consider treating also sexual partners. Now, let's look at a clinical case for a deeper understanding of HSV. We have a 22-year-old patient, presents with painful genital vesicles, with history of burning sensation before the lesion appeared, and mild fever during the first episode. How we are going to approach such a patient? In approaching this patient, we take a focused history, including sexual history. We perform physical examination, and we consider PCR testing if we need confirmation of our diagnosis. After all this procedure, what would you suspect in this case? The most likely diagnosis is genital herpes caused by HSV-2. After all this management includes starting antiviral therapy as well as patient education regarding avoiding sexual contact during active lesion and using protection. Also, apply the same treatment plan on his or her sexual partner. From this case, we can see that the diagnosis is mainly clinical and management focuses on antiviral therapy and patient education. To sum up, HSV is a very common infection with characteristic clinical features. It presents with both primary and recurrent episodes, and early recognition is important for appropriate management. What I want you to keep from this presentation is to think of HSV in patients with painful grouped vesicles, that there might be recurrent due to viral latency, that the diagnosis is mainly clinical, something that highlights the importance of physical examination, and that the antiviral therapy improves symptoms and reduces transmission. Thank you very much.
So, good afternoon, everyone. I'm Rafaelos Hailau, a third-year medical student. We just saw herpes, where the skin often is clear clues, like painful grouped vesicles. Chlamydia is different. With chlamydia, the infection may be present even when there is nothing obvious to see. So the main idea is that a normal examination does not always mean absence of disease. Before we go further, let's start with a quick clinical check. Here we have no lesions, no symptoms. Do you think that is chlamydia possible? The answer is yes. This is the main diagnostic trap. A patient may look completely normal, but infection can still be present. Now this second image shows the opposite situation. Here we see a genital lesion with inguinal lymph node swelling. What do you think is the most likely diagnosis? The most likely diagnosis is chlamydia. specifically lymphogranuloma venereum. So from the beginning, we can see the contrast. Most cases are silent, but the invasive form can become visible. The clue here is a genital lesion followed by lymphadenopathy. Chlamydia trachomatis is the most common bacterial STI, especially in sexually active young adults. Unlike herpes, syphilis, or HPV, it usually does not produce obvious skin findings. Many patients are asymptomatic, so infection is often found only when screening is done. This is why chlamydia is such an important public health issue. It's not rare or difficult to treat, but it can be missed because patients may not know they are infected. Absence of lesions does not equal to absence of disease. This is the main dermatological point. In most cases, chlamydia has no specific skin findings. If we rely only on visible lesions, we may miss the diagnosis. This is different from infections like herpes, where vesicles can guide us, or HPV, where words may be obvious. With chlamydia, the absence of lesion is part of the clinical challenge. Chlamydia is also missed because of where it infects. It commonly affects mucosal sites such as the cervix, urethra, rectum, as you can see in the picture, and less commonly oropharynx. These areas are not always visible during a routine examination, so the skin may look completely normal while infection is still present in hidden mucosal sites. This is also why sexual history and risk assessment are important. Can asymptomatic infection still lead to complications? This is why screening matters. Even without symptoms, untreated chlamydia can ascend from the lower genital tract and cause pelvic inflammatory disease. Over time, this can lead to infertility or ectopic pregnancy. So the patient may feel well, and the examination may look normal, but the infection can still progress internally. After the silent form, these images, as you can see, show when chlamydia become more visible. Lymphogranuloma venereum may begin with a small genital lesion that is painless, temporary, and easy to miss. Later, as you can see in the second picture, it can progress to painful inguinal lymphadenopathy or buboes. So here, the important point is not just the lesion itself, but the timing and progression. A small lesion may already be gone by the time the patient presents with lymph node swelling. Another way chlamydia becomes relevant to dermatology is through reactive arthritis. Here, the skin findings are not caused by direct infection of the skin. They are immune-related findings after infection, such as cercinate balanitis and keratoderma blennorrhagica. This is important because the patient may no longer have clear genital symptoms, but the skin findings may suggest a previous infection. This slide brings everything together clinically. Chlamydia should not be excluded because there are no visible lesions. If we see a genital ulcer with inguinal lymphadenopathy, we should think about lymphogranuloma venereum. If we see cercinate balanitis or keratoderma blennorrhagica, this can point towards reactive arthritis, which may follow a previous chlamydial infection. But we should also look beyond the skin. A new partner, multiple partners, or a partner diagnosed with an STI are enough reason to test even when the examination is normal. So the decision to test is based on the whole picture: skin findings, risk factors, and clinical suspicion together. Once we decide to test, diagnosis is made by nucleic acid amplification testing. This can be done using first cut urine or a self-collected vaginal swab. These are practical options, especially because many patients have no symptoms. The important point is that testing is available and accurate. The difficult part is recognizing who should be tested, especially when there are no visible signs. Treatment is straightforward, but management is more than giving antibiotics. Doxycycline is first-line treatment. We also need partner notification and treatment, avoiding sexual contact until treatment is completed, considering gonorrhea co-infection, and retesting to detect reinfection. This is important because if partners are not treated, the patient may become reinfected and transmission continues. Now we move on to a case presentation to apply this idea clinically. A 25-year-old sexually active female has a new partner, inconsistent condom use, and no previous STI screening. She has no symptoms, no visible genital lesion, no discharge, and no pelvic pain. Based only on examination, there is nothing obvious to suggest infection. This is a kind of patient who can be missed if we depend only on symptoms or visible findings. In this case, her nucleic acid amplification test is positive for Chlamydia trachomatis. So the diagnosis was made because screening was performed, not because the infection was clinically obvious. This case summarizes a whole message of uncomplicated chlamydia. The patient may look well, but she still requires testing based on risk. Normal examination does not exclude chlamydia. To summarize, chlamydia is common, often silent, and usually not visible dermatologically. A normal examination does not exclude infection. Dermatology still matters because chlamydia can become visible through lymphogranuloma venereum or reactive arthritis. Diagnosis depends on testing, and management must include treatment, partner notification, and prevention of reinfection. And now we move from chlamydia to gonorrhea, which will be presented by my colleague Maria.
So, lastly, gonorrhea, commonly co-infecting with chlamydia, as my colleague Raffaello said, and the second most common STI on the world. So, even when chlamydia is silent, gonorrhea might be what we actually see. Hello, everybody. My name is Maria Papavasiliou. I'm a second-year medical student at European University Cyprus, and today I will talk to you about the skin manifestations in gonorrhea. I would like to thank the organizing committee of CAMeSM, our supervising professor, Dr. Zampetta, and my colleagues. So, let's start with a quick question. Skin lesions in gonorrhea are rare, but is this enough to ignore them? So, the correct answer is no, but most people would probably say yes, because we usually associate gonorrhea with genital manifestations. So, what exactly is gonorrhea? It is a preventable and curable sexually transmitted infection caused by the bacterium Neisseria gonorrhoeae, which is the microorganism you can see in the image. It can be transmitted through vaginal, oral, and anal sex, and it can also be passed from the mother to the newborn, causing ophthalmia neonatorum. It is very common, with 82 million approximately cases per year, usually among young adults. Here we can see the epidemiology of gonorrhea. In the first image, you can see the epidemiology from 2013 to 2024. During this period, there was a 321% increase at the notification rate. Please take into consideration that this increase is not only due to the uncontrolled transmission, but we also have an increase at the improved of screening initiatives, which lead to more cases being diagnosed and reported. Also, the increase was very steep during 2021. At the left image diagram, you can see that the cases were highest among men who have sex with men, but there was also a clear increase at both heterosexual males and females. Now, there is a problem. Gonorrhea is usually asymptomatic, especially in women. When symptoms do appear, they usually develop within 2 weeks after exposure. And why is this important? Because if we rely only on classical symptoms, we might miss many cases. And skin manifestations can sometimes be our first or only clue to the diagnosis. Also, if gonorrhea is left untreated, it can lead to severe complications. In females, we have pelvic inflammatory disease, ectopic pregnancy, and infertility, while in males, we have urethral strictures or infertility. At both sexes, we have an increased risk for HIV transmission. So, skin manifestations fall into 3 categories. Let's start with primary cutaneous gonorrhea. It can occur in 2 main forms. First, extragenital, which is rare, and it usually comes after cutaneous trauma. It is characterized by digital pustules, like the ones you can see at the image, abscesses, lymphangitis, and ulcer-like lesions. Second, we have genital, which is uncommon, and it doesn't come with urethral or cervical symptoms. It is characterized by lesions looking like tiny pustules, furuncle-like nodules, or shallow ulcers. Then, secondary cutaneous gonorrhea. First, we have the genitourinary infection. This is most common in males, while it's present at both. And it is characterized by urethral meatus edema, erythema, and potential phimosis due to foreskin and glands involvement. Also, there are implications at the Bartholin or Cowper's glands, as you can see at the first image. While the second one shows a penile complication, where there is also some mucus production from the urethra. Now moving to the anorectal complications. It's usually symptomatic, but when it occurs, it comes from anal intercourse and from perianal contamination. During it, we have proctitis, which starts with pruritus, then noticeable erythema, lichenification of the skin, and eventually it can lead to mucopurulent discharge. Now, about oral manifestations, they are also rare. They are characterized by small ulcers and mucosal erythema, while pharyngeal infection is also present, as you can see at the bottom left images. Next is disseminated gonococcal infection, found only in 3% of gonorrhea patients, which occurs when the bacterium spreads into the bloodstream. And it leads to two separate syndromes. The first one is tenosynovitis dermatitis polyarthralgia syndrome. During it, we have visibly skin lesions in approximately 90% of the cases. And we searched for skin lesions at the distal extremities, mainly the hands and feet. And these are usually small and painless, and at multiple stages of evolution. Also, these come from embolization of the bacterium, and they last 3 to 4 days, so they are transient. So, don't forget that sometimes skin manifestations might be the only clue, with the other symptoms being absent. And if this initial triad is left untreated, it can lead to the other syndrome, purulent arthritis syndrome, during which the skin lesions disappear and the infection will settle in the joints, mainly the one at the knees, wrists, and ankles. Patients will present with classic suppurative arthritis symptoms like pain, redness, and swelling, which lead to a decreased range of motion. It's a shift from a systematic skin and ache to a more aggressive and inflammatory phase. So, about the diagnosis, the gold standard is nucleic acid amplification testing, which is very sensitive. Other diagnosis methods include microscopy, during which we search for gram-negative diplococci inside neutrophils, as you can see in the image. Then we also have culture, which is very helpful for antimicrobial sensitivity. And lastly, as Raffaello said, we should check for co-infection with chlamydia. Now, about the treatment, our first-line treatment is 500 milligrams of ceftriaxone, which is given as an intramuscular dose. And this is usually for patients weighing less than 150 kilograms. However, when co-infection with chlamydia has not been ruled out, we also add the course of doxycycline, which is 100 milligrams, taken orally twice a day for a full of 7 days. However, a major issue, as we all know today, is antimicrobial resistance. For this reason, FDA approved in 2025 two new drugs, zoliflodacin and zepodidacin. These two, even though they are effective, they have clinical data which are limited, so they should be used when the patient has no any other options for treatment. To sum up, gonorrhea is usually symptomatic, especially in women, and actually 90% of female individuals are symptomatic, while only 10% of males. It can impact health and life quality if it's left untreated. Key diagnosis and prevention are key. And finally, skin manifestations, although rare, are crucial for early recognition, especially in disseminated gonococcal infection. So going back to the question in the beginning, no, we should definitely not ignore skin lesions in gonorrhea because they might be rare, but they might be the first or only clue that leads to the diagnosis. Thank you for your attention.
Okay. Okay, I would like to congratulate all students for their thorough research and detailed work. And please let me say a few things about these sexual transmitted infections. Until 19th century, these diseases were called venereal diseases. That's why dermatology, it's on its title as a specialty, also has the name venereology. And these diseases were very important, very common. Hundreds, thousands of people died because of these diseases because there were no treatment. With the discovery of antibiotics in the 20th century and penicillin, finally we got some serious treatment, especially for syphilis. And now we would say that nowadays we wouldn't see these infections and that they would have become obsolete. But unfortunately, because of misinformation of young population and the less and less use of condom in everyday sexual activity, we have seen an outbreak in syphilis and chlamydia. So the World Health Organization and European Academy of Dermatology and Venereology run special campaigns every year trying to let people know that there is this outbreak in the sexually transmitted infections and to help with awareness. That's why we decided, instead of discussing about a very common dermatological issue like the inflammatory diseases or acne or psoriasis, atopic dermatitis that affect many people worldwide, we decided to shed some light on the sexually transmitted infections. Thank you. And of course, if you have any questions, feel free to ask us. Thank you. Yes, please. Let's give a microphone to for everyone.
First of all, let me start by saying that the presentation was very good and a great opportunity to raise awareness about sexually transmitted diseases. I have a question. There are over 100 strains of HPV. If we do the vaccine, does it cover all of them? Or if it does some of them, which ones?
Could you please repeat your question? I didn't hear you.
Yes, I was saying that there are over 100 strains of HPV. If we do the vaccine, then we get covered for all of them or just some of them?
So, typically HPV vaccines covers the high-risk types and the low-risk types. And Gardasil 9, which is a vaccine, covers a lot of types of HPV, but not all of them.
To answer to your question, yes, we do the vaccine, but it protects us against the most oncogenic subtypes of HPV family. And Gardasil 9 protects us against the 9 most common oncogenic subtypes.
Thank you so much.
Could you repeat which are the types of HPV? Yes, of course. We have the high risk and the low risk types. The high risk types are the oncogenic ones, and they are HPV 16 and 18. And the low risk types are the ones associated with dermatological manifestations such as condylomata and R6 and 11.
Okay, now it looks as if I'm specifically for HPV because I want to say a question about that as well. It's not, I'm not trying to like bully into anything, but I was very curious to know, so you've mentioned about type 16, 18 being oncogenic. Now, for me I want to understand what makes them, I know that specific strain is like dangerous, but what makes them like what's the difference that it has with the other strains that makes them like oncogenic, like maybe molecularly? I don't know, I don't want too much detail, just like I've always had this question, what makes it so dangerous?
Yeah, very nice question. Well, actually, these subtypes cause condylomas, and as long as condylomas stay on the genital area, this persistence alters the molecular environment in the cells of the cervix, for example, in women, and for anus, penis, even the oral cavity for men. And the pharynx as well, because we can get pharynx cancer by HPV. This is how it works, but it is, of course, a lot more detailed. What usually I explain to my patients in everyday practice when they come with some condylomas, genital warts, that they shouldn't be worried that when I have genital wart, I also can get cervical cancer. It doesn't mean immediately this thing, but we should be aware and careful to, if we notice any change, to access the specialist doctor. And of course, in women, we have the pap test that can be done annually or twice every 2 years, and we can find more quickly any changes in the cells of the cervix.
Okay. Thank you very much.
You're welcome.
Does anybody else have a question?
Yes. Over there.
Thank you. Since chlamydia has no obvious genital lesions, what makes the clinicians actually test for it?
Okay, actually, this is the main clinical challenge in chlamydia. Clinicians don't test only based on what the skin looks, to say it clearly. Risk assessment is also important. For example, if someone is young, sexually active, has a new partner or multiple partners, has an inconsistent condom use, or has a partner with an STI, then screening is, I think, is more than important than just skin findings on a normal examination.
All right, thank you.
Does anybody else have a question?
I think we're fine. Okay. Thank you for your attendance today.
So in a minute, we will display a QR code. We will have it for 1 to 2 minutes. And you can scan the QR code and vote for our roundtable. Thank you.
Ναι, να βγάλεις μία όλοι μαζί. Ψηφίστε καλά, παιδιά. Ψηφίσουμε όλοι, είναι τέλειο. Και εγώ ψηφίζω, μάλιστα. Ήταν πολύ καλή αυτή η παρουσίαση και μπράβο. Μπράβο σας βασικά. Μπράβο, σας. Πολύ καλή, μπράβο. Ήσασταν όλοι πάρα πολύ.
Guys, please, whoever's going to stay for the next roundtable, we need you to exit and enter again so we can scan you. I'm sorry for this, but it has to happen. Thank you.
Ελάτε να βγούμε μια ομαδική φωτογραφία. Ελάτε, παιδιά, να βγούμε μια ομαδική φωτογραφία. Ελάτε πιο κοντά, πιο κοντά. Να είμαστε έτσι όλοι μαζί. Έτσι, έτσι. Α, και μία, ελάτε και μία. Ναι. Όλοι μαζί.
Ραφαέλ, να σε βάλουμε στη μέση που Βλέπετε, είμαστε πάρα πολύ καλοί.
Πολύ αναλυτικά όλα. Πολύ αναλυτικά.
Αλλά ευχαριστούμε πάρα πολύ.
Μπράβο, και αυτές τις ρομπότες πάρα πολύ καλά.
Ελένη, μου κλείνεις το κινητό μου μία. Ευχαριστώ, μωρό. Ναι, έρχομαι. Ναι. Πινελόπη μου, να πάρεις εδώ πέρα τα πράγματά σου. Δεν είναι δικό μου αυτό. Της Μαρίας είναι. Μπορεί, έλα.
Just in order?
I think so.
Are the professors sitting up here?
10 people.
Oh yeah, there were 10 people. Okay. Maybe a bit back a bit.
We're gonna be a bit cut.
It's fine. 10?
Okay. Don't you do anything?
Okay.
So, makes sense. You told us to sit downstairs. Downstairs.
Let's go down. Change of plans. Let's go down, make a move us up.
We are 10 people.
Hey guys, everybody make sure you have scanned for voting the dermatology.
environmental health are deeply interconnected. It challenges us to think beyond individual diseases or isolated organ systems, and instead consider how wider biological, environmental, and social factors shape health and disease. This roundtable was developed with the valuable contribution and guidance of Dr. Sofia Themistokleous, forensic scientist, Dr. Vasiliki Gretzi, professor of biomedical sciences, and Dr. Andreas Yalouris, assistant professor of biochemistry. Our student presenters for this session are Jessica Shehata, Lydia Katanaki, Despina Panaghi, Athanasios Kouros Koutsoumbas, Anna Andreu, Margot Kourkouiotis, Marilena Yandri, and Fayo Idou. We invite you to follow the discussion with an open mind and reflect on how future healthcare professionals can better understand disease through the connections between people, animals, the environment, and society. Please join me in welcoming the academic leads present today and our student presenters.
Hello everyone, I'm going to be starting this presentation. Move this around. So, I'm Athanasios Koutsoumbas, I'm a third-year medical student here at EUC, and I'm going to be talking to you about One Health, its challenges, its future, and also what's going on around the world. First of all, we have to ask the question, why did One Health become a global priority? Well, that's fact for different interconnected factors. First of all, globalization. This allowed the disease spreading to be very fast. Climate change alters ecosystems and expands disease vectors. Urbanization, it increases the contact between humans and animals. And AMR, where microorganisms evolved to resist different drugs in order to not die. So AMR, antimicrobial resistance, it increases because we are misusing antibiotics. Now let's go around the world. Not in 80 days like the book says, but yeah. Let's start with the Western world, Europe and North America. One Health is highly developed. We have very well-established surveillance networks and regulatory frameworks. The main focus is on antimicrobial resistance and food safety, particularly in regulating antibiotic use in healthcare and agriculture. However, although we have these very advanced systems, AMR still remains a problem and a challenge, which shows that we need continuous coordination and global collaboration. South America, especially, let's say, in the grand forest in the Amazon, we have higher biodiversity, and that increases the risk of zoonotic diseases. Deforestation and human expansion bring humans into closer contact with wildlife, increasing exposure to novel pathogens. So the challenge that we have here is to balance economic development with environmental protection. Now to the continent of Africa. The focus of One Health is mainly on infectious and zoonotic diseases. I think all of us have heard of Ebola, among other diseases. Frequent outbreaks highlight the close link between human and animal health. However, a major challenge we have here is the limited healthcare funding. We have limited infrastructure, which raises also a problem about inequality. On to Asia, where I believe all of us know that the main focus here is the very high population density, as well as the contact between humans and animals. That allows the rapid disease transmission. All of us have seen the live animal markets in the internet, and we have seen that in this region, one local infection can become a global pandemic. We all lived COVID-19. This highlights the importance of early detection and international coordination. A big part in One Health play global organizations. Let's say the WHO, the World Health Organization, focused on human health. The Food and Agriculture Organization on food and agriculture. The World Organization for Animal Health, of course, on animals. These work together by sharing data and coordinating global responses. Now, what are some challenges we have? What challenges does One Health have? Well, we have made a lot of progress over the years and the decades, but there are several factors that limit the implementation of One Health. Funding remains pretty limited, especially in low-income countries. Communication between human, animal, and environmental sectors sometimes is pretty poor. The elephant in the room, political barriers. Countries from different continents, different ideologies refuse to work with each other. And overall, there's significant inequality in resources between the nations. These create problems when it comes to One Health. Now on to the future. What should we be doing? Well, first of all, we need stronger global collaboration. We need to be working together. We need faster identification and response to outbreaks. Early detection is key here in order to combat global threats. And in addition, we need technology. We need AI, which is the future. We can use AI to monitor the disease patterns in order to identify the disease early and fight it effectively. All of these approaches can significantly improve global health security. Now, to wrap this whole thing up, One Health highlights how human, animal, and environmental health are inseparable. Although its application varies globally, the need for coordinated approach remains universal. We need to strengthen the connections to improve global health and to prevent future global threats. We don't need to be working in silos. We need to work together as one big family, as one Earth. Now I gave you the basics. I think you understood pretty well. But there's something else that's pretty important that we need to talk about, and that is the microbiome. And I think, Jessica, you can take over.
Thank you so much. Now I'd like to continue what is microbiome and how this dysbiosis of microbiome can affect us. We always think of ourselves as purely human, but in reality, we function more like an ecosystem. Trillions of microorganisms are on our body, constantly interact with our cells. These microbiomes are not just passive inhabitants, they actively influence health, metabolism, and immune system. If we talk about what is exactly microbiome, microbiome refers to the community of microorganisms, including bacteria, fungi, viruses, along with genetic materials. These are found in multiple sites, such as gut, skin, oral cavity, and lungs. Importantly, the microbiomes exist in a dynamic equilibrium. It's not static, but constantly changing in response to internal and external factors. Microbiome works in a dynamic process, as I mentioned. External inputs such as diet and environment, antibiotics first. These microbiomes interact with those host metabolism, immune system, and protective mechanism, lead to physiological effects. When this side is balanced, it maintains health. But when it's disrupted, it results in dysbiosis and diseases. I would like to focus more on what is metabolic mechanism. One key happens in gut fermented dietary fiber that we cannot digest. Short-chain fatty acids. These molecules serve as an energy source of colon cells and play a role in regulatory glucose metabolism, insulin sensitivity, and even appetite. When this system is disrupted, it can contribute in metabolic disorders such as obesity and insulin resistance. Microbiome is also crucial in immune regulation. It interacts with immune structure in the gut and gut-associated lymphatic tissue, helping the immune system distinguish between harmful and harmless tissues. It promotes immune tolerance through mechanisms it is lost, it can lead to immune dysregulation, contributing to autoimmune diseases and allergies. Now, it's perfectly fine, but if something goes wrong, when dysbiosis happens, there is an imbalance with those microbiomes. This includes a loss of microbial diversity, reduction of beneficial bacteria, and overgrowth of opportunistic organisms. It can be caused by factors such as antibiotics, which are non-active sensitivity, as well as dietary changes and environmental influence. These disruptions lead to loss of colonization, resistance, and immune imbalance. As a result of these dysbiosis, it can affect a lot of things. These include infections such as C. diff infection, as well as metabolic disorders like obesity and type 2. It can also contribute to immune-related diseases, including autoimmune conditions and allergies. This wide-ranging effect can occur because the microbiome interacts systemically with the body. Importantly, microbiome is not isolated. It's shaped by external factors. Human, diet, environmental exposures, and exposure can affect that. These highlight that human health is deeply interconnected with animal, and antibodies can affect that, making the microbiome a direct interaction and a good framework for One Health. Now, when the microbiome is disrupted, it affects no limited in one-to-one system, but the gut microbiome can also be affected, as well as the oral cavity and dentals. This demonstrates that microbial imbalance can manifest across multiple organ systems. And now we'll go more into details with Anna and with the rest of my team to continue how it can affect other systems. Thank you.
So now let's continue with endocrine health. I will be talking specifically for type 2 diabetes. So type 2 diabetes is also known as adult onset diabetes or type 2 diabetes mellitus, and it is considered a chronic metabolic disorder. It is characterized by insulin resistance, a condition in which the body cells do not respond properly to insulin and glucose is not taken up efficiently from the blood. As a result, the pancreas produces more insulin to compensate, and over time this leads to hyperglycemia. The symptoms and signs of type 2 diabetes some common symptoms and signs of type 2 diabetes is frequent urination, increased thirst, fatigue, increased hunger, rapid weight loss, blurred vision, slow healing, and tingling numbness. An important thing to know is that the symptoms can appear slowly, so many people that have the disease don't know it for many years until they are diagnosed. Type 2 diabetes is a multifactorial disease, and it is caused by a combination of genetic, lifestyle, and environmental factors that all work together to disrupt normal glucose regulation. Genetic factors include family history, lifestyle factors include unhealthy diet, physical inactivity, and obesity, and environmental factors include urbanization and obesogenic environments. These factors interact with each other and they develop type 2 diabetes mellitus. Another important factor that is receiving a lot of attention is the gut microbiome. It plays a key role in metabolism, insulin sensitivity, and inflammation, and its imbalance is linked to insulin resistance and obesity. It is also influenced by diet, environment, and antibiotics, and it acts as a link between environmental and human health. Now, this is why One Health concept is really important. The One Health concept recognizes that human health is not isolated, but connected to the environment and animal health. Diet, lifestyle, and environmental exposures all interact together and influence disease development. In our case of type 2 diabetes, this approach helps us understand how modern lifestyles, food systems, and even microbiome contribute to the disease. Therefore, prevention requires a multidisciplinary strategy and not just medical treatment. Nowadays, type 2 diabetes affects millions of people worldwide. As you can see the graphs, it's higher rates in urban populations and low and middle income countries. Today, it is a major public health concern, and it is associated with rising obesity rates, as 4 in 5 people that are suffering from type 2 diabetes are also affected by obesity. A really nice example of type 2 diabetes is in the Middle East. Because of the rapid economic growth, the lifestyle changed. It shifted from traditional diets to fast food and sugary drinks. And in addition, hot climate caused reduced outdoor physical activity and saw high rates of obesity. As a result, they had an increased prevalence of type 2 diabetes. So now, this is why One Health matters. Diabetes, as I have previously said, is multifactorial and it cannot be addressed by medicine alone. It requires public health policies, environmental changes, and lifestyle interventions. The prevention strategies include healthy diet promotion, meaning to eat in a balanced diet, physical activity encouragement, sustainable food systems, and early screening. If the disease is detected early, we will take control early and we will prevent complications. So now some things that are important to remember. Type 2 diabetes mellitus is a multifactorial disease. It is influenced by genetic factors, lifestyle choices, and environmental conditions. And the One Health approach is essential. Prevention requires lifestyle changes and public health strategies. And to summarize, to have better outcomes, we have to follow a comprehensive approach. Now my colleague will continue with female reproductive health.
Hi, everyone. Okay, so I'll stay in the endocrine aspect of this presentation, but I'll now focus on the female reproductive health perspective within One Health. So I chose this topic because, let's say that environmental pollution has increased with industrialization and urbanization, and the reproductive system is one of the most hormone-sensitive systems within our body. And therefore, even subtle disruptions in hormonal balance can affect ovulation, implantation, and fertility, which makes it a very interesting biomarker of what's going on globally. In fact, when we think about fertility, how often do we think about environmental exposure as a cause? Well, almost never. So, unfortunately, it has been shown that environmental pollutants, especially endocrine disruptors, but also heavy metals and air pollution, affect fertility. Now, this recent systematic review found consistent associations between environmental contaminants, such as heavy metals, bisphenols, phthalates, organic pollutants, and female infertility. These chemicals, such as BPAs, phthalates, PFAs, pesticides, and parabens, are chemicals that we are, fun fact, exposed to every day. Plastics, food packaging, air pollution, perfumes, soaps, cosmetics, personal care, pharmaceutical products, textiles. We found them everywhere. And these chemicals accumulate in soil, water, enter the food chain, affect wildlife, livestock, and humans. From a young age, these chemicals can mimic estrogen and thus modulate its effect. They can suppress androgen, they can alter the HPO axis, and studies are now showing associations with anovulation, reduced ovarian reserve, premature ovarian insufficiency, irregular menstrual cycles, PCOS, early menopause, and to add the cherry on the cake, increased risk of infertility. And to add to that, in addition to affecting the female reproductive health, this meta-analysis found that maternal exposure to endocrine disruptive chemicals is significantly associated with miscarriage and preterm birth, and it affects the neonate as well. In fact, it showed that it's linked to small for gestational age infants and low birth weight. And this meta-analysis found that certain chemicals, such as phthalates and parabens, were significantly associated with congenital anomalies, and more precisely, urogenital anomalies. And if you want to know how all of that happens and how maternal exposure can impact the fetus, I invite you to type environmental pollution and pregnancy, Or fetal growth on the internet, and you'll see studies about how certain pollutants can affect the morphology of a mouse's placenta, or how they can enter the bloodstream and thus be exchanged with the fetus. It's all very interesting, but it's alarming. However, what's emerging now is a more complex pathway. Environmental pollutants don't just act directly on hormones. They also alter the microbiome. And this creates now a dual mechanism with a direct endocrine disruption that I mentioned before, and now this indirect hormonal effect via microbiome changes. Now, the microbiome plays a key role in ovulation, fertilization, implantation, and what happens if we disrupt that? Well, we have a problem, and this is what we call dysbiosis. And now dysbiosis has been linked to many things, and just to cite a few, it has been linked to bacterial vaginosis, chronic endometritis, PCOS, endometriosis, altered ovulation, blah, 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 a lot of things. And overall, it doesn't take a genius to understand that all of that reduces the chances of getting pregnant. Now, I'm not going to go into the details of the mechanisms of how dysbiosis leads to these pathologies, because we'll still be here tomorrow. But what I will do is briefly explain how we go from endocrine disruptors to dysbiosis. And I will focus on the estrobolome, which basically represents the regulation of estrogen by the gut microbiota. So what I want you to remember is this pathway. So endocrine disruptors alter the host's physiology, which in turn alter the gut habitat, which causes a microbiome shift and affects reproductive health. If you remember, endocrine disruptors affect estrogen, androgens, and the HPO axis via the direct pathway. But now this matters for the gut, because sex hormones are not just reproductive hormones. They're also gut physiology regulators. So when endocrine disruptors alter hormone signaling, we are reprogramming the gut physiology. And this is important because this changes the physical habitat of bacteria, which shifts the microbiome composition towards inflammation-tolerant species. And this shift, this imbalance, is what we call dysbiosis. And therefore, the one thing that I want to emphasize is that this microbiome, or should I say these microbiomes, are, like Jessica mentioned, influenced by environmental exposures and pollutants, so human-animal microbial exchange, antibiotics, agriculture. Therefore, as we've seen, fertility is not just biological, but it's also ecological. And as a conclusion, to make this fit into the One Health perspective, pollution, endocrine disruptive chemicals, heavy metals, and more affect both hormones and microbiome. Antibiotics used in livestock alter the human microbiome via the food chain microbiome transfer. General antibiotics disrupt both the gut and vaginal microbiota. And all of that, through this dual pathway, is linked to increased dysbiosis and reduced fertility. And the one thing that is worth mentioning, especially in our roundtable, is that humans are animals. And therefore, what affects humans is likely to affect animals as well. And now I'll pass on the floor to my colleague who's going to present cancer through the One Health lens.
So thank you, Marco. Hi, everyone. My name is Despina Panagi. I'm a third-year med student, and today we're gonna see together cancer through the One Health lens. But before I start, a quick question. When we think about cancer, the first thing that comes to mind is genetics, right? Well, actually, cancer is a complex multifactorial disease, and although it's traditionally known to involve just genetic mutations, we now know that it also involves the environmental factors, infectious agents, and the microbiome. The environment includes also factors like tobacco smoke or pollutants that can cause DNA damage, and other infections that can lead to long-term changes that promote cancer. So cancer does not develop in isolation. It's a continuous interaction between different factors, and here we see a diagram that shows human, animals, and the environment. Humans are exposed every day to risks through their lifestyle and working environment, animals are contributed mainly in research by helping us understand disease patterns across species, and the environment plays a major role in pollution, climate change, and contamination. Here we can see a figure showing the global variation in cancer, and we can see that in high-income countries, we have more incidence rates of breast cancer, colorectal cancer, and lung cancer. These types of cancer are strongly associated with lifestyle factors like obesity or diet. And then we can see that also in low-income countries, there is a high prevalence of liver, cervical cancer, and stomach cancer, which is associated to low healthcare access, limited healthcare access, and infections. So cancer is not just biology, but it is influenced by infections rates and the environment and the lifestyle each person has. Here we can see the drivers and risk factors. They're actually even more than that, and even more than what the picture shows, but we're going to focus on environmental, infectious, and lifestyle. Starting with environmental, we have air pollution, we have environmental, including air pollution, pesticides, and industrial chemicals. Infectious factors that include human papillomavirus that can cause cervical cancer, hepatitis B and C that cause liver cancer, and Helicobacter pylori that causes gastric cancer. And in lifestyle, we have smoking, alcohol, and diet that further increase the risk for cancer. Moving on to the microbiome, as we already mentioned, this is the main topic of our presentation. The microbiota regulates immunity and inflammation, and any disturbance in this balance that may be caused by the diet, antibiotics, or environment is what is called dysbiosis and can probably lead to cancer. Animals play an important role as well. As they have infection-related cancers like HPV, as we already mentioned, and hepatitis viruses. And the role of animals is really important, as we said, because they act as reservoirs and research models. Therefore, we have cross-species prevalence. Now, moving on to environmental factors, which are environmental exposures are major contributors to cancer risk. Starting with air pollution, that is strongly associated to lung cancer, while contaminated water and soil can introduce carcinogens in the food chain. For example, arsenic exposure in drinking water has been associated with certain cancers like skin cancers, bladder cancers, and lung cancers. And these exposures affect both humans and wildlife, showing that the risk is shared across ecosystems. Now, for the health consequences, the consequences of cancer extend beyond humans. We can see that in humans we have increased cancer burden. In animals, there is increased tumor rates that can act as early warning signs for environmental hazards. And in ecosystem, there is biodiversity loss observed, as well as bioaccumulation. So, what are the solutions? One Health suggests the following solutions: collaboration between medicine, veterinary science, and environmental science through the strategies of vaccination, pollution reduction, and safer agriculture practices. So the One Health intervention suggests an integrated approach that includes environmental regulation, infection control, and lifestyle intervention, and importantly, microbiome protection. So, as a key take-at-home message from this presentation, I want you to know that cancer is not only genetic, It's a One Health issue shaped by environmental, infectious, and microbiome interactions across humans, animals, and ecosystems. Now, my colleague Lydia will take on with oral health.
So, in addition to cancer, oral health is also a significant component of the concept of One Health. Although, is it a missing part of this concept? Oral health is a fundamental component of overall health, as oral cavity represents a crucial interface between host and environment. The oral microbiome contributes to physiological homeostasis, but despite its importance, oral health remains underrepresented in One Health concept. To understand why this matters, we first need to look at the oral cavity itself. The oral cavity is the primary entry point for nutrients, airborne particles, and microorganisms. It is continuously exposed to both exogenous and endogenous factors. It has also protective mechanisms including salivary antimicrobial peptides and enzymatic activity, stratified squamous oral epithelial barrier, as well as innate and adaptive immune responses. In this way, it maintains host and microbial equilibrium under physiological conditions. This balance is controlled by the oral microbiome. The oral microbiome is a highly diverse, site-specific microbial community consisting of approximately 700 species. As we said before, under physiological conditions, it maintains homeostasis. Some of its functional roles are the colonization resistance against pathogens, the modulation of innate and adaptive immunity, and the contribution to metabolic and inflammatory regulation. However, this balance is not always maintained. Disruption of the oral microbiome, also called dysbiosis, refers to disruption of microbial composition and function. It results in loss of microbial diversity and stability, with a lot of contributing factors like high fermentable carbohydrate intake, inadequate oral hygiene, antibiotic exposure, and environmental and behavioral determinants. And this disruption has direct consequences. So, what are the consequences of oral microbial dysbiosis? Dysbiosis is associated with the development of oral diseases like dental caries and periodontal disease. These conditions are characterized by persistent local inflammation, increased permeability of oral tissues, as well as alteration of host immune responses. But the effects are not limited to the oral cavity. There are a lot of systemic implications of the oral microbiome. Oral cavity functions as a reservoir of microorganisms that can spread through the bloodstream or via the oral-gut microbial interactions. Therefore, oral dysbiosis contributes to systemic inflammatory burden and reflects host-environment interaction. This highlights why oral health is relevant within the One Health concept. Oral health is shaped by common determinants of health, like environmental exposure such as diet and pollutants, behavioral factors like oral hygiene practices, and socioeconomic conditions. This corresponds to the common risk factor approach of public health. Also, it reflects interaction between environmental and systemic health determinants, while it demonstrates the interconnected nature of oral health within One Health principles. Despite this, oral health is still often overlooked. The main question is why oral health is underrepresented, and there is a lot of reason for this. First of all, historically, dentistry was separated from general medicine. Additionally, the focus of One Health is on zoonotic and emerging infectious diseases, while oral diseases were often perceived as non-life-threatening. Also, there is limited integration in public health policies and surveillance systems, along with inequalities in access to oral health care globally. Together, these factors contribute to its underrepresentation. So, Marilena will explain it more extensively.
And now we will continue with the connection of oral health to overall health. Oral health is actually not isolated, but has a strong relationship with the entire body. Oral cavity acts as a mirror and a gateway to many bacteria that affect actually our whole body. Under healthy conditions, oral cavity has a complex ecosystem that consists of bacteria, fungi, and viruses. All these, under health conditions, they can function normally.
Although when imbalance happens, like Lydia said before, we have dysbiosis. Everybody would ask, how is oral health and systemic health connected? The answer is chronic inflammation. Oral health can affect many systems in our body, and especially cardiovascular systems. Oral bacteria in the mouth can contribute to endothelial dysfunction, the early stage of atherosclerosis, and those can lead to an increased risk of coronary artery disease, stroke, and heart failure. In addition, there is an established relationship between diabetes and oral health. Actually, this relationship is bidirectional. Diabetes can alter oral microbiome and can make immune response more weakened. On the other hand, periodontal disease can worsen glycemic control and can make the diabetes harder for us to manage. Next, looking at the pregnancy, periodontal disease is actually linked to preterm birth and low birth weight, while respiration, and more specifically the bacteria that are in our mouth, can cause poor oral hygiene, and this bacteria can enter our lungs during a procedure called aspiration, and can be a major cause of aspiration pneumonia, especially for those patients who are hospitalized. Next, moving to the next slide, we focus on health inequalities and ethics. The key question here is, if oral health is so important to overall health, why do so many people still lack access to basic dental care? Despite the strong evidence linking oral health to systemic diseases, access to dental care remains actually unequal across populations. The most affected groups are the low-income communities, the rural populations, and the marginalized groups due to economical regions, due to lack of infrastructures and educational purposes. And those can lead to a higher prevalence of untreated oral diseases. When it comes to the consequences of the inequalities, we have increased burden of preventable oral diseases, worsening of systemic health outcomes, and reinforcement of existing health disparities. From an ethical perspective, there is strong evidence that oral health should not be excluded from general healthcare system, because it can widen the gap between those who can pay and those who cannot. For many people, oral healthcare is seen as a luxury rather than a fundamental component of healthcare. Finally, we should include oral health in One Health concept because it reflects interactions between diet, environment, and systemic conditions. Recognizing all these inequalities, we have some recommendations, like integrating oral health into primary health care. Also, we can spread awareness about prevention and education. We can also improve access to dental care services so that it can be affordable to everyone. And finally, we can encourage collaboration between both medical and dentistry fields. So now my colleague Feyo will continue.
So, hello everyone, I'm Fayo, and I'm going to be speaking about defending and utilizing the microbiome. So we're going to talk about the attacks and defenses for gut microbiome health, and an example of how to harness the microbiome for a disease treatment. So the first attack for microbiome health is poor nutrition. So the Western diet, which we can see in this picture, is also called the chronic disease pyramid, is characterized by prepackaged foods, sweets, fried foods, so just simply a bad diet. So, and as we can see in this picture, it increases dysbiosis, which we've spoken about with the other presenters. So what this causes is dysbiosis. The main consequence is dysbiosis. So carbohydrates in excess does increase fermentation, disrupting the intestinal homeostasis. Fatty acids in excess increases the intestinal absorbing capacities. Sodium in excess decreases the good bacteria in your gut. And saturated and trans fats in excess reduces the diversity that we see in the microbiome and increases the bad bacteria for your gut. So how do we defend against poor nutrition? So improved nutrition. Why is this important? So suboptimal diets are defined as high sodium and low fruits and low grains. In 2017, suboptimal diets actually caused 11 million deaths, which is 22% of all adult deaths. And in 2021, it accounted for 7.2 million. By 2030, healthy diets could prevent 11.1 million and also decrease premature mortality by 19%. So, which diet is the best? So, the Mediterranean diet is chalked up to be the most beneficial and the most balanced diet. It decreases the risk for heart disease, and it lowers risk factors. So, it decreases cholesterol and also high blood pressure. So, it's eating unsaturated fats instead of saturated and trans fats, and also more vegetables. So apart from a diet, increasing probiotics, prebiotics as well, which is from yogurts and also just from supplements. So another more innovative way to improve nutrition is actually personalized nutrition. So has anybody heard of personalized medicine? Show of hands, maybe? Okay, last two. Has anyone heard of personalized nutrition? Okay, so personalized medicine is using your individual genes to tailor, like it determines your predispositions. So it will determine what diseases you're more likely to develop and how to tailor treatments to you. So personalized nutrition is very similar, but it focuses on your diet. So the first thing is avoiding foods that you are intolerant to. So a good example is, for example, lactose intolerant people. Although they're notorious for not staying away from food with lactose, that is an example of personalized nutrition. Another example is metabolic variability. So foods that might cause dysbiosis in your gut, personalized nutrition would steer you away from it. So where does One Health come into this? Firstly, I want to talk about the sustainability of the Mediterranean diet. So unfortunately, the Mediterranean diet is inherently exclusive. It only includes Italy and southern France. So it excludes other regions in the Mediterranean, such as West Asian countries like Syria and Turkey, Eastern European countries like Croatia, and other North African countries in Morocco and Tunisia. So where One Health comes in is it's important that the global diet is encouraged to have more fiber. So from whichever country you're from, just having a diet that embraces the foods of that region but increases the fiber of that diet. So also gut microbial health for livestock. As our presenters have said, it's really important that, it's really important that animal health is considered as well. So we need to also think about what diet are we giving livestock and what diet are we giving the animals on Earth. So lastly, cross-sector collaboration. This really just stresses that nutritionists, livestock farmers, the government as well, to encourage homegrown food, to encourage diets, and also food-based dietary guidelines that continue to emphasize how important it is to eat more fiber and eat in a more balanced diet. So the second attack is an overuse of antibiotics. Firstly, the Hughes study, it is behind that picture, but I don't think you can see. The Hughes study showed that 1 in 3 people in the world actually use antibiotics without a prescription, which is really bad. And in England, it was shown that 20% of antibiotics prescribed were inappropriate. And this image, which we can see, actually shows that Cyprus is the highest for antibiotic consumption, which is not very good. Just to explain it a bit further, the smaller bar that we see at the bottom, those are called watch antibiotics. So those are access antibiotics. So those are the antibiotics that we're supposed to go to first. And the bar that we see on top is actually the watch antibiotics, and these are the ones that are worse for antimicrobial resistance. So as we can see, Cyprus and Greece are actually first in this. So it just shows that these antibiotics, which cause more AMR potential, are more sought after in Cyprus, which is not good. So the main antibiotic is actually clindamycin, which causes dysbiosis and also C. diff infections. So how do we defend against overuse of antibiotics? So antimicrobial stewardship and also fecal microbial transplantation. So we'll talk about both. So firstly, antimicrobial stewardship. This involves looking at guidelines that provide concise, evidence-based guidance on how to prescribe antibiotics. Secondly, as we see, it must have cross-sector collaboration and using nudge-based approaches. So I'll just explain that. That's going into hospitals and basically scrutinizing GPs and saying 80% or a certain percentage of hospitals prescribed less prescriptions than you. And in 2016, this actually showed a decrease in 3% of antibiotics. So interventions like this are really important to decrease antimicrobial consumption and increase stewardship worldwide. So FMT it sounds very unappealing, but it actually has a cure rate of 95% for C. difficile. So I'll just explain it. That's putting someone else's, it does sound gross, it's putting somebody else's feces in someone who's infected with this. And it has shown that it is the best option. But again, there's issues with accessibility. So expanding donor banks, a lot of people in lower resource communities won't have access to this. And also safety, resistant strains can still spread. And if we're thinking from a global perspective, then it can spread globally. And like we've said, animal health is just as important. So investigation is needed to use FMT for animals. But FMT should be used as a last resort. If we increase the demand for FMT, then we're basically agreeing that we've had too many antibiotics and antimicrobial stewardship has failed. So it is innovative, but it should be used as a last resort. So the last bit of my part is how to harness the microbiome. So as we've heard, there's a lot of conditions that are multifactorial, and the microbiome is very important in treating these diseases. So this is an example of how the microbiome can be used for cancer therapy. So using prebiotics like we talked about and using personalized nutrition actually increases the efficacy of immunotherapy for cancer. And if this is used for other conditions like rheumatoid arthritis, it can create a more personalized treatment plan for people struggling with the condition. So microbial health interventions need to have a One Health approach, and it needs to support human, animal, and environmental health through cross-sector collaboration. And the microbiome is our second genome. The microbiome actually has 150 times more genes than our actual genome, so it's really important that research starts to harness it for more personalized treatments to transform patient care. So that concludes our presentation. Just to conclude, One Health does emphasize that health is interconnected, and the microbiome is one of the keys to getting that overall balance. So these diseases are multifactorial, like we spoke about with type 2 diabetes, endocrine health, and oral health. All of this is multifactorial. Environment, lifestyle, and genetics all contribute, as well as the systems in the body. So like we said, oral health needing more emphasis in the One Health perspective. And it does need a holistic approach. So our main conclusion again is One Health is essential for improving global health. And that concludes our presentation. Thank you. So,
Perfect. Very well done, guys. All right. Do we have any questions from the crowd? Anybody?
I have one.
Go ahead.
Okay. So, hi, guys. Thank you for inviting us. It was a very nice session, very interesting. And we had 8 different presentations with 8 different styles, 8 different perspectives, and all of them, in a very nice manner, explained to us why One Health is important. All right. So my question is, you are clinicians or doctors to be, right? Why do you care? Like, what's the ultimate? If you had to summarize that in one sentence, like, why would you say you came here, you listened to all this work? They have done a lot of work to make these presentations, to tell us how One Health is important. Have they persuaded us? Why is it important? Danai. Fayo.
Hi.
Right?
Hi. I really liked your part, especially how you showed this innovative way of not using antibiotics and the fecal microbiome treatment. And I feel like having the opportunity to see these things, it's a very nice opportunity for us in the future to use these innovative ways. And also ethics is a very important thing to have as a doctor. And I think that nowadays lots of doctors don't have it. So let's hope our generation is the one that is ethical. Anyway, I'm yapping, so.
Okay, thank you, Danai. Anything else? Like, I would think that you are all going to face a patient at some point, right? And this patient is not an isolated unit, and it's not an isolated organ you are looking at. You may be a specialist of cardiovascular, I don't know, a cardiologist, but you're not looking at a heart. You are looking at George, Anna, Maria, who are, have many organs, many systems, right? They interact with many different environments. They come from a different place of the world. They may have a cat, a dog, a fish. I don't know what they have. And you have to take all of this into account. So that's the key point, and you summarized very well every aspect of it. We just need to, every time you have a patient in front of you, you just need to remember this, right? And ask the right question, like all the things you mentioned. Okay, just a general thing.
Very good.
If we have something more specific.
Yeah. All right, very good. So, as Dr. Grezzi very correctly said, you guys need to take this into account, especially pets, very important. Every patient you see, especially if you're going to be pulmonologists, please make sure you ask your patients if they have any pets. There's a lot of diseases, especially disorders, that come from cats, unfortunately. All right, so make sure you guys ask these questions. Okay, let's ask a few questions to our board, and of course, feel free to add to it as well.
Any questions you would like to ask? Something that you found?
No? Where's the microphone?
Asking so much about it.
But
ask.
It was something about implanting it into the stomach, I think.
You mean the fecal?
Yes, I just have the question of, isn't that a high risk for sepsis or something? I mean, it's not the patients. I don't know, I'm just asking.
So,
that's why she said it's not that, it's unappealing.
Yeah, it is. It doesn't sound really nice. So that's why they screen before it. So they do test. They make people basically poo in like samples. They take people's samples, but then they do like heavily screen it, and they do really test it. I think they even sterilize it. So one method is just taking the feces as it is, and it's put in liquid and then put up the patient's back passage, basically. So it does sound gross, but it is a really good way to solve C. difficile infections. I didn't really mention it, but C. diff is actually really dangerous in healthcare because it's very resistant. So that's when antibiotics might not work. So FMT is a really good way. Obviously, it doesn't sound nice, but it is a different way to solve C. diff and other resistant infections.
And there are a lot of ethical concerns about using this type of treatment still in many countries. So,
no, that's fine. Thank you for the question.
Anyone else would like to ask something? Okay. All right. Would you like to ask the students something specific?
Okay. I ask in general, and you're free to answer. Okay. We're free to discuss. Okay. So Athanasios. Athanasios. He mentioned AI, which is very. I mean, we all use it. It's in our lives every day. So how is it going to affect us in a one health perspective? You use you're loud, but use it.
1, 2, 1, 2.
I think AI, the most like effective use that we can have it with it, is that we can use AI to predict disease patterns.
Okay, so the patient comes and you
now
say,
that's different. We say One Health
I'll
now.
use the ChatGPT
Okay.
to tell you.
That is different. Now when it comes to a patient,
Okay.
of course, a doctor should never rely on ChatGPT or a Gemini or something else
Okay.
to use to
You
prescribe
know,
or
the patient will though. The patient will have a diagnosis made by the AI and come to you. How do you deal with that?
I think first of all, we have to teach the people, let's say with education, that AI cannot always provide the correct solution. That we have to teach the populace that AI can make mistakes. And when it comes to medical matters, when it comes to stuff that decides whether you live or not, let's say, I think we shouldn't only rely on AI. We have to rely on entrusted individuals that know, that study it, that have done their work, and we shouldn't just blindly accept AI. I think educating the people of what AI is and what it does, I think you can show them pretty well how they can use it.
Excellent, thank you. All right, I
Thank
have
you.
a question. It is on Anna's part, but of course, anybody feel free to answer. It's not necessarily for Anna. So, there are a few discussions going on in public health regarding making policy changes for children and obesity, especially in some countries. Could you guys maybe share some ideas of what changes we can make to actually prevent having diabetes type 2 occurring in children? Because the numbers seem to be going up year by year, and that is actually very worrying. So are there any policies you may have in mind that maybe we can put forward to try and help with this situation? Think maybe schools every day? Yes. Very good, come on.
Healthy eating.
Yeah.
So reduce of obesity factors.
Yes, so if we help, because I'm thinking as a, how to say, as a, in the government, like how could they help? They can't go, especially if the mentality of eating fast food and etc. is very implemented. The only way they can reach people, first obviously is by educating their kids, but also it's through money. And if like eating healthy is less expensive than eating fast food, then it's already a step forward.
Whereas now it's the opposite. It's healthier if you eat the unhealthy. It's cheaper to eat the unhealthy rather than the healthy.
Yeah.
Yes, yeah, of course. Go ahead. Thank you.
Also, something to add in this, we said education, we said the school, we said the government, but I think the most important thing here is family. If the parents and the elder members of one family set up a good example and they teach their kids that it's okay to do this, it's not okay to do that, to eat certain foods, I think that can decrease a lot. The case of type 2 diabetes, family is important.
What about doctors?
And definitely doctors, also
So
doctors.
if you go to a doctor and the doctor smokes and he talks to you about
That's pretty bad.
against smoking, for example.
And that's a problem. We can see this, say, I'm Greek personally, so I see this a lot in Greece, which is pretty bad. A doctor should be an example, should be a role model. You shouldn't smoke inside your office. You shouldn't smoke generally. But you should be example for your patients.
Exactly. Aaron?
I think going back to what you said about the children as well and in schools, I think having, not like in a bad way, but having like a mandatory physical education program in schools is very important. A lot of the time now, like I know from my school back home, towards the later years, physical education wasn't mandatory, and there's a lot of students that would opt out of sports teams or just general physical activity in school. And I think this kind of develops a mindset in youths where, you know, if you're not necessarily good at a particular sport or if you're not interested, you completely disconnect from physical activity in total. And I think that's what is also leading to a lot of increasing rates of childhood obesity, because, like I said, if you're not directly invested in a sport, then you're just sitting at home or you're not pursuing a high level of physical fitness, and coupled with the fact that, like Axel said, a lot of the time processed and unhealthy food is cheaper, you have these two factors which are promoting increasing rates of childhood obesity. Whereas if from a young age you promoted the fact that physical activity, whether you're good at a particular sport or not, is just part of your life and it's part of what is being healthy, then that would decrease a lot of childhood obesity that we're seeing.
Very good, Aaron. And as he very correctly said, one of the main things is schools. So as medical professionals later on, biomedical professionals, dentists, you guys will be part of public health decisions. They do include you guys in these decisions. So it is a good idea to include these, especially in the educational system. If you guys have a look online, you will find some countries, such as Sweden and China, they actually have a compulsory 1 hour a day exercise scheme within the school. They also give children the opportunity to rest at school, which is very important, and it helps prevent this. And that's why their numbers are low compared to ours. Another question I do have is in two parts. The dentists will be a bit more interested in this one. You guys very correctly mentioned about antibiotics. So my first part of the question, do you have any data as to why Cyprus and Greece were so high in antibiotics use?
That was Fayo's.
Yeah, Fayo's part. Did it say anything in the paper as to why?
The graph showed that most of the antibiotics prescribed are part of the watch section. So these are the antibiotics that are more accessible, but they do cause more.
So they were prescribed. It wasn't just that the patients were preferring to skip the doctor and go for.
So that's why a lot of the blame is still on doctors. I think education does need to start in hospitals. It didn't show it was behind the picture, but even in England, the statistic was 20% of antibiotics are inappropriately prescribed. So even though there is a lack of education in the public, there still is mistakes and I would say negligence from healthcare professionals, which is why obviously it's important for all of us to understand that. And there was a picture of it's an antibiotic guide that WHO has, that they say these antibiotics should be prescribed first and then go to these ones, but it's not as used in hospitals, so it's just important that healthcare professionals obviously have that education.
Very good, okay. So I actually see a few students here from second year, and we did ethics recently. So does anybody remember what the main problem I told you we had between medical professionals and patients? What is missing a lot? You remember? Yeah, of course. Just so everybody else can hear you as well.
Yeah. Is it on? Yes. So I think the problem is the Cypriot mentality, of the patients. I mean, when a patient goes to the doctor, and the doctor says, "Okay, you have nothing. It's just a virus," they just don't accept it. So they in the back of their minds, they say, "What a shitty doctor that is. He didn't prescribe me anything, so I won't go to him again." So for that period of time...
How do we cope with that?
How do you think we can change?
Because this will be a
it's
matter you will face
thing.
at some point.
It's educational thing. So the mentality is wrong.
The mentality is wrong.
Yes.
So how can we... Despina?
Or better education, because as we know, drugs don't work again. We can take drugs, bactericidal drugs against viruses. And when antibiotics. So when we go home, we just have okay, I'll take a Panadol, a paracetamol, and I will be fine. We take it every day. And like I have a minor headache, I'll take a Panadol every day.
A way to minimize this, I think, is first of all for the patient to have to go and test themselves at the pharmacy for viruses first, like the pentapulo, tetrapulo. And if it's negative, then the doctor can prescribe. But I also think that doctors shouldn't get paid for prescribing the antibiotics. That way, they don't overprescribe them. Because in Cyprus, we also have this thing that ESC and stuff, doctors get paid for the pills they give. So maybe if for antibiotics, since they are harmful, we can make them a kind of category that is not money making for doctors. I don't know. So that way they don't feel that, oh, I'm going to prescribe to make money. They just feel that, okay, I'm going to prescribe to whoever actually needs antibiotics. I don't know.
Very good. So that you kind of touched a bit the part of my second question, which was the main issue we have, and we mentioned this a lot in ethics, is the trust between patient and doctor. I'm not just talking doctor, it might be even with the dentist. You need to make sure you maintain that trust. And unfortunately, there is an issue with trust. Okay, so how would you go about to explain to your patient that, look, there's no reason for me to prescribe something to you, but at the same time, make sure you maintain that trust so they don't worry and think, oh no, this doctor is ignoring me. That's why he's not giving me anything. How do you guys think you could deal with that? Go ahead, Faya.
When I was researching, I actually found specific to Cyprus that 70% of Cypriots think that antibiotics cure viral infections. So I think even though it's easy to blame a patient, I think the doctor still has a duty to care and a duty to inform a patient. Yeah. It's really, I don't know if we do, I'm from UNIC, so we do in communication skills like ideas, concerns, expectations. I think it's just, it sounds boring and it's like really long-winded sometimes, but really understanding what the patient would do if you don't give antibiotics, and like making them understand that it won't help, and maybe even not scaring the patient, but making them understand that there are risks, exactly, like C. diff infections, and that taking antibiotics when they're not needed does cause more harm than benefit. So I think it's about just communication with the patient.
Excellent. Would you like to ask something? Yes. Magromo? Yeah.
I also have something to add to that, because before I was in med school and before I understood how antibiotics worked, I went to the doctor and I was like, oh, I have a cold or whatever, and he gave me amoxicillin. And he said, oh, you take it for 1 week and then you'll feel better. After 2 days, I felt better and I stopped it. And that's an issue, because then you create resistance to that antibiotic. And if the doctor had told me you need to carry on with the 7 days, because if you don't, then you're going to have this consequence, I wouldn't have stopped it at 2 days because I felt better. And I think this is something that it's obvious for us now as doctors, if you do pharmacology, that, oh, you have to actually go on through the 7 days. But if you don't know that, you might stop at 2 days and then that antibiotic might not work later. So I think if it makes sense to us, it doesn't have to make sense to the patient, and that's something to keep in mind as well as doctors, but also as dentists, as veterinarians, as everything, actually, if you're in healthcare. So that's just something I wanted to add as well.
And also, if it was a viral infection that you had and you were taking,
it wasn't necessary.
Yeah, it was not necessary. And also, maybe the doctor could have said that if you have a viral infection, you still get antibiotics. If you didn't actually get, you might have become better earlier than antibiotics. Yes, that's me.
Can I add something on what Margot said? And then if you used it just for 2 days, and then 2 months after I didn't sleep well at night, I woke up in the morning and I had a headache, and my doctor gave me those pills I have still, so I can use them, and then that's how we misuse the drugs.
True, drug misuse. Okay, so Despina, you talked about cancer and dysbiosis, right? Do you have anything in mind, any particular example?
For example, we have hepatitis infections that lead to liver cancer.
Very nice.
We have HPV,
H. pylori,
cervical cancer, H. pylori gastric cancer.
Very nice, very nice, very nice. Excellent. Good.
I have one general question, but I'd rather leave it to the end. So if you want to ask.
Okay, I have one for the dentist. So do we have other dentists here? Only the two in the round table? You are underrepresented, you see? Even in this room.
When you go back up tomorrow, on Monday, complain to them.
Okay. So Lydia and Marilena, as a dentist, now that you have done all this beautiful work with One Health, how can you exploit concepts, the concepts of One Health in your office? Like, can you be careful about something that will affect your patients more than others?
Yes, we should examine the oral cavity to find diseases that might start from the oral cavity. Yes.
Other than that, related to the materials you're using, for example? You're using a lot of...
Most of them are tested in order not to cause something bad for the patient. But like Lydia said, disease like periodontal disease, as I mentioned before, can be an example that maybe we have to consult a doctor and we have to say to the patient, you have to go to a doctor because he may have another problem, a medical problem.
Yes, because many oral diseases are interconnected with other systemic diseases like diabetes.
The definition of One Health.
Yes, exactly. Yes, I think I'm done.
Yeah. Okay, so I'll ask a quick question before I go to my final one. Margot very correctly mentioned a lot of products that we may use that can help, that can be an issue in terms of microbiome and so on. Some of those products being necessities that we definitely need in everyday life. Like, how can we avoid it since they are necessities? I mean, how would you advise a patient who doesn't really have the knowledge and background that we do and how to deal with it, Krista?
I think it's just very difficult to say to someone, you have to change your whole lifestyle now if you want to live a healthier life. It's just impossible. I asked myself that while like trying to prepare for that round table, and I was like, it's incredible. Like from basic things that you use every single day. Soap, like, are you going to stop washing yourself with certain types of soaps? Like, food packaging. Maybe you could try, like, instead of using plastic, like, use a certain type of, like, paper bag, but still the paper bag is infected by whatever, like, types of chemicals. It's just too difficult. Like, you'd have to not live anymore. It's impossible. And something that is actually really interesting is, what actually shocked me, is how even if the mother is, like, exposed to these endocrine disruptive chemicals, even the baby before it's born can be infected by these things, and it's really incredible, and it's very, very alarming. And I really don't know what we can do. It's like good food for like thinking about that, because it's I don't know about you guys, what you think about it, but for me it's we should do something about it, but then what? I'm a loss for words for that one.
Maybe small steps,
small steps, but it's still very difficult. Like I don't know, you would have to find a way to replace these items with healthier versions, but all of that is...
Based on that, I want to see a raise of hands. How many of you actually read the packages before you buy something at the supermarket? Just out of curiosity. Only 4, 5, 6 of you? 7?
What are you looking at when you're reading? What are you looking at?
What do you look at when you...
Okay.
Very good. So you have to, food allergies definitely.
There's also a nice app that I don't know if you know. It's called Yuka. I don't know. And you can scan barcodes of the items, and it shows you if it's healthier or not. But so that could be something more accessible.
Whoever is in this room or whoever's watching us, make sure you read the products, okay? The most classical products that have been withdrawn in the recent years are shampoos and conditioners, okay? So make sure you're reading what you're putting on you. A lot of shampoos have been found with products inside that interfere with hormones. Yes, Axel. It's true. That's another issue. Yeah, even if you read the label, most of the things on that label are gibberish. You don't understand what they are really. But at least try and see, figure out.
There are a few things that you can look at. For example, all the food that has a E, the name
products
E something,
with an E12,
and a number.
E8.
That's an indication that there is something there that is a chemical, right?
Shampoos that have sulfates. Not good for your skin.
That's for food, so that's good. That's an initiative that's good, putting A, B, C, D, E to at least know in which category of healthy we are. But in things like shampoo, body lotion, soaps, whatever, there's no.
But what about GMOs, genetically modified organisms, in our food?
I mean, this is, I think it's solved by the bio, but then it's more expensive and most people cannot like afford it on a regular basis, so.
So in Cyprus, we were not allowed to sell products that have GMOs inside, but we buy things that are made of GMOs. For example, corn syrup, things like that come from other countries. You cannot.
Maple syrup, especially. Yes. Very good. Okay, so our last question, because we are close to our time. So we have a panel here from different backgrounds, okay? You guys come from different education systems and so on. I'd like your input a bit. So moving forward, what do you think are the challenges of all of you working together for One Health? Because one reason One Health hasn't been going forward as easily is because there's difficulty between the collaboration in different fields. So getting a panel of environmental scientists with biomedical specialists and medical specialists and dentists and vets together is not very easy, as you can understand.
Yeah,
you saw how it was experienced.
Dentists and medical doctors, so not much of the variety.
Yeah, but what do you guys think? How can you move forward? Even as students, you can start making changes now. So how do you think moving forward you can start to be able to collaborate with each other from these different fields? Yeah.
We have to identify the common risk factors, the common risks that cause both to the dentists, to the patients that come to the dentist, both to the patients that come to the doctors, and to collaborate in order to solve them.
Athanasia, you wanted to add something? Ah, perfect. All right. Yes. Question? Another addition? No. Is it working?
Everyone in the healthcare systems must get the same education about this matter, because I think, like, we do a public health class, someone else doesn't do it, so it would be better.
True. So key thing, yes, make sure you understand what One Health means and make sure you're able to spread the word that there is such a thing as One Health. It is an important factor in everyday life, and to be honest, based on the presentations we've just seen, I believe it's a very important way for us to move forward, especially in research and especially as professionals that you guys will be meeting patients in a few years. You need to be able to explain this stuff, all right? Anybody else have anything to add or questions? Would you like to add something else? No?
No, I think you've done a great job. And,
very good job, yeah.
I'm very proud of you.
Excellent. Very good. Round of applause, guys. Very good. Thank you very much, guys.
Thank you so much, everyone. I would like to congratulate on behalf of the organizing committee and everyone involved in CAMeSM, both the presenters and the professors. Everyone has done a terrific job, and you really deserve congratulations on that. Now, I would really like you guys, those of you who are still present, to please scan this QR code and vote for this roundtable. We have roundtable awards this year, so this is a great way of supporting these great people, and maybe they can get an award. Okay, thank you.
Yes,
so
guys,
much.
please vote for us. Come on.
This will be up for about 1 or 2 minutes, so please do this.
Vote 100 times if you need to. Come on.
CAMeSM roundtable discussion on the anatomy and physiology of the heart, titled Four Chambers, One Symphony, the silent dialogue between cardiac structure and its function. The heart is often described as a pump, but its function is far more intricate than that simple image suggests. Every chamber, valve, vessel, muscle fiber, and electrical pathway contributes to a highly coordinated system where structures and function are inseparably connected. This roundtable will explore how the anatomy of the heart supports its physiological role, from the movement of blood through the four chambers to valve function, myocardial contraction, electrical conduction, and the synchronized activity that allows the heart to sustain circulation throughout the body. Today's discussion will be led by Dr. Zayad, together with our student presenters, Aphrodite Argiridi, Clarita Saloom, Joey Awad, and Razi Khan, and roundtable coordinators Teriani Pali. We invite you to follow the discussion actively and reflect on how a strong understanding of cardiac structure and function forms the foundation for recognizing disease, interpreting clinical findings, and practicing medicine with greater precision. Please join me in welcoming Dr. Zayad and our student presenters.
Hello everyone, my name is Joy Awad. I'm a first-year medical student at the University of Nicosia Medical School. And today I'll be presenting the first part of our roundtable. And basically I'll be talking about what the heart is, what it does, and the basic blood flow in the body. Now, as you can see, our title is called Four Chambers and One Symphony. And that's because although the heart has many processes and many parts, they all work together in harmony to achieve the same goal, which is to make sure that blood flows smoothly throughout the body. So this is just an overview of what I'll be discussing. First, I'll start off with a short introduction. Then I'll move on to the function of the heart, then the basic structures and anatomy. Then I'll move on to the blood flow in the heart, which leads me to the pulmonary and systemic circulation. Finally, I'll close with a conclusion. So to begin, the heart is located in your thoracic cavity, which is in the center of your chest, and it's protected by your ribs, which is really important because the heart is a vital organ needed for life. It's also a muscular pump, which means it contracts to pump blood out of the heart, but it also relaxes to allow blood to be flown into the heart. It's the main organ of the circulatory system, which is basically the system of blood flow in the body, and it works continuously day and night to provide blood to the body. Moving on to the basic function of the heart. Now, the heart has two main pumping roles. The first one is that it pumps deoxygenated blood to your lungs, and this is basically the blood that lacks oxygen and nutrients is taken to the lungs to be renourished again. And then the second role is that it takes oxygenated blood to the rest of the body. Now, this oxygen-rich blood is needed for your tissues and organs for them to function properly. And just a quick little fun fact is that the pig heart is 80 to 90% similar to the human one, which is why it's so often mentioned in medical studies and learning. Moving on to the four chambers, so the basic anatomy of the heart. Your heart has two sides. We have the right side and the left side, and each side is separated into two chambers. We have the atria on top, so the left and right atrium, and then we have the ventricles on the bottom, so the left and right ventricles. Now, the atria are the first to receive blood, whereas the ventricles pump blood out of the heart. We also have, let me just open the laser pointer. We have these white curves, as shown, and these are called your valves. They prevent the backflow of blood. We have two main types. We have the atrioventricular valves, AV valves for short, and from the name, they're between the atrium and the ventricles. We also have the semilunar valves, which are between the ventricles and the artery, but you'll go into more detail about these by my colleague Clarita later on. And another important structure is the septum, which is here in the middle. This separates the right and the left side of the heart, which also prevents the mixing of deoxygenated and oxygenated blood, since each side only deals with one. Now, moving on to the basic pumping cycle of the heart, which is also called the cardiac cycle. First, the atria receive blood, but the atrioventricular valves are still closed. Then the AV valves open, allowing the ventricles to fill passively. After that, the atria contracts, giving that final push of blood into the ventricles, which is also known as the atrial kick. And finally, the AV valves are closed, the ventricles contract, which allows the semilunar valves to be open and blood is pumped to the body. Now, I mentioned before that the heart has two main pumping roles, which brings me to the first one, which is the pulmonary circulation, and it occurs on the right side of your heart, and it pumps deoxygenated blood to your lungs. So all that blood that lacks oxygen and lacks nutrients is taken up by your inferior and superior vena cava and taken to your right atrium. From the right atrium, taken to your right ventricle. From the right ventricle, the deoxygenated blood is pumped into your pulmonary artery, which transports the deoxygenated blood to your lungs so it can get nourished again. Then we have the systemic circulation, which occurs on the left side of your heart, and it pumps oxygenated blood to your body. So after that deoxygenated blood that was pumped to your lungs by the pulmonary artery is now oxygenated, it's picked up by your pulmonary vein and taken to your left atrium. From the left atrium, pumped into the left ventricle. From the left ventricle, transported by the aorta to the rest of the body. Now, the aorta is the main artery in your body that carries oxygen-rich blood. And finally, when you put both of them together, the pulmonary and the systemic circulation, we get what is called a double circulation, which basically means that the blood flows through the heart twice during one complete cycle. So just to recap the full cycle, the blood from the body is taken by the inferior and superior vena cava to the right atrium, pumped into your right ventricle, then taken by the pulmonary artery into your lungs so it can get oxygenated. Then, once it is oxygenated, it's taken by your pulmonary vein to your left atrium, to the left ventricle, and finally taken by the aorta to supply oxygen-rich blood to your body. To conclude, the heart is a vital muscular organ that works continuously to provide life and support life as well. Its four chambers and valves work continuously and they work together in order to make sure that blood flows in the correct direction and also flows smoothly throughout the body. So understanding the basic structure and function of the heart, but also understanding the basic blood flow, helps us understand how truly important the heart really is for circulation, for oxygen supply, and of course for overall health. Thank you so much.
Hi, my name is Clarita Saloom, and I'm a first-year medical student at the University of Nicosia. And I will be talking about the heart valves. So to begin, I'm going to show you a brief overview of what I will be discussing. I have the introduction, then the valves, the cardiac cycle, and lastly, valve dysfunction, and then the conclusion. To begin with, valves are very essential in the human heart because they keep the blood circulating in one direction, and in addition to that, they prevent the backflow of blood. We have four main valves. The first is the tricuspid, and then we have the pulmonary, and then the mitral, and lastly, the aortic valve. Healthy valves support efficient circulation and help deliver oxygen to the body. Now, how do these valves work? We have, essentially think of them like doors. When you push a door open, you're pushing it through pressure. So the valves work passively through the pressure of blood. Now let's take the tricuspid valve as an example, and it looks like somewhat like this. So when blood comes in, blood's going to enter, and there's going to be pressure on the valve to open passively likewise. And you can see here on the screen, this is the tricuspid valve, and this is a clearer image of how it looks. Now let's take into consideration the pulmonary valve. It doesn't look like this, more so like this. So when blood enters, blood is going to push out like this, in this manner. Now, where are the four main valves located? We have the tricuspid valve, which is located on the right atrium, between the right atrium and the right ventricle. The pulmonary, which is located between the right ventricle and the pulmonary artery. And the mitral, which is located between the left atrium and the left ventricle. And lastly, the aortic valve, which is located between the left ventricle and the aorta. Now, just a quick check to see if you guys are following along. I have a question. Which valve prevents blood from flowing back into the left ventricle? Bravo. So if any of you didn't hear, it's the aortic valve. Now, moving on, we have the cardiac cycle sequence. Now, as my colleague Joey had mentioned earlier, we have two categories. We have the atrioventricular and we have the semilunar. Now, what falls under the atrioventricular are the tricuspid and the mitral, since they are located between the atrium and the ventricles. And what falls under semilunar are the pulmonary and the aortic. Now, we begin with ventricular filling, where the AV valves, they open and the semilunar valves are closed. Then we have ventricular systole, where the AV valves close and the semilunar valves open. And lastly, ventricular relaxation, where the semilunar valves close to stop backflow and the blood flows to the rest of the organs. Now, I've talked about the valves functioning healthy up until now, but we may have valve dysfunction. Now, we have two main types, stenosis or regurgitation. Now, stenosis is narrowed opening. So instead of the valve opening likewise and allowing all of the blood to move forward, there's a narrow opening and not all of the blood may move forward. Regurgitation is incomplete closure, so there may be a backflow of blood. Both these can lead to symptoms of breathlessness, fatigue, and swelling, and they make the heart work a lot harder, and this puts a lot of pressure on the heart and reduced flow to the organs. To conclude, heart valves are very essential as they keep the blood moving in one direction and they prevent the backflow of blood. We have four main valves, the tricuspid, the mitral, the aortic, and the pulmonary. And sometimes we may have valve dysfunction such as stenosis and regurgitation, which may result in some symptoms such as breathlessness, fatigue, and swelling. Thank you so much for listening.
Hi everyone, my name is Aphrodite Argiridi and I'm a third-year medical student. I'm here to discuss the electrical system of the heart. Just a brief introduction first of all, with the normal cardiac conduction pathway, the electrical timing and why this is important, followed by any abnormalities such as complete heart block, atrial fibrillation, and how these may have physiological and clinical impacts on our patients, as well as any conclusions. So, how does the heart know when to beat? Does anyone have any idea? So, the human heart beats approximately 100,000 times per day, completely automatically. This is possible because the heart has its own intrinsic electrical system, meaning it can generate impulses without any external stimulation. These impulses originate from specialized autorhythmic cells known as the SA node. Although this process is automatic, it is still modulated by the autonomic nervous system, where an increase in sympathetic activity will increase the heart rate, whereas an increase in the parasympathetic activity will decrease the heart rate. So the key question here is, how does the heart coordinate all of this to produce an effective beat? Essentially, how does it know when to beat? Let's move on to the conduction pathway. The image shown here on the right, we see the cardiac conduction system, which is the electrical network responsible for initiating and coordinating each heartbeat. It begins at the SA node located in the right atrium, which acts as a natural pacemaker by generating spontaneous impulses at a beat of 60 to 100 beats per minute. These impulses spread across both atria, causing atrial contraction and pushing blood into the ventricles. The signal will then be pushed further to the AV node, where there will be a brief delay of about 120 milliseconds. This is done so that the ventricles have enough time to fill with blood. The AV node also has its own intrinsic rate of 40 to 60 beats per minute. In the case that the SA node fails, the AV node will act as a backup pacemaker. From the AV node, the impulse will then travel down through the intraventricular septum by the bundle of His, spreading into the left and right bundle branches towards the apex of the heart, where it then spreads through the Purkinje fibers within the ventricular walls, triggering ventricular contraction at a rate of 20 to 40 beats per minute. This occurs only if all other pacemakers fail. Now, I said before we're going to discuss timing. So why is timing important? In this little diagram here, we see how the cardiac system is broken down into its single heartbeat with its respective key components, the P wave, the R wave, and the T wave. The P wave represents the atrial depolarization, where the atria contract first, filling the ventricles. The PQ segment represents the brief pause where the electrical signal slows down at the AV node, ensuring that the ventricles are filled with blood before they contract to move towards the rest of the body. The R wave represents ventricular depolarization, where the ventricles will contract to pump the blood out towards the rest of the body. And the T wave is responsible for ventricular repolarization, resetting the cycle for the next heartbeat. This precise sequence is what ensures efficient cardiac output. So what happens if this timing is broken down or if it fails? Let's go take a look at that. When the cardiac conduction system is disrupted, electrical impulses travel abnormally through the heart. In first-degree heart block, conduction through the AV node is delayed, but it is not blocked, causing a prolonged PR interval greater than 0.2 seconds, while all other impulses are still able to reach the ventricles. Essentially, your heart is beating slower. So if we compare these ECGs, the normal and the first-degree AV block, what we see is that in the first-degree block, there's a pause between the P wave and the QRS. So instead of seeing P, QRS, you're seeing P, QRS, P, QRS. In second-degree heart block, some of these impulses fail to conduct, so some P waves are not actually followed by a QRS complex. So some of the P waves occur as such: P, P, QRS, P, P, QRS. In third-degree AV block, which is also known as complete heart block, the atria and the ventricles are losing their disconnection from each other, meaning that P waves and QRS waves cannot occur independently. The P waves are going such: P, P, QRS, P, QRS, or P, P, QRS. Essentially, they're disrupting the coordinated contraction, and they're reducing the cardiac efficacy, often causing bradycardia with a regular ventricular rhythm on the ECG. Now, another disorder we can discuss is atrial fibrillation. This image here shows us a 12-lead ECG of atrial fibrillation. The first thing to notice is that there are no clear P waves. Instead, you're getting this chaotic, irregular baseline, which is most obvious in leads V1 and V2. This is because instead of having one clean SA nodal impulse, we're getting hundreds of disorganized circuits all firing at once. And now, if we look at the bottom rhythm strip, the spaces between the beats are all different. Some of them are smaller and some of them are larger. This is classic for irregularly irregular rhythm of atrial fibrillation. Another thing to note is that the QRS complexes are narrower, so the ventricles are actually conducting normally. However, because they're being triggered randomly, the rate is sitting at around 100 to 110 beats per minute, essentially causing uncontrolled atrial fibrillation. And this sustained fast heart rate drives down the cardiac output and puts the patient indirectly at a stroke risk. Now, moving on to the complete heart block, if you guys remember, the electrical signals between the atria and the ventricles are completely interrupted, meaning that no impulse is able to be passed down from the atria to the ventricles, resulting in a total AV conduction failure. To compensate, the system will have to generate a ventricular escape rhythm by the ventricles, serving as a backup pacemaker for this. However, this rhythm is going to be much slower, usually occurring between 30 to 50 beats per minute, and this is often inadequate to maintain sufficient cardiac output, potentially causing clinical instability of these patients. Now, the other thing to note is that third-degree AV block also has many different symptoms, which mainly stem from a much slower heart rate, which essentially lowers the amount of blood being pumped out. Because of this, less blood is able to reach vital organs, reducing the oxygen supply. This shortage is displayed as everyday common symptoms such as fatigue, dizziness, and shortness of breath. These signs reflect how the body struggles to meet its energy needs, especially during physical activity, and they can get worse if the heart's pumping ability continues to decline. Another thing to note is the clinical signs of AV dissociation. They have distinct clinical signs. The atria may contract against a closed AV valve, essentially pushing the blood back into the venous system. This results in prominent jugular venous pulsations, as we see here, known as Canon A waves. They are visible in the neck. And another thing to note is that heart sounds also may vary, both in intensity due to the independent activity of the atria and the ventricles. These findings are key clinical indicators of complete heart block, and they are often detectable during a physical examination. In conclusion, I would like to remind us that normal cardiac conduction depends on a coordinated electrical pathway from the SA node to the AV node to the ventricles, allowing for efficient and synchronized contraction. In third-degree AV block, that is where this communication is completely lost and the atria and ventricles are beating completely independently and the ventricles are relying on a slower escape rhythm, leading to bradycardia and a reduced cardiac output. In atrial fibrillation, the system is a little bit different, and the issue is a little bit different though, because the SA node is essentially being replaced by hundreds of disorganized circuits and the AV node is conducting randomly. So if there's no atrial contraction, the cardiac output will fall, and blood stasis is what will raise the stroke risk. Both conditions highlight how critically dependent the heart is on a functioning conduction system. Thank you for listening.
Good evening, everyone. So, I'm your last presenter for this roundtable. My name is Razi. I'm a first-year med student, and I'm going to be going over the coronary circulation of the heart. So, contents. What do we need to go over? The big question. Why does this system exist in the first place? Why does the heart need its own blood supply? We're then going to go over the anatomy. You are warned this has anatomy, so if you want to leave, leave. There are two key concepts that we'll go over, and then a clinical case study. In the clinical case study, you may need some anatomy, and you may need one or two of the key concepts. I'm not going to tell you, but sit back, relax, and enjoy the presentation. So, before we start, heart delivers blood around the body. However, where does the heart get its own perfusion from, i.e. its own blood supply from? Trains. This is a train map from the UK. We have a lot of trains there. And trains take people to vast regions of land, right? But how does the train move? It has its own energy system, whether that be coal or electricity. The little people in the carriages aren't just going to get off and push the train themselves. That's not how trains work. So let's imagine the train is the heart. The heart is contracting to deliver oxygen around the body via the blood. But it needs energy. The myocardium needs that energy. And how do we make energy? We need oxygen. And the blood's carrying the oxygen. So therefore, the heart needs its own blood supply. So we've answered the big question, great. Now we're going to move on to the anatomy. We're going to split the heart into two, the right side and the left side. So the common conception that we all know, the right coronary artery supplies the right side of the heart. Yes, but what is it actually supplying? It's supplying those branches on the right side. And I'm going to go over a few of them. There's a lot that we're meant to know about, but I'm not going to go over through all of them. We're going to go over through some. First one is the SA nodal branch, the sinoatrial node. Remember, this is the main pacemaker of the heart, so it's quite a critical one. And in about 60% of individuals, is supplied on the right side, the other 40 on the left, and we've also got the AV nodal branch. This is for atrial contraction, and about 90% of individuals are on the right side, and the other 10% on the left, via the left circumflex artery. Then we've got the right marginal arteries. Right marginal arteries supply the right atrium. And if you remember, the right atrium is pushing that blood towards our lungs. So this is quite a critical artery. And then we've got the posterior descending artery, covering the left and the right ventricles, i.e. the inferior wall of the heart. I'm going to call it the PDA from here, much easier. Dominance and codominance. This is one of the key concepts. No, this is not dominance from genetics. We're not covering alleles, so those of you with genetics PTSD, I'm sorry if I triggered it. But what is dominance? Dominance can be defined as the artery that supplies the PDA, and in turn, this artery will supply the inferior wall. And there are 3 types we need to know. You've got the right, which is the most common, codominance, and left dominance. What is codominance is where both the right and the left coronary arteries meet at this T-junction, and they supply the PDA. I've got a lovely image to show you here. You can see the right here, the codominance here, and the left here. And what is, no, that's it. So, we covered the right side, so let's move on to the left. The left coronary artery supplying the left side is actually the branches. So, we've got the left marginal artery, covering the left wall of the left ventricle, the circumflex artery, which I'm repeating over and over. Don't worry, only a couple more times. Covering the left lateral and posterior wall of the ventricle, and then the left anterior descending artery. This covers the left anterior wall, the 2/3 of the intraventricular septum, and the apex of the heart. It's also called the widowmaker. Why? A, it probably made someone a widow, my condolences. But B, if blocked, you are virtually not supplying most of the left side, because this artery is actually responsible for about 60 to 80% of the left ventricle. So, we have covered some anatomy. How do we actually know the extent of damage done? How do we actually test it? Unless you're Superman with X-ray, of course, you're going to need a coronary angiography. What is this? A sedative is given prior to the patient. And why do we need the sedative? To relax the patient, to reduce movements. And then a small incision is made. This can be made either the radial artery or the femoral artery. And then a catheter is guided to your heart. And once in place, a dye is injected through the catheter. Why do we need dyes? To provide contrast, to distinguish the arteries away from all the other structure. And I've got a beautiful image to show you. Laser pointer works. Here on the left, you can see a normal coronary artery. And here, this is a left circumflex. It looks well supplied, right? But on the right, well, it looks like my computer wires at home, disorganized and chaotic. This is because there's a narrowing here. There's probably a blockage here. And it shows that even just a small blockage can lead to such big complications in such a complicated system. Now, we also have the CT version of this, the CT coronary angiography. What does this use? The clue's in the name, CT. So, in CTs, if we remember, you have to lie still. But we can't make the heart still, because otherwise you're going to kill your patient. So how do we get this? So, the patient will be given a beta blocker. The beta blocker will slow the heart contractions just enough so that the computer can analyze this, and then it can take the perfect snapshot at the right moment. And here's a beautiful image. The left one's quite ugly, so we're going to go off the right one. Here we can see there's the left main, the circumflex, the obtuse marginal artery, the first one, the first diagonal, and the left anterior descending artery. And you can see that the left anterior descending artery is covering most of that left side. Where there's arteries, there's veins. Yin and yang. Cannot separate it. There are 4 we need to know. the anterior, the great, the middle, and the small. And they all have one role, to drain that deoxygenated blood, because it's not going to stay there once it's been used, right? So it goes into the coronary sinus. They all connect to the coronary sinus, and then they all drain into the right atrium. Imagine you're driving all the way back to Paphos at 11 in the evening and there's traffic. You want to take a shortcut. This is that shortcut. Okay, clinical case study time. So, I'm going to present you a patient, some brief information, and then we're going to figure out what's wrong with him and how we treat him. So, patient's name, Mr. Jack Daniel McMarlborough. Says a lot about him already. He has been saying he's 53 for the last 5 years. We're going to say he's 53 for now. His profession, he's an elite gambler. I know this because I met him at the casino the other day. We won a lot of money. And his family status, his wife.
Can I interrupt you for a second? Jack Daniel McMarlborough says a lot about the patient. A big pen says a lot about the doctor. No?
Yeah.
Yes.
His family status. His wife has begged him to quit the alcohol. You know what he says? He would rather quit the kids. What a role model. What a father. Give it up for Daniel, guys. What a father. Okay, symptoms. Severe crushing chest pain, shortness of breath, profuse sweating, and nausea. His history, a high-fat diet consisting of steak and sea salt. Sea salt. He's been recently physically inactive. He's developed alcoholism, and he smokes. I'm not talking about those e-cigarettes or vapes these kids use. I'm talking about proper red Marlboro cigarettes. Honestly. Now, upon examination, he has an elevated heart rate, and his pain was not relieved by rest. So, I'm going to give you a few moments just to take a guess, and for the preclinical years, I'll focus on V1 to V6 and the AVF. Got to stay hydrated. So, would anyone want to take a guess at what this could be? No one? All right, that's unfortunate. Let's go and take a look.
Disappointing.
I'm very disappointed. This is a STEMI, an ST elevation myocardial infarction. And this one's an anterolateral one. But how do we know it's an anterolateral one? Well, just like an MI, it's caused by the complete blockage of a coronary artery. But there's an ST elevation from V1 to V6. Unfortunately, though, V1 decided to say, no, I'm not going to work today, so I apologize about that. But the others decided to come into work. The first two cover the septal aspect of the heart, the second two, the anterior, and the last two, the lateral. And if we remember correctly, there is an artery that covers all three of those. The LAD, the widowmaker. Poor Daniel. So how do we help Daniel? What do we give him? We give him a percutaneous coronary intervention. Are you okay? I hope you're okay though. This is a PCI. This is similar to the coronary angiography, but at the end of the catheter, there is an umbrella. Not the ones we use to take out when it rains. We don't set umbrellas into people. That would be unethical and wrong. This umbrella will widen the coronary artery to relieve it of the blockage. So to conclude, the coronary system exists to supply the myocardium of the heart oxygen, and it's got all these branches to supply that different myocardium. And we were successfully able to use the anatomy to identify the STEMI and the culprit vessel. So, thank you all for listening. I'm not done yet. We're not done yet. I said listening. We're not actually done yet. No. We actually have a surprise for you. We have a video of an echo. We were going to do it live, but due to some technical difficulties, we couldn't. So on behalf of all of us, we apologize. But we'll show you the video. Thank you all for listening, and I hope you have a great CAMeSM.
What's with the cursor? It doesn't let me. Wait. Ah, right there. Thank you. Όχι, μην το.
Is it good?
Just give me a second.
Is it good?
Hello everyone, my name is Teliani. I am the coordinator of the Anatomy Physiology of the Heart Roundtable. This right here is the baby, and this right here is our beloved Labra, Razi. So today we will be performing a cardiac ultrasound on him. He has given his full consent, by the way. And this imaging technique, also known as echocardiogram, is used to visualize the heart in real time and assess both function and structure. So, let's start. This view right here, that Aphrodite is showing us, is called the parasternal long axis. We can see some very key cardiac structures. These are involving the right ventricle separated by the intraventricular septum from the left ventricle, and the left ventricle, whose lateral walls are right here, is separated by the left atrium via the mitral valve, whose anterior and posterior cusps appear right here. On top of that, we have the aortic valve, which regulates blood flow from the aorta. Here we can see that as the heart beats, we have the rhythmic contraction of the left ventricle. During systole, it contracts, ejecting blood into the aorta via the aortic valve. And during diastole, it fills with blood and relaxes, allowing blood from the left atrium to come in. On top of that, it's worth mentioning that this coordinated movement allows blood circulation to happen effectively. I think we have had enough from the long axis. Let's move on to the short axis. The fish-looking thing right here is the mitral valve, and Aphrodite, can you switch so that we can see the optic? Sure. Thank you. And this right here, the Mercedes sign looking thing is the aortic valve, and in this view you can also take a very subtle look on the tricuspid valve right here, and on the pulmonary as well, and the pulmonary artery on top of it. Right here we can see an apical four-chamber view that allows us to see all the four chambers simultaneously.
And here we have the left atrium with the left ventricle separated by the mitral valve, and the right atrium with the right ventricle separated by the tricuspid valve. And both ventricles and atria are separated by the interventricular septum, respectively.
We have finished with our ultrasound. I would like to thank Razi for allowing us to experiment on him, of course.
Also, we would like to thank Dr. Zayad for giving us this opportunity to learn how to use an ultrasound machine under his guidance in our preclinical years.
And we'd like to thank our lovely coordinator, Sturgiani, for making this all possible.
Thank you guys so much, and I hope you had fun with the roundtable. Just give me a second to go back to the slides. Hello everyone, my name is Tatiana and I'm the coordinator of the Anatomy Physiology of the Heart Roundtable. This right here is a baby, and this right here is our beloved Labra, Razi. So today we will be performing a cardiac ultrasound on him. Fixed it. Yes. Fixed it. Let's get back to the PowerPoint. Wait. Before our discussion starts, this is a QR code that you can scan in case you want our roundtable to win best roundtable, of course. If you want, you can vote us. It's up to you. Thank you.
First of all, thank you all for the dedication that you guys showed in this presentation. And thanks to the organizing committee of CAMeSM for an incredible, yet another incredible few days. Personally, I think this was very fruitful. It's very interesting for me to see students of the preclinical years being involved and being motivated to learn about or have a clinical gear, let's say. Their motivation and their dedication showed. It was very obvious. I mean, we spent, and the talent showed too, because I think we spent a total of 4 hours, 5, 4 hours with me, a bit more, okay, fine. Less than a day though. And the three of Aphrodite, Razi, and Styriani are now able reliably and consistently to get almost textbook images on ultrasound. This is something that took me maybe a month or two to learn, so that was great. And they have this passion for the clinical aspect of cardiology. Their understanding was, I think, transmitted to you guys very fluently, with a good flow, and that's what makes those roundtables interesting. It would be boring if this was a normal lecture, but rather the way that it was explained was very, very nice. I hope you guys enjoyed it as much as I did. I hope McMarlborough lives, and I hope the interventional cardiologist with the nice Mont Blanc pen gets paid a good... Okay, thank you guys. If you guys have any questions, we're open. And just for the faculty or people of the clinical years, I think it's very, very important to embrace students wanting to learn a skill or wanting to learn and go more in depth into a specialty to actually embrace that and give them the opportunity to learn as much as possible. I think we'd be surprised how much we can offer them, and with the 1% or 10% that I gave Aphrodite, Razi, and Styriani, they were able to take it all the way to 100% on their own. So we thank the European University for that too. Awesome. Thanks.
Do you guys have any questions? Who wants to answer?
Am I to assume that all of you are aiming to become cardiologists one day?
Hopefully. I mean, I'm first year, so I personally haven't decided, but it's up there. It's up there. That's what I'll say. Yeah.
Well, the subject matter was on the heart, so that's why I assume that probably in the back of your minds, even though you may not be committed completely to cardiology,
I mean,
you're thinking about it.
Clarita?
You can assume that all of us want to become great doctors in the future, no matter the career that we pursue, and we will do our best to attain to anyone who would want to be a patient, not want, not want, but who might be a patient, because that is our duty and that is our role as doctors.
Well, good luck to you. I can tell you that the presentations were very interesting, well presented. I happen to be a professor myself, not of medicine, and I can tell those that have put work behind the presentation, they know the subject matter, and they try actually to be the best they can be. And thank you all of you for being dedicated doctors one day. We need you, not only for science, but also for humanity.
Thank you so much.
I have a question about the heart, basically. So, why a patient during an echocardiogram has to be on his side, laying on his left side, actually?
That's actually a very good question that I had as well before we started this roundtable. Basically, we want to maximize imaging quality. So by having the patient lay on his side, the heart, anatomically with gravity, goes towards the chest wall. So in that way, we minimize the distance between the ultrasound waves and the heart, and we have more clear pictures. And another thing, we minimize that way lung interference. So because air, as you might know from physics, is not a good medium for ultrasound waves. And in that way, again, we get more clear pictures. I hope I answered that question. Dr. Zia, do you have to? Okay, thank you.
First of all, guys, that was amazing. Really well done. That was so insightful. Thank you so much for your time. Razi, I have a question for you. Why can't the heart absorb the oxygen directly from the blood inside its chambers?
Hello, thank you for the compliment. So the myocardium of the wall, of the heart, is quite thick, so oxygen cannot diffuse alone, hence why we have the specialized system to get through to the deep layers to supply it with oxygen. I hope that answered your question. Thank you.
It does. Thank you.
I would like to ask, why does the impulse slow down in the AV node? Could some of you explain that to us real quick?
So the reasoning behind the impulse slowing down is to allow enough time for the ventricles to fully fill before they contract, so that enough blood is able to be delivered to the organs.
Thank you so much. Cheers.
So I have a question, but I don't expect, it's a kind of difficult one. So preclinical years to know this extent. But I was wondering, you were mentioning about heart blocks. Second degree, if I'm not mistaken, has 2 types. Which one is more dangerous? And is there a reason behind this?
I think if I'm not mistaken, but we haven't covered that part yet, I think it's second degree.
Okay, thank you.
From the second degrees, you have the Mobitz and the Weckenbach, and depending on the case itself, some of them can convert to third degree, and others don't, or to a higher degree of block. In essence, none of them are really benign. You need to monitor the both. Even a first degree heart block at some point could be an early warning sign. So you need to really monitor those patients at all times.
I have a second question.
Follow up, yeah.
This is about the coronary anatomy. I was wondering, you said the PDA determines the dominance of the heart. And you said you can have left and right dominance, you can have co-dominance. So my first question is, which one is more dominant? Is it left or right? And the second, answer that now.
I believe traditionally it's more right. I think I've mentioned it's about 70-80% of individuals are more commonly right, and some individuals are left.
And if it's left dominant, would that be from the main coronary artery, or would it be that supplies the PDA, or would it be from another artery?
I mentioned it's from the left circumflux and then the left coronary artery.
Okay, just make sure. Thank you.
Thank you.
Great presentation.
Any other questions?
Congratulations to all the students today. And I have to say, I'm extremely proud of all of them, even though I don't know any of you. But I know my colleague Ziad, and I know he loves teaching, and he loves what he's doing here. So I'm very proud of you, bro. Thank you.
Alex, we need to go back to work, huh? Any further questions before we close the roundtable?
Well, if you don't have any other questions, again, you still have some time to scan the QR code if you think that we were the most interesting roundtable. Of course we were, let's be honest here, and, and very humble, of course. That's it. Thank you all for attending today. I want to thank Razi for allowing us to experiment on him multiple times for the sake of the eco. I would also like to thank Aphrodite for spending extreme amount of time on learning how to get the parasternal axis, the short axis, every echocardiogram view. I would also like to thank Joy and Clarita from Unique, and you guys did an excellent job.
Thank you.
I liked the open door analogy as well, Clarita. And Razi, man, you need your own show. Please. Also, I would like to thank Dr. Zayad for the hours he spent teaching us how to do the echo, because this is a clinical skill that we do not get taught at uni during the preclinical years. So it's very important to develop that skill early, because many people have difficulties later. And we really appreciate it. Everyone from our team can agree on that. And of course, thank you all for attending today. Have a nice rest of the day at CAMeSM, and see you.
Good afternoon, everyone, and welcome to the final Day 1 CAMeSM Roundtable discussion in pediatrics, titled Old Diseases, New Challenges, Why Are Preventable Diseases Coming Back? Preventable diseases were once considered major public health victories. However, in recent years, several of these diseases have begun to reemerge, creating new challenges for pediatricians, healthcare systems, and communities. This roundtable will explore why diseases that should be preventable are returning, and what this means for children's health. The discussion will consider factors such as vaccine hesitancy, misinformation, reduced public trust, gaps in healthcare access, migration, global outbreaks, and changing patterns of disease prevention. Today's discussion will be led by Dr. Atamos Hadjipanais, consultant pediatrician, director of the Pediatric Clinic of Larnaca Hospital, and associate professor at our university. He will be joined by presenters Sotiria Lorita, Eva Bronzu, Maria Paskevova, Dr. Polina Adonio, and Konstantina Yergadzinu. We invite you to follow the discussion and actively reflect on the future roles that doctors can play in protecting children and communities, especially in diseases that medicine already has the tools to prevent. So please join me in welcoming the doctor and the presenters.
Okay. Good evening, everyone. Thank you so much to be here. Can I ask a question? All diseases, new challenges, why are preventable disease coming back? So, in this roundtable, we will discuss about major vaccine preventable diseases, such as measles, pertussis, and Haemophilus influenza type B, while also exploring why these diseases are re-emerging. In particular, we will focus on the role of vaccine hesitancy and the need to strengthen vaccine confidence. First of all, we'll discuss for measles. A definition of the measles. Measles is a contagious infection disease. It's caused by a virus from the morbillivirus genus. It spreads through respiratory droplets when someone coughs or sneezes. And it's serious because it can lead to complications, especially in young kids. Early symptoms. What do you feel first? The early signs are common cold-like symptoms, such as high fever, cough, runny nose, and red watery eyes. And these usually show up first, kind of like the initial stage of the illness. Case signs and progression. A couple of days after those initial symptoms, things start to get more specific. 2 to 3 days after initial symptoms, the classic measles you might see couple spots. These are tiny white spots inside the mouth, and they are a pretty key indicator. 3 to 5 days after initial symptoms, the classic muscle rash appears and usually starts on the face and spreads all the body. Epidemiology. Measles has a story. It was first described by Francis Home, and it was really common childhood illness. In the US, measles officially became a reportable disease. Before the vaccine, all children would get infected by the time they were 15. The graph here, as you can see, the graph shows the incidence of measles cases in the US, and you can see how vaccination campaigns have drastically reduced the number of the cases. The impact of vaccination. We can use two types of vaccines, the MMR and the MMRV. The MMR vaccine protects against measles, mumps, rubella, and the MMR vaccine, this is the primary vaccine. It's effective, but for complete protection, 2 doses are recommended. The MMRV is another option, which also protects against chickenpox, and it's typically given to children aged 2 months to 11 years old, and for protection, 1 or 2 doses recommended. Both the MMR and MMRV vaccines can be given at the same time as other childhood vaccination, making the immunization schedule more efficient. Recent outbreaks, Greece and Cyprus. In Greece, between 2017 and 2018, there were over cases. This was mainly due to low vaccination coverage in specific communities. And in Cyprus, it was very different. Most cases are imported and intends to spread within unvaccinated groups. The graphs show that even with high overall coverage, small gaps can lead to quick spikes in cases. And in Europe and globally, as you can see at the bigger picture, Europe is still struggling, and countries like Romania, Italy, and France have been significant outbreaks recently. If you look at the global map, you will see the darkest red areas in Africa and South Asia, where large-scale outbreaks are such more common due to limited access to vaccines. Thank you.
So, while measles highlights the consequences of gaps in vaccination, pertussis presents with a slightly different challenge, a vaccine-preventable disease that, despite long-standing immunization programs, is now re-emerging globally. But what is exactly pertussis? Pertussis, also known as whooping cough, is a highly contagious, vaccine-preventable respiratory infection. It is caused by the bacterium Bordetella pertussis, and it primarily affects the respiratory tract, and it's characterized by prolonged coughing episodes, which can be severe, especially in infants. To better understand the disease, it is important to first consider its underlying pathogenesis. So, pertussis, as I said, is caused by Bordetella pertussis, which is a gram-negative coccobacillus that colonizes the upper respiratory tract, particularly the nasopharynx. A key factor in disease pathogenesis is the production of pertussis toxin. This toxin disrupts the host immune response, damages the ciliated epithelium, and impairs mucus clearance. As a result, pathogens and secretions accumulate, leading to the characteristic persistent cough. Regarding the transmissions of pertussis, it is transmitted through the respiratory droplets, typically via close contact. Importantly, transmission can occur not only from symptomatic individuals, but also from those with mild or even asymptomatic infection. This makes controlling its spread particularly challenging. Moving on to its symptoms, we observe symptoms like persistent cough, inspiratory whoop, rhinorrhea, or even vomiting. Complications can include pneumonia, seizures, apnea, and in severe cases, even death. Clinically, pertussis follows a well-defined progression. More specifically, its progression is divided into 3 main stages. The first is the catarrhal stage, which resembles a mild upper respiratory infection and is highly contagious. This is followed by the paroxysmal stage, characterized by severe coughing fits, as well as the classic inspiratory whoop. Finally, the convalescent stage involves gradual recovery, although the cough may persist from weeks to months. However, not all individuals handle this disease the same. Unfortunately, high-risk populations, such as unvaccinated individuals and infants, present with apnea and cyanosis. Here. It was supposed to be a video showing an infant girl having trouble breathing after she was diagnosed with pertussis, to highlight the fact that these populations have higher risk of complications and higher mortality rates. Yeah. Before the introduction of vaccination, pertussis was one of the leading causes of childhood morbidity and mortality worldwide. In the early 20th century, hundreds of thousands of cases were reported annually, with thousands of deaths, particularly among young children. This highlights the significant disease burden prior to vaccination. The introduction of the whole cell pertussis vaccine and later the combined DTP vaccine and the acellular vaccine dramatically changed the epidemiology of the disease. Following widespread immunization, cases declined by over 90% and mortality was significantly reduced. This clearly demonstrates that pertussis did not disappear naturally. Instead, vaccination fundamentally altered its trajectory. However, despite these successes, pertussis has re-emerged globally in the recent years. Outbreaks have been increasingly reported since 2010, with epidemic cycles occurring every 3 to 5 years. Additionally, a rise in cases has been observed following the COVID-19 pandemic, as multiple factors contribute to this resurgence. In Cyprus, pertussis incidence remains relatively low, with sporadic cases reported. Infants continue to be the most affected group, and transmission is often linked to mild, undiagnosed infections in older individuals. In Greece, a similar pattern has been observed, but with a notable increase in cases in recent years. During the COVID-19 pandemic, cases declined, likely due to public health measures such as masking and social distancing. However, after 2022, a rebound in cases has been reported, with a clear increase in 2024. Again, infants are the most vulnerable, while adolescents and adults act as important reservoirs of infection. As we understand, what we are observing today is not eradication, but a shift in epidemiology. This trend exists beyond the borders of Cyprus and Greece. Across Europe, several countries, including the United Kingdom, France, and the Netherlands, have reported significant increase in pertussis cases between 2023 and 2025. In some regions, cases have been increased more than tenfold compared to previous years. Importantly, the highest mortality continues to be observed in infants, who account for the majority of severe outcomes. Finally, pertussis remains a vaccine-preventable disease with a significant historical burden. Despite the success of vaccination, its recent resurgence highlights ongoing challenges in disease control. And importantly, infants continue to present the most vulnerable group population, emphasizes the need for sustained and effective vaccination strategies.
Good afternoon, everyone. Following the presentations on measles and pertussis, I'll be continuing with another vaccine-preventable pediatric infection, Haemophilus influenza type B, or HIB. HIB stands for Haemophilus influenza type B. It is an encapsulated gram-negative Coccobacillus, and there are 6 encapsulated serotypes from A to F. We care specifically about type B because before vaccination, it was the serotype most strongly associated with severe invasive disease in children under 5, especially meningitis. Its capsule is made up of PRP, or polyribosylribitol phosphate, which is the key antigen used in HIB vaccines. HIB spreads through respiratory droplets, colonizes the upper airway, and in unvaccinated children can invade the bloodstream, causing severe disease. Now let's look at how HIB can present clinically. HIB can cause different infections depending on where it spreads, but the main concern is invasive disease. The classic and most serious example is meningitis. These children may present with fever, irritability, lethargy, poor feeding, decreased mental status, or neck stiffness. Another very important presentation is epiglottitis. This is a medical emergency because swelling of the epiglottis can quickly lead to airway obstruction. HIB can also cause cellulitis, often involving the face or around the eyes, septic arthritis with a warm and painful swollen joint. It may also be associated with less invasive infections, such as otitis media, where we would see a child with ear pain and often pulling their ear, sinusitis, and conjunctivitis. So overall, HIB can present in many ways, depending on the site of infection, but the key message is that it can cause severe and rapidly progressive disease, especially in unvaccinated or incompletely vaccinated children. After seeing how serious HIB disease can be, the next question is, how do we prevent it? The answer is routine vaccination, starting early in infancy. The primary series is usually given at 2, 4, and 6 months, followed by a booster at 12 to 15 months. HIB protection starts early when children are most vulnerable, and completing the schedule, especially the booster, helps maintain protection beyond infancy. So the next question is, does this booster dose really matter at the population level? Figure 3 helps answer that. This figure shows an important lesson from HIB vaccine programs. Introducing the vaccine was the major turning point, but maintaining control required an optimized schedule. Booster doses help sustain protection after the infant series, especially as immunity can decline over time. So the HIB story is not only about having an effective vaccine, it's also about giving the right doses at the right time. Before we look at the main impact graph, I want to quickly set the scene. Before vaccination, HIB was not a rare infection. It was one of the leading causes of bacterial meningitis in children under 5 years old. The children most at risk were infants, especially around 6 to 11 months of age. In the United States, around 20,000 cases were reported every year before routine HIB conjugate vaccination. So this was a real pediatric problem, and keeping that baseline in mind makes the next graph much more powerful. Now let's see what happened after HIB conjugate vaccination was introduced. This was probably the most important graph. It shows the incidence of invasive HIB disease in children under 5 over time. On the left side, we see the pre-vaccine era. Then comes the turning point, the introduction of the HIB conjugate vaccine. Then, after that, the curve almost tells the story by itself. The incidence drops dramatically and remains very low. What I want to emphasize is that this was not just a small improvement. It changed the epidemiology of pediatric disease. HIB moved from a diagnosis clinicians had to fear to a disease many younger doctors may rarely see today. So the key message here is simple. HIB conjugate vaccination transformed pediatric infectious disease. After seeing the overall vaccine impact, I want to bring the discussion closer to our region. This figure shows the incidence of HIB and non-B Haemophilus influenza meningitis in Greece between 2003 and 2020. The most important point is that HIB meningitis remains very uncommon, which is consistent with the success of vaccination. But the graph also reminds us that Haemophilus influenza disease has not completely disappeared. Non-B strains continue to appear, and this is why surveillance remains remains important. So the message here is slightly different from the previous graph. Vaccination has controlled HIB very effectively, but clinicians and public health systems still need to monitor the broader Haemophilus influenza picture. No, sorry. So after seeing what happened closer to our region, the next step is to ask, what does the broader European picture look like today? This figure shows conferred Haemophilus influenza disease by serotype and age group in the European Union and European Economic Area in 2023. The important point is that after HIB vaccination, type B disease became rare, but Haemophilus influenza did not disappear. Today, much of the burden comes from other serotypes and non-typable strains, and this varies by age group. For pediatrics, that distinction matters. HIB vaccine protects against type B, but not against every Haemophilus influenza strain. So this graph reminds us that vaccination transformed HIB disease, but surveillance remains important because epidemiology has shifted. So to conclude, HIB vaccination is one of the clearest examples of how immunization can transform pediatric infectious disease. Before vaccination, HIB was a major pediatric threat, especially as a cause of meningitis and other invasive disease in young children. After the introduction of HIB conjugate vaccines, type B disease became rare in vaccinated population. But the story does not end with the vaccine introduction. The success depends on completing the schedule, including booster doses, maintaining high coverage, and continuing surveillance, because non-B and non-typable Haemophilus influenza strains still cause disease. So my final message is simple. HIB vaccination changed pediatric practice, and sustained prevention keeps that surveillance alive. Thank you.
So, hi everyone, thank you for being here. And we are moving on to the potential causes that are bringing back the vaccine-preventable diseases. And the reasons are numerous, but I will focus on the ones that are associated with the outbreaks. And by the end of my presentation, you will understand why the outbreaks occur and what factors are actually beneficial from changes. Starting off, the first reasons for reemergence of disease outbreaks is waning immunity, which is the natural decline of immune response over time following a vaccination, and booster gaps. These two are primarily the main causes behind the pertussis outbreaks. The recent outbreaks have highlighted the challenges of disease control despite adequate amounts of vaccination, which is due to the short-lasting protection of the pertussis containing vaccination with the frequent need of booster shots. This is quite paradoxical because while the individuals are reported as being vaccinated, they're insufficiently protected later in life, which is very harmful because it endangers the susceptible population, especially the infants and the younger children who are at more risk of severe complications. Moving on, another reason for the reported cases increasing is the improved detection, which is one of the reasons why we're having the Haemophilus influenza type B outbreaks. These outbreaks have reflected a rebound of reported cases after reduced transmission during the COVID-19 pandemic restrictions, and as I've mentioned, improved detection. But while we're in the context of COVID-19, I would like to note some post-pandemic behavioral changes that have influenced and changed some of the health-seeking behavior. And I will focus on the delayed routine childhood vaccinations. So, interlinking that, we're going into the last reason that I will break down in this presentation, and this has to do with the drop in vaccination coverage rates, which is very important to break down because it is one of the main causes that is causing these outbreaks and something that can be actually reversible. It is also the main cause of why the measles outbreaks have re-emerged. These outbreaks have highlighted the close link between the declining vaccination coverage and the increasing incidence rates. Despite the direct protection to the vaccinated, high vaccination rates have shown to offer indirect protection to the susceptible population via the herd immunity since they delay transmission of the infection. But why would vaccination coverage rates drop in the first place? There are numerous causes, and we will break down some of them. First of all, I'm mentioning vaccine hesitancy, which has become a global phenomenon, but it is quite difficult to pinpoint one definition because of how complex and how many factors are actually influencing it. But I will place one definition just so you can understand what I'm actually referring to. So based on the WHO-SAGE definition, vaccine hesitancy refers to the delay in acceptance or the refusal to vaccinate despite availability of services. The main factors that influence it are based on the 3 C's model, and these 3 C's stand for convenience, complacency, and confidence. Convenience includes the barriers to availability, affordability, and accessibility of vaccines, while complacency reflects the low perceived risk of disease, which leads to the low perceived need for vaccination. This is very ironic because the reason why we don't comprehend the risk or the severity of the diseases is mainly due to the succession of the vaccination programs. But anyway, and as for the third, confidence, it highlights the lack of trust in the safety and effectiveness of vaccines, the healthcare system, and the policy makers. So to sum it up a bit, vaccine hesitancy mainly focuses on factors that influence the parents' decision-making. But it is not the only barrier to the vaccination drop. which brings us to the healthcare system factors. And as a first factor, I'm mentioning the healthcare professionals, which are the strongest influence on parental decision. Think of it as a mathematical equation. If you have a healthcare professional which is confident and knowledgeable about the importance of vaccination, you will definitely have more increased vaccine uptake. But if you have a healthcare professional that is hesitant, unsure, or unclear about vaccinations, you will definitely notice a decrease in vaccine uptake. As for the organization of care, the infrastructure of pediatrician versus general practitioner led primary care has raised and reflected some differences that raise many questions, because they have noticed that parents that are consulting general practitioners are more hesitant than parents who are consulting pediatricians. And so they're trying to investigate more as to what could be the causal factors for that. Further into this category, as contributing factors, we have the lack of reminder systems, the failure of follow-ups after missed doses, and the long waiting lists. It is very important to note that a disorganized and messy healthcare system will always breed confusion and mistrust to the receivers. Now we're going more into political territory, but it is very important to note that there are mandatory vaccination requirements for school entry in multiple countries, which has raised mistrust and also enhanced the perception of financial motives rather than public health ones. And this is due to the controlling nature of these actions and the loss of autonomy. Inequity between populations is also evident for vaccines that are not covered by the government, but they are advised by experts. And as my last factor, I will, as a last reason, I will break down the socio-cultural factors, and I will mainly focus on the media. I will obviously not break down every article, but I just don't have the time. I would love to, but yeah. The main point of this slide is to highlight that the media has always played a role in keeping controversies and scares alive, even in the face of strong evidence of safety and effectiveness of vaccines. Be it the association they've made about hepatitis B vaccine and multiple sclerosis, or maybe most of you know this, the MMR vaccine and autism. Healthcare professionals are thankfully still the cornerstone of health concern consultation. However, we are noticing that the internet has now become an essential source of information. In conclusion, as you may have understood, both the reemergence of outbreak and the decline in vaccination coverage are multifactorial. Addressing vaccine hesitancy is important, but not the only factor, since healthcare systems, policy, and social influences play a key role in vaccination uptake. So addressing all of these determinants is crucial for the prevention of future disease outbreaks. Thank you so much for listening to me, and we're going to vaccine confidence.
All right. Okay, so last but not least, it's vaccine confidence, and it's a major part of the whole presentation. So what is the definition itself? So according to the World Health Organization, when we talk about vaccine confidence, we're talking about the parents and essentially the patients being able to trust and have confidence in the healthcare system, and then of course the doctors themselves, in order to come and vaccinate themselves because of effectiveness and safety. Now, I mainly have studies for different reasons. I want to showcase how confidence had affected throughout the years. So here we do have a study that was done between 2015 to 2019. Specifically, we had 179 countries that were involved into it. And the main cause of it was to actually evaluate vaccine efficiency, effectiveness, and then the importance of actual vaccines. Now here we have some important graphs. Unfortunately, I do not have a pointer, but you can see here the countries. So we have found that we had an increase in the vaccine confidence in specific countries over the years, which was France, India, Mexico, Poland, Romania, and Thailand, though we did have a decrease throughout the years in Indonesia, Philippines, Pakistan, South Korea, Afghanistan, and Vietnam. Now we go to another study, and here you can see that it was done over 67 countries. So the aim was to kind of address whether vaccine itself is an issue in terms of public health, also kind of identifying if we do have a decline in confidence, and then of course kind of leading to vaccine refusal themselves. And then we have also here the trends in more specifics and graphs, and we could see that Portugal and Spain had the highest percentage of people responding positively and actually wanting to vaccinate their kids, while Cyprus actually was one of the lowest countries with 41% over the years. But more importantly, in 2020, they also revisited everything, and they noticed that specifically we did have an overall vaccine confidence that was decreased, specifically in Greece, Romania, and the UK. Okay, so what can build vaccine confidence? And you can see them there, which first of all, obviously, is trust. So you need the parents to trust the healthcare professionals. They need to themselves understand why we do a vaccine, what's the importance behind it, what it can prevent itself, and then the social influence. It's a huge part of it, because if you hear that, oh, one parent doesn't want to vaccinate their kid, then eventually others also want to. So essentially, if you have correct information and knowledge and trying to trust and make sure that parents understand, themselves will come and want to vaccinate their kids. Then again, past experience, if you are dismissal, if you don't want to showcase to the parents the importance, also spend time with them about every vaccine, then of course they won't be also positive to come and vaccinate themselves. And of course, accessibility is the last one. Again, it depends on the country, but I think Cyprus and Greece have actually been quite well in terms of accessibility to vaccines. And lastly, and this is the last slide, and we can go back to discussion, what can build vaccine confidence? And you can see the lovely graph there. So the first one is kind of correcting misinformation. A huge issue of why people don't vaccinate is because of misinformation. For example, the MMR vaccine, which was a huge misinformation about giving autism, which obviously is false. So again, educating and making sure that correct information is passed is really important. That also goes to social media, unfortunately, in our days, because if something is false, then it will go along and spread, unfortunately, really, really fast. And then again, healthcare professionals spending time with their parents and their kids explaining why the vaccines are important. So these are our references, you can see. And we are done. Thank you so much.
So thank you very much. Congratulations to all of you. You have done a very good job. This process has many objectives. One of the objectives is to know how to prepare a presentation. Every time I come across to this issue, I see students and colleagues that they prepare 20, 30 slides for a presentation of 10 minutes. This is one of the main mistakes that we all do at the beginning. And then you have to concentrate on the clarity of the slides. And of course, especially on this round table, you need to be a member of a team, so you need to be a team player. Then you have to acquire the skills on how to present, which is also important. Lastly, the knowledge that you acquire through this process in medicine, and of course, the paths that you need to follow in order to get the right knowledge for this specific roundtable. I'm really happy with the outcome of this roundtable. with the students, we had 3 meetings, and I noticed that their presentation improved drastically, and I'm really very happy with what you have presented today to the audience. So thank you very much, guys. Now I open the discussion, and I'm happy to receive any questions from you. Yes, please, go ahead. Just a moment to pass to you the microphone. Can you come closer?
So first of all, thank you all of you for the amazing presentation, and hopefully one day we'll see these diseases eradicated. Secondly, because you're talking about vaccines, I read sometimes that some vaccines are safe for children, some of them are not. So if you'd comment on the types of vaccines and which of those are safe for children?
Well, should I reply to you, or
anyone, honestly?
Does anyone of you want to reply? Please go ahead.
Sure. So I'm a pediatric resident actually in Greece. So I'm going to go straight to the point. As a healthcare professional, each country has its specific suggestions of what vaccines should be done and when they should be done. So first of all, everything is checked from beforehand. It has gone through a lot of testing. So to be able to be recommended in a country to be vaccinated in children, it means that they're safe. So I'm starting from the first point. Now, I don't think it is safe to have children be unvaccinated for a lot of reasons. You can see the outbreaks that the girls mentioned, measles, pertussis, unfortunately, and we can see also unfortunately in Greece. We do have increase of outbreaks because of a lot of people not vaccinating their children. So the whole point is we need the vaccines to prevent having the outbreaks, and of course, not having children dying, which can lead, unfortunately, to a lot of death. So the answer in a sentence is vaccinate your children.
Sorry, my question is like mRNA vaccines, life attenuated, that's like what I meant.
Essentially, if they are recommended, they are safe to be.
Okay, thank you.
Because there is testing before they're being even approved.
There is no vaccine out there in the market if it's not safe. This is one of the major parameters that we have to take into account before we give the license to a vaccine. So all the vaccines that are available in the market are safe. So you shouldn't worry about this. There are only mild side effects, and as my colleague replied to you earlier, I mean, it's better to vaccinate the child for any disease and get these mild side effects, which is usually pain, and sometimes low fever, instead of acquiring any of these diseases. And unfortunately, some vaccine-preventable diseases that we had the feeling that have been eradicated, they are coming back. And we see patients dying because they have not been vaccinated. The last month in my department, we had a child with meningitis, suffering with meningitis from Haemophilus influenza, which is something that I haven't seen the last 40 years in my practice, and this kid was not vaccinated. And unfortunately, the parents will not give any vaccine to the child even after these incidents. Just for you to understand the attitude of the parents. Vaccine hesitancy is a major issue. It's better to talk about vaccine confidence instead of vaccine hesitancy. But you have to put the hesitant parents into two groups. One group is the parents that they have safety issues, and you can discuss with them, and you have to reply to all the questions that they have. And finally, I'm confident 99% that you'll be able to convince them to get their children vaccinated. But there is a small group of parents that this is how I call them stubborn. Whatever you tell them, it's a waste of time. You're not going to convince them in any way. And this is a very good example. This child was literally dying, and finally he is alive. But even after this incident, his parents are not going to give him any vaccines. Any other question? Please.
So, how you would explain or even discuss the fact that health professionals, even colleagues, physicians, refuse to vaccinate their children in the 21st century?
That's a tough question, huh? Anyone wants to reply to this? You can try. Please go ahead. Yes?
Yeah, okay. So we see it every day, unfortunately, in the hospital. There is still a lot of misinformation, and I feel like also healthcare professionals don't research enough sometimes to actually get the information that is accurate for vaccines, especially when it comes to their children. So at least what we try to do, and I'm not saying it's the best, it's not, but we do try every time. A parent is if it's not a health professional, but some way in medicine, like a nurse or anything in that aspect, we try to go through the vaccines and kind of inform them why we do them and what's the importance of them. We do have some of them that they try to refuse. Again, you can't force, unfortunately, a parent to vaccinate their child, but at least you have done your duty to educate as much as you can on the importance of why you do it and what the kid itself could benefit from it. But it is a huge issue, and unfortunately is not getting better.
You have touching my heart with this question. You know, I have been the leader in launching a number of vaccines here in Cyprus, and I have been asked to give presentations in Europe and Middle East about vaccine hesitancy. I strongly believe that the main obstacle of the low vaccination rates among countries is the healthcare professionals, and I can say this openly. And I don't blame the healthcare professionals per se, but also the system. So we need to understand that to vaccinate a child, we need time. So the vaccinator, whoever is the vaccinator, a pediatrician, a GP, a nurse, needs to be compensated for the time that he's going to allocate for this procedure. So in some countries, the authorities understood this major issue, and they are putting a lot of effort to resolve it. In Cyprus, we had a long discussion with the previous ministers of health, so we managed to combine the VCRs of the children assigned to their list, to their salary, and we have seen the increased levels of VCRs among Cypriot people. But yes, I agree with you that we are of the people that should get the children vaccinated. The parents trust us. You choose myself as the pediatrician of your children because you trust me. So I'm in a position to convince you to get your children vaccinated. If I'm not convinced about the importance of the vaccines, how can I convince you? There is no way. And of course, again, it's a matter of financial issues that each one of us want at the end of the day to go back at home and take a good salary. Yes.
Not only, as you say, believe, but they don't know that
what's supposed to know about the vaccines. So first you have to educate the internals, and then we go to the outsiders.
I couldn't agree more. It's, this is the truth. So we have to educate and convince our colleagues before we go down to the ground and start talking to the parents. Because who is going to talk to the parents? The pediatricians, the healthcare visitors, the nurses, whoever is the first contact to the parents. You are absolutely right. And unfortunately, there are colleagues that I could say they are neutral towards vaccines. I can't say that they are anti-vaccinist, but they don't really support the idea of vaccinating children.
They remind me the priest that does not believe in God, actually.
Yes. Well, in two words, you're right.
Congratulations from my side. Well done, and good coaching, and it shows, and well done to everyone. Coming from a corporation, I want to tell you that it's a bit of a discrepancy of what kind of trust we put to pharmaceutical companies that develop these vaccines, because a big chunk of the responsibility towards lack of education and awareness of the doctors falls on the shoulders of pharma companies. And as a result, the confidence is not instilled in the doctor, and in turn, it's not instilled in the parent who acts as a guardian and decision maker for the child. So it's a bit of a paradox, because patients are very, very fast in putting trust in pharma companies and their drugs when disease hits them or their children, and they are very quick in wanting innovation and drug development that comes from pharma company. But that is at the time of disease. The fact that you vaccinate people or children at a time where they're not in fact ill, and the mode of administration through an injection, are two things that the pharma companies need to clarify and sort out internally before this trust is instilled primarily in the doctor and in a second phase into the patient. So it has deep roots of lack of trust, and it does hit all levels of the participants.
Well, this is a human being behavior. So I can understand this, and I can understand that the people, if they get sick, they seek for advice to recover immediately. But you know, to prevent a disease, they usually say, well, this disease will never hit me. That's the idea behind this. And I can tell you a real story I had in my professional life. That was 20 years ago. The HPV vaccine was launched in Cyprus in 2006. And at that time, I had an 18-year-old girl that the family didn't want to give the vaccine of HPV for many reasons. But I think mainly it was for religious reason. And 2 years before, I mean, after 18 years, they came to my office because that lady was suffering from cervical cancer, and the father told me, listen, doctor, I can sell my house, I can sell anything I have in my life, please save my daughter. I couldn't really say anything to this family. I couldn't go back and tell them that, listen, guys, do you remember 20 years ago you are in the same office and I was trying to convince you to get this child vaccinated? You didn't, and now you are standing in front of me telling me that you can sell everything you have in life to save her life. But this is not possible, because cervical cancer is not treatable at the end of the day. Yes, please.
vaccination, but the parents disagree. What happens then?
That's an ethical. It's about the ethics, okay? And when depends from country to country. But please go ahead to give the reply, and then I'm here to support you in any way.
Yeah. Okay. So it's as Dr. Hajibangi said, it depends on the country. So unfortunately, for instance, where practice in Greece, it goes by the law, which says that if a parent disagrees, they can sign that they disagree on a specific vaccine. So they do sign on the booklet of vaccines that for child has, and it's their essentially fault in a way, or legally, if something happens in later in life. So legally, a parent always needs to agree, in Greece at least, where I practice. So it's a huge discussion because unfortunately, like you can see a lot of children that have critical thinking, as you said, and they do understand, but then for whatever reason, that could be religion, that could be what they read, and it was obviously misinformation, or for whatever reason, if the parent disagrees, unfortunately, you cannot do much. You can always try to explain the reasoning, unless it is threatening their child's life, where you can call you call essentially the law, where police is involved essentially also within the whole thing, but it needs to threaten the child's health.
So to reply to your question quickly, during my presidency of the European Academy of Pediatrics, we ran a study to find out what is the law across Europe. And unfortunately, in some countries, there is no law. And there is a huge variation between the countries that there is a law in place. So in these countries, children can take their own decision for themselves at the age of 16, in some other countries 17, 18. So it depends very much on the country. So this is the straightforward reply to your answer. So I think, the last question, and then we close the session because it's already 5 minutes past 7. Please, go ahead.
Actually, I don't really want to ask a question. I want to congratulate all of you on your excellent presentations. I think you've worked on them, and this really showed throughout the presentation. And congratulate the professor as well, and thank him both for your time and for your guidance throughout this procedure. And now, since unfortunately time is up, perhaps you would like to have a final statement, and then we can move on with the opening ceremony for everyone. Thank you.
Thank you. Congratulations to the team. And of course, the idea, I want to repeat myself, is not to bring to you the knowledge about the vaccines, the vaccine preventable disease, but that was a nice trip that we took together, and I hope that you enjoyed it as much as I did. So thank you very much.
Also, before you leave, don't forget to vote us in the QR code.
Good evening, everyone, and welcome to the opening ceremony of the 8th Cyprus Annual Medical Student Meeting. We would like to begin by inviting to the stage our chairs, Aphrodite Pasco and Ioannis Metalinos.
Thank you.
Good evening, everyone, and welcome to the opening ceremony of the 8th Cyprus Annual Medical Student Meeting. On behalf of the organizing committee, it is our pleasure to welcome our distinguished guests, faculty members, doctors, students, and everyone else joining us this evening.
CAMeSM was created with a simple but important purpose: to bring medical students together through education, clinical exposure, academic discussion, and meaningful collaboration. Over the course of this meeting, we hope to offer not only knowledge, but also inspiration, the kind that reminds us why we chose medicine in the first place. This year's program brings together keynote lectures, clinical workshops, roundtable discussions, free paper presentations, and opportunities from students from across Cyprus to learn, connect, and engage with the wider medical community.
It is now our pleasure to invite Dr. Ioannis Patrikios, Deputy Dean of the School of Medicine at European University Cyprus, to join us to the stage for the opening address. Ladies and gentlemen.
Good afternoon, everybody. As a matter of fact, I am of the two that founded CAMeSM in the third year of operation of this school. At CAMeSM, the letters of this CAMeSM meeting, it was my idea. And I'm proud about that small E in the middle. Used to be a capital E, but I said, no, it has to be a small, and that made the difference. So this is my baby, my dear friend, Achilles. Saying that, thank you for inviting me for this short kick-off talk. Distinguished guests, esteemed colleagues, respected medical professionals and scientists, dear students, it is a true pleasure to welcome you to the opening ceremony of this year's Student Medical Congress, the CAMeSM 2026. Standing here today, I am reminded of the extraordinary energy and ambition that define our School of Medicine. This Congress, organized by Students for the Students, is one of the clearest expressions of that spirit. I want to begin by acknowledging the remarkable dedication of the organizing committee. You have taken on the responsibility of creating a platform that brings together aspiring physicians, researchers, and innovators with some of the most accomplished figures in modern medicine. This is no small task. It requires vision, discipline, and the courage to imagine something bigger than yourselves. You have succeeded, and you should be proud. To our distinguished medical professionals and scientists joining us, your presence here carries immense weight. For our students, you represent not only expertise, but also possibility. You are embodying the idea that medicine is not a static field, but a living, evolving discipline shaped curiosity, compassion, and relentless pursuit of knowledge. Thank you for investing your time and wisdom in the next generation. To our students, the heart of this Congress, I want to say this clearly. Events like today are not simply academic gatherings. They are milestones in your professional formation. They are opportunities to challenge assumptions, to ask difficult questions, to learn from those who have walked the path before you, and to begin shaping the kind of medical professionals you aspire to become. Medicine today faces challenges that are more complex than ever. We confront global health disparities, rapid technological change, ethical dilemmas in research and practice, and the growing need for interdisciplinary collaboration. But with these challenges come extraordinary opportunities. You are entering the field at a moment when innovation is accelerating, when scientific breakthroughs are reshaping our understanding of disease, and when the world needs thoughtful, skilled, and compassionate physicians more than ever. This Congress is your chance to engage with that reality. Over the coming days, you will hear from experts who have pushed boundaries in their fields. You will present your own work, exchange ideas with peers, and perhaps even discover new interests of future collaborators. I encourage you to participate fully, not only by listening, but by contributing, questioning, and imagining. As Deputy Dean, I am deeply proud of what this Congress represents. It reflects the values we strive to cultivate in our school: academic excellence, intellectual curiosity, leadership, and a commitment to service. It also reflects the power of students' initiative. When you take ownership of your education, when you create spaces for dialogue and discovery, you elevate the entire academic community. Let this Congress be a reminder that your voice matters, your ideas matter, your passion matters. The future of medicine will be shaped not only by established experts, but by you, the students who will soon become clinicians, researchers, educators, and leaders. I wish you an inspiring, productive, and memorable Congress. May the conversations you begin here continue long after the closing ceremony. May the connections you form grow into collaborations. And may the knowledge you gain strengthen your commitment to the noble and demanding profession you have chosen. Thank you, and I officially declare the Student Medical Congress, CAMeSM 2026, open. I am also happy and I have the privilege to introduce a colleague, a friend, a brother for so many years, for 15, 17 years, Achilleas Gravanis. Thank you for coming, Achilleas. You are always welcome. Achilleas Gravanis, Professor of Pharmacology, School of Medicine, University of Crete, and researcher, Institute of Molecular Biology and Biotechnology, Forth. He served as a member of the European Commission's Biomedical Research Program Committee, a member of the board of the Hellenic Council of Quality Assurance, Authority for Higher Education, and chairman of the Sectoral Scientific Council for Biosciences of the Hellenic National Council for Research and Technology. He served also as a member of the Council of the Hellenic Research and Innovation Foundation in charge of life sciences. Affiliated professor, School of Pharmacy, Northeastern University, Boston. Affiliated professor of pharmacology, Medical School, European University Cyprus. He vice president of the board of directors of Athens Life Tech Park. Affiliated principal investigator at Emulate, a spin-off of which Harvard University, co-founder of the biotechnology spin-offs BioNature and Reneurocell Therapeutics. He published 174 papers, sitting in PubMed with an H index of 57. The podium is yours.
So, guys, thank you so much for this very kind and honorable invitation. I must tell you that today I had to be with the Prime Minister of Greece. I participate in a committee for the foundation of a new ministry for higher education, research, and innovation. And I replied to him that I have better jobs and better things to do in my life, being with you, medical students. And you know why? Because I'm quite sure that you will be my physicians in the coming few years. So I have a vested interest to be today with you here. Today I'm going to tell you my journey for the last 20 years with young physicians, scientists in Crete. And I'm going to explain to you how a small group of talented young people can make the difference and start to work on the development of new therapeutics in a small country like Greece without any tradition for contributing in this era. And I hope that I will convince you that everything is possible if you are a teammate, you are a group of people with interdisciplinary approaches of a specific medical condition, and you can find a way and the courage to go on with very ambitious, actually, projects. So our group has two paths to follow. One is to develop small molecules which are very useful in the treatment of neurodegenerative diseases like Alzheimer's or Parkinson's disease or demyelinating diseases. And we have founded, all of us, a small company 19 years ago in Crete. Its name is BioNature. And we have some patents in this spin-off. Actually, I must tell you that two of the inventors of these patents are undergraduate students of our medical school. Now they are very, very prominent, actually, colleagues internationally, and you will follow their evolution through my slides. The second spin-off company was founded a few months ago. Its name is Reneurocell Therapeutics, and it deals with new treatments, cellular treatments for brain trauma, and we focus specifically on spinal cord injury and paralysis, and lately the reversal of damages in the optic nerve. The first indication is paralysis, and the second is blindness. So we advance new technologies to create actually new therapeutics. So let's start with the first spin-off company. I must tell you that, you know, I have studied pharmacy and medicine. I never practiced none of them. Actually, I'm an educator for medical students and a researcher. So I can tell you that in your life, you cannot do everything. You have to prioritize your activities. So to become very effective, you can work very well as a clinician. You know, everybody of us in medicine and research work for the clinicians, actually. These are the guys that treat people and us. But you can follow your path in research and stay in research, clinical research or basic research, or become someone that is dealing with drug developing big pharma. So you have to be open-minded what to do with your profession. So BioNature started 19 years ago, and we have now pretty good data. There are two ways to develop a new medicine. The first one is to have a therapeutic target. You know a pathophysiological condition, you know the mechanism, how the diseases evolve, and you target the different paths. There is another way, which is by chance. You work in a completely different field, and you find data and findings that are useful to organize a potential new therapeutic tool. In our case, is the second one. So we were working as a group for many years, 20 years ago actually, on DHEA, dehydroepiandrosterone, is the most abundant steroid in humans. We have levels in our circulation and in brain and other issues, in other tissues, 20, 50, 100% more steroids like estrogens, glucocorticoids, or androgens. DHEA is a very, very old molecule. You can find it in species 500 million years old. And we were working on very interesting clinical data showing that during aging, DHEA declines in the brain, in the human brain. And there was a big, actually, discussion and hypothesis that this molecule was a neuroprotective molecule. So that's why we found no levels at all in people post-mortem, in people suffering from Alzheimer's disease. So we engaged in Crete to define what is the molecular mechanism by which this steroid acts as an endogenous neuroprotectant in the brain. So Yannis Charalabopoulos, in the left part of this slide, came in Crete to prepare his PhD thesis. He was a biologist, and he found very interesting data showing that DHEA, it's a small molecule, it's a steroid, it doesn't bind to the conventional intracellular steroid hormone receptors as other steroids do. On the contrary, it's recognized by membrane receptor, a steroid recognized by a membrane receptor. It activates genes that are involved in controlling apoptosis, specifically by inhibiting apoptosis through the induction of anti-apoptotic BCL2 proteins. So when Yannis Charalabopoulos was writing his PhD thesis, we were shocked by the similarities of the whole mechanism with a very important and prominent, actually, peptide, polypeptide, nerve growth factor. Nerve growth factor is a neurotrophin. It was discovered not by chance when I was born, actually, and the guys, the colleagues that discovered it, Levi Montalcini and Cohen, got the Nobel Prize for this discovery. Neurotrophins are very important to sustain the neural tissue. If we lose neurotrophins, the capacity of our brain to produce neurotrophins, even at the late stage of our lives, this is a signal for the nervous system to decline. Not only the nervous system, but also myocytes. So it is a very important molecule, and we'll see some of its properties later. So the question was how this molecule works. We didn't have any specific receptor, no receptor that mediated this effect. And Iakovos Lazaridis, Yannis Charalabopoulos went to Karolinska Medical School, and now he is the professor of pharmacology in our department. He came back, and he evolved as a professor of our department in Crete. The second guy that came in the lab was Iakovos Lazaridis. He finished his master's degree in biochemistry in UK, and he came to take the field from Yannis. And he showed that the unknown receptor actually for DHEA in the membranes of neurons was the very known TrkA receptor, the high affinity receptor for NGF. So we had a mechanism showing that a small molecule, very, very old molecule, can mimic actually neurotrophins by binding on its receptor. Iakovos Lazaridis is an assistant professor of neuroscience at MIT in Boston today. So the third guy that came, the three musketeers, many years ago, was Sifis Pediaditakis, a biologist coming from the University of Crete. And Sifis tangled the question, okay, this small molecule binds only to an NGF receptor or also to the other neurotrophin receptors. We have NGF as a neurotrophin, BDNF, we'll see later, and NT3. And Sifis discovered that indeed this small molecule can bind to all neurotrophin receptors. So we published this data, and we advanced the theory that, you know, this small molecule, highly lipophilic, was the ancestral actually neurotrophic factors in very simple species that can need a small molecule with high half-life to stay everywhere and forever within the organism to protect and support the survival of their neural tissue. Once the species evolved, we needed a tempospatial regulation of brain development, so a steroid, so stable steroid was not a good case. So nature discovered and uncovered polypeptidic neurotrophins, more elaborate neurotrophins, which are actually hit-and-run molecules. It's not like DHEA. They are produced, they activate specific neurotrophin receptors, and then they disappear. So Sifis Pediaditakis came with me in Emulate, in Harvard Medical School, to continue his studies as a postdoctoral fellow, and now he has founded his brand new company. Its name is Fragma Therapeutics, and he is dealing with the development of new therapeutics for Parkinson's disease, and they have very good data. In the next year, they will go into clinical trials with a very specialized antibody for Parkinson. Few informations on neurotrophin receptors. We have three major neurotrophins, NGF, BDNF, and NT3. Each one of them bind to a specific receptors of TrkA family of the receptors, TrkA for NGF, TrkB for BDNF, and TrkC for NT3. All of them bind to pan-neurotrophin receptor with lower affinity. In other words, they need more concentrations to activate the receptor compared to the three ones. And in contrast to the TrkA receptors, which are neuroprotective receptors, once they're activated, they protect neurons, BDNF and NGF and NT3 binding on the P75 NDR receptor induce cell death and apoptosis. So this system of neurotrophins regulate in a very precise manner the development of neural tissue in the early phases of our life, and they are very important for many actually events happening in the brain, from cell survival, proliferation, differentiation, axonal growth, dendritic allocation, synaptic formation, and many other things. So these molecules are extremely important for the sustainability and the health of human brain. So having all this data in our mind as pharmacologists, we said, okay, we have a small molecule that can mimic some of the properties of neurotrophins. This is a good candidate to produce and design small molecules against neurodegenerative diseases. And there are many mechanisms of neurodegeneration of our brain. First of all, we have loss of neurons in many different types of neurodegenerative diseases. Depending upon the type of the neuron, you have a specific condition, clinical condition. And cholinergic neurons, for instance, are very important for Alzheimer's disease, and other neurons also are involved in different neurodegenerative diseases. Another phenomenon that is happening during neurodegeneration, demyelination processes. Neuronal axes lose myelin, and by this way they are not functional. We have also neuroinflammation with the activation of microglia, very important, astrocytes. And another phenomenon that was discovered the few last years is neurogenesis. When I left medical school, we had all of us the knowledge, the dogma of Cajal, a Spaniard, actually, neuroanatomist. Once you are born, you will die with the neurons that you got from your mother, and that's it. So now the dogma is not existing anymore, because we know even in the brain of a person of 90 years old, you have niches of neural stem cells. Cells, in other words, that can differentiate, proliferate asymmetrically, and differentiate to different types, almost all types of neurons we need. So even a brain, an aged brain, can have the capacity to self-repair by just increasing the numbers of residual neurostem cells, migrate them in the neuropenic areas, and the microenvironment can give the signals to differentiate into different types of neurons. Sensory neurons, motor neurons, GABA alpha neurons, NMDA neurons. And this is something that is very important for your future, because one of our efforts now is to develop small molecules, boosters of endogenous neurostem cells, to induce self-repair of the brain in different neurodegenerative diseases, including aging. So when you will be specialized physicians, most probably you will have new medicines that will help stop, even reverse, the aging of the brain, which is a very important task for the modern, actually, medicine. We cannot become, live forever, but imagine someone that has good status of their working brain in his or her 90s. So this is one of the very important, actually, targets of modern medicine. So another thing that we faced as a group, not only us, but everybody that working in the neurodegenerative diseases, is that we don't know, guys, the mechanism, the pathophysiological mechanism of whatsoever of all neurodegenerative diseases, except the monogenic ones like Huntington chorea, which is formed by specific mutation of Huntington, a specific protein. So we don't know what is the mechanism to develop Parkinson, multiple sclerosis, demyelinating syndromes, Alzheimer's disease, or whatsoever. So we could not, we can't, not us, everybody, had the knowledge to design systematic treatments, treatments that will stop the disease, even reverse the disease. So, and this is your future. You know, research will give you the data and the knowledge to design in the coming years, not so far from today, systematic therapeutics, not symptomatic ones. So you will have the possibility of giving a medicine to an Alzheimer's guy that will stop the disease, even reverse some of the events, negative events of the disease, by inducing neurogenesis and replacing cholinergic neurons, suffering cholinergic neurons, with freshly formed neurons. So this is your future. Our presence is to help these patients to develop very effective, multifaceted, symptomatic treatments. And we focus on that. One message to you, if you cannot treat a disease, you have to give lots of efforts to keep your patients in good shape, because medicine can give you solutions not after 1 or 2 or 3 or 5 years, even after months. So your responsibility is to keep the good shape, the good status of your patients, so to give them the chance to have a better life by having new therapeutics. It's not important only to stop the disease, but it's very important to keep them in good shape. This is very important. You should keep in mind when you will practice clinical medicine. So we focused, when I was doing my PhD studies in France, in pharmacology, the dogma and the a la mode actually system for developing new drugs was the magic bullet. One molecule, one receptor. So you don't have side effects, you focus on a specific receptor system, and you are very effective and less toxic. But unfortunately for us, most of the diseases are not monogenic diseases, they are multifaceted diseases. So, and they have redundancy. You can stop one pathological pathway, but you can have 3 or 4 around that will continue the natural history of the disease. So now the new dogma, which will not prevail for sure for the coming years, and it's you that will, will do that, is multifaceted molecules. One molecule, different receptors that are involved in a pathophysiology. So that was our way of thinking, and we decided to develop small molecules that can first inhibit apoptosis and autophagy of neurons, become neuroprotective. Second, block the activation of microglia and in diminishing or even inhibiting neuroinflammation, protect the synapses, because in most neurodegenerative diseases, synapses also are suffering because the soma of the neuron is suffering. So you have a regression of the neuron axis and demyelination. And of course, on the same time, if it was possible, to have the possibility of this molecule to induce neurogenesis de novo in situ in the brain. So we collaborated with a very talented, actually, organic chemist, Theodora Kalogeropoulou, in Athens, in the National Institute of Research in Athens. And we got DHEA as a lead molecule to develop small synthetic derivatives of DHEA. We were lucky enough because in the paper of PNAS a few years ago, we dissected the pharmacophores dealing with the neuroprotective effects, which we were lucky was in 3-hydroxy on the actually the left side of the molecule, and we were very lucky because the endocrine part of the endocrine molecule DHEA was not involved in its activity. Let me remind you that DHEA is very high in steroidogenesis. You have cholesterol, pregnenolone, DHEA, and afterwards you have estrogens, androgens, and many of these steroid hormones. So imagine giving long-term this small molecule to control a chronic disease. You will scramble actually the endocrine system of these patients. And of course, you know very well that some of these steroids are dealing with hormone-dependent tumors, particularly to people that are predisposed genetically to develop hormone-dependent tumors, breast cancer, endometrial cancer, prostate cancer. So we dissected, chemically dissected, the endocrine part of the molecule from the neuroapoptotic. And we were lucky enough, we developed a big library of chemical derivatives of DHEA. We patented these small molecules, and we started with the brand new, at that moment, spin-off company, By Nature Ltd. CVS Pediatrics showed that indeed one of these derivatives binds with very high affinity, KD, consensus of dissociation of 1 nanomole, very strong association. What means for pharmacology this part of the effect of the molecule? If you have a very low KD, that means that you can have an activation of the receptor in very low concentrations, meaning that you will have a chance to have much lesser toxicity. If you have higher KDs, so you need more of the molecule to activate the receptor, and then you increase the chances of having secondary effects, which is not a very good, actually, thing for a molecule. We have done molecular dynamic studies here in NMR infrastructures, and we used AI technologies to further develop our molecule, and the AI formation of new derivatives, and we went through all the story, and we found much better derivatives of DHEA. Now we have small molecules, more dynamic molecules, which bind. They are not toxic. They are high lipophilic to give them perose, mouth. They bind and activate at low concentrations NGF receptor, and they have neuroprotective actions. They boost neurogenesis, and they block neuroinflammation and protect synapses. We focused on two indications. The first one on diabetic retinopathy. Retinopathy is a neurodegenerative disease. Retina is neural tissue in the back of our eyes. It is connected to the optic nerve, which brings, the optic signals to the optic cortex, and that's how we see. So we focused on diabetic retinopathy, and the second indication we were working was Alzheimer's disease. We published in the official journal of the American Diabetes Association, Diabetes, our findings with one of these molecules, BNN27, showing that they inhibit microglia in the retina of animals, experimental animals, becoming diabetic with the toxin, spetozotocin. They inhibit retinal cell death, which was really very important for us. And now this molecule, every one of these publications is already out there in PubMed. You can go with my name and find them and read them. Most of them are open access, in good journals, open access, so you can have them and read them. The second, indication was Alzheimer's disease. We can use a humanized, animal model, 5xFAD mice. Remember, when you develop medicines for CNS, you have a big problem because the behavior and the biology, neurobiology of us, compared to a small rat, it's quite different, okay? So you have to find an animal model that simulates much better the human function, the human brain function. So we produced transgenic animals having 5 in their genome mutations dealing actually with human Alzheimer's disease. We studied these animals on behavioral changes in their memory. 6 months after their birth, they lose their memory. They have lots of the characteristics and biological points of human Alzheimer's disease. We tested our compound in these animals, firstly on in vivo studies showing if this small molecule can reverse the loss of memory. And I advise you, when you start doing as physicians an experimental series of experiments, not go to the in vitro or ex vivo studies, but go to an animal model, if it exists, that simulates the disease. Once you find effective this small molecule or a big molecule, then you can go and delineate the mechanism with ex vivo or in vitro studies. This small molecule, we were very surprised by showing that reversed almost 50% of the memory loss with different behavioral tests, and we were very happy actually with this piece of work. Maria Kokali prepared her PhD thesis in our medical school and published very recently actually her data. We found also that this small molecule in these animals in vivo, when it was given in vivo, can diminish very strongly beta amyloid in the cortex of these animals. You have to be very careful when you hear new therapies for Alzheimer's disease, like monoclonal antibodies against beta amyloid. They don't work well. I wrote lots of commentaries and papers on this, not so good for the pharmaceutical companies that produce these antibodies, but it's true. Beta amyloid is an epiphenomenon of the disease. It does not produce the disease. Something is happening for many years in our brain. Alzheimer's disease is developed, and one of the consequences and biological points of these differences, we don't know them, is the increase of neurotoxic beta amyloid, the tangling of this peptide, and the death of specific neurons. So this small molecule was able to diminish 50% of the accumulation of beta amyloid in the cortex of these animals. Another trick we're doing in modern pharmacology, we have an animal model, we try to humanize it, but still it's far from a human being. So one way to find out if this data we're producing in vivo are relevant is to compare the action of this molecule to the main endpoints of the disease. So we know, for instance, for Alzheimer's disease, that there are different genes, ApoE, very known, BACE1, et cetera. So we were doing comparative proteomic studies on the effect of this small compound in the brains of these Alzheimeric animals to find out if indeed this small molecule can control the expression of these genes shown already to be related with likeness analysis with human Alzheimer's. And we found indeed in the molecular psychiatry paper that this is the case. In these animals, we tested also the effect of another neurotrophin, BDNF, brain-derived nerve growth factor, and we found that indeed this neurotrophin can protect the oligodendrocyte precursor cells. Remember, oligodendrocyte precursor cells are differentiated into mature oligodendrocytes, the producers of myelin. So if you don't have well-functioning all this chain of events, cellular events, you won't have enough myelin to myelinate your neuronal axis, and you have a big problem. I'm saying to the people not in our profession that multiple sclerosis is an electric actually phenomenon. You have the neuronal axis, which is not isolated in many neurons, so the gapping of the contact of this damaged neuronal axis produce breakdown of the formation of the signal, and by this way you don't have the signal going down or up, and you're paralyzed. That's as simple as I presented. So we found that indeed BDNF is able to protect another neurotrophin, oligodendrocyte precursor cells, and not only that, but also it's a protective factor against the deleterious effect of amyloid beta in the system of oligodendrocytes. We went to our organic chemists, and Despina Haru, chemistry, graduate, produced another new chemical library, not for TrkA receptor, for NGF receptor, but for BDNF receptor, TrkB receptor, and again with the collaboration of my good friend Theodora Kalogeropoulou, research director in Athens. We have tested some of these small molecules in different types of in vitro and ex vivo models, and we found that indeed in adult rat hippocampal or even fetal rat hippocampal cells and neural stem cells, this small molecule was very effective in protecting these neurons. Again, to define the significance of our data in vitro systems and in animal models, we tested with functional genomics and expression analysis, ontology, if this small molecule could block or induce gene expression that was involved in Alzheimer's disease. And in the paper, you will see that it was very effective in controlling many, actually, of these genes involved in the disease. So now we have small molecules, non-toxic, highly lipophilic. You can give them per dose, stable enough. We know exactly the pharmacokinetics. And we propose for an efficient, actually, control of the symptoms of neurodegeneration, the combination of these small molecules to block apoptosis, demyelination, neuroinflammation, and potentially induce neurogenesis. Our spin-off company studied a proof of concept experiments in different types of neurodegenerative diseases, and we were very, very happy. 1 year ago, one of these molecules was licensed in a small spin-off company, being Novalic, being a spin-off company of a huge company, having 20 actually drugs for diabetic retinopathy. You know how big pharmas work now. They work without sourcing. They don't have labs, dear colleagues. They don't spend money for researchers like us in-house. So they do contracts with small companies, spin-off companies, universities, medical school, pharmacy schools, or research institutions. It's less expensive because the institutions have the personnel. They don't have to pay the personnel. They have the infrastructure. They give money for the consumables and all this money we need to do research. And they, once something is happening, positive, they have a contract for working together to clinically develop the compound. So we're very lucky now. We are on the phase of new pharmacokinetic studies with the eye drop solution they have, with no water at all, just nanoparticles, because if you don't have any water, and you apply these eye drops on the eye, so you don't lose even a small quantity leakage of your eye drop. It's highly lipophilic to enter into the eye and go far and touch and perfuse, actually, retina in a very efficient way. And we are hoping that in the next year, beginning of next year, we will start clinical trials in Europe and in the US. This is the team. Nothing will happen without these young guys. Some of them are not young now. Like Yannis Karalabopoulos, actually, he has more white hairs than me, and actually he doesn't have any hair anyway. He's my professor now, the new professor. Iakovos is at Karolinska. He was at Karolinska, now in MIT. Vasilis Minas was an undergraduate medical student. Vasilis went to Oxford. He did gynecology. Now he's a world expert in Oxford for endometriosis. But he has shares in our spawn company, and he waits our success to get some of the money, if the money are coming. We don't care if the money are coming. We care, and believe me what I'm saying, to find ways to help patients out there with no symptoms, with very dangerous symptoms, no treatments like the diabetic retinopathy. 170 million diabetics. 40% of these guys, if they survive from cardiovascular and kidney problems, they will have lots of problems with their vision, and 10% of them will become blind. And we have no ways, even paragoretic ways, now to help them. So the joy of developing a help for them would be really without money, with no money comparison. Paskalis Evstathopoulos went to Karolinska, and now he's a senior scientist at Novo Nordisk, Novo Nordisk, with the new medicines on metabolism, very effective, very interesting, with different indications actually. And he is the chief of the new department in Novo Nordisk for developing new cellular therapies with stem cells for Parkinson's disease. And Maria Kokali left us, and she works now in IntelliCadia, a new company in New York, dealing with the development of algorithms to follow up real-time clinical trials and measure the risk of success or failure. So imagine a phase 2 or phase 3 that needs from $200 to $1 billion to have a tool that you can say precautiously that this doesn't go well, so you have to stop it, gain some money, and go give the money elsewhere for the development of our medicines. I will finish with the new company, Neurocell Therapeutics. The idea is to develop neuroimplants for the treatment of spinal cord injury and paralysis. The trauma in the spinal cord has many phases. In the first phase, you lose actually neurons and you create a cyst. But all neural cells and supporting cells like astrocytes and microglia, they die with necrosis. They release lots of neurotoxic material within the brain and propagate the loss of neurons, other neurons that were not initially traumatized, for many weeks. So that's how paralysis develops, and we don't have the way to help these people. We have not, again, even a pyrogoretic treatment to make them diminish their, their loss of sensory and motor neurons, and they become paralyzed and with no reversal. The condition is very complicated because you have loss of neurons, you have to replace them, to reestablish neuronal function, to limit neuroinflammation at the same time, to modulate astrogliosis and the formation of scar tissue, imagine a cyst within the spinal cord. You have disconnection of the neuronal axis, up, down, down, up, so you have paralysis. In the same time, you have formation within the cyst of scar tissue, very strong scar tissue. Even some of the neuronal axis from the normal physiological neurons had the chance to communicate and reestablish connection. They won't do it because they cannot pass this strong wall. So you have to deal with these very difficult problems. And of course, the elongation, the problem with elongation and connectivity of neuronal axis. The last 2 years, there were efforts to inject different types of cells within the spinal cord of this animal, of these patients, clinical studies in humans. So intrathecally, they were injected different types of, or systematically, of neural stem cells, or stem cells in general, mesenchymal, for instance, stem cells, Schwann stem cells, oligodendrocyte cells, and neurostem cells. It didn't work, but we had, as always in medicine, failure gives you excellent knowledge for the next step to succeed. And another thing, failure is the best professor for you, dear colleagues. You don't be disappointed when you fail. You have to be resilient and try again. And in most of the cases, you will find your path, your way to succeed. So without failures, you won't become successful. And let me tell you something, if you are immediately successful, something is cooking in there. So, okay, this is very rare, this is happening very rarely, so you have to make questions about your colleagues and your team. So you will have difficult life to become successful. Conclusions of these non-effective, actually natural neural stem cell treatments, we know now that injection of human neural stem cells within the spinal cord, it's not toxic. This is very important for the next efforts, for the next tries. The problem with the neural stem cells, solutions is that you cannot keep them within the traumatic area because they diffuse within the spinal cord. And remember, 45% of the of the medicines we are using today, only 45% are small molecules. 55% are big molecules, you know, the different bioactive peptides and polypeptides, antibodies, genes, RNAs, mRNA, microRNA, sRNA, cells, different types of cells, not only stem cells, and devices. So in a very, and this is very important because if you have a non-effective or less effective treatment, this treatment will not be sustainable. So you can treat the, underquote, the patient for a few months or for years, but you know, the disease will come back. So in a very complicated condition like the spinal cord injury, you have to combine things to, you know, to tackle these different types of problems. Neuronal loss, neuroinflammation, demyelination, synaptic loss, etc. So we decided to combine the different types of manipulations, and we formed a neuroimplant, which is a scaffold, a sponge, with cavities within. It's not easy to construct it. It took us 2.5 years to find the conditions of polymerizing, cryopolymerizing human proteins. Why human? Because the neuroimplant will go into humans. So we won't have to have rejections. We have something that is very familiar, it can be afforded in the human body. So, and this very elaborate, actually, sponge, scaffold, we populated with human neural stem cells in the presence of different types of small molecules to support survival, proliferation, and differentiation within the scaffold of these neural stem cells, human, ex vivo, before transferring into humans. So this is the elaborate way of tangling a very complicated human disease. Another message to you, it's not simple to tangle a very complicated disease. If someone tells you that you have the magic bullet, you have a miracle to treat people, don't believe it. Don't believe him, don't believe her. Most of the time you need, you know, elaborate manipulations, therapeutic manipulations of whatsoever type, from small molecules or cells or genes or devices. So, and this is the case, believe me, in 99% of the cases. So this is an electron microscopy, scanning electron microscopy of a neural stem cell within the scaffold, and you can see in yellow the soma of the neuron, and in blue the forming already neuronal axis. This is a very important thing I'm going to say now. We don't want to transfer into the patients terminally differentiated neurons. Why? Because we have to give them precursor neural stem cells. So once they are in situ there in the trauma, the microenvironment will decide which kind of cells, terminally differentiated cells, they need, not us. So it's very important. Another, you know, complication of developing the neuroimplant, you have to stop, in a certain extent, the differentiation. We don't care about proliferation, but the differentiation, we have to keep them early, precocious. So the spinal cord, the traumatized spinal cord, will decide what type of neurons will form after the transplantation. As always, pharmacology starts with animal models. We went to my friend Robin Franklin, the chairman of Brain Repair Center in Cambridge, in London, and we learned how to operate rats and mice on their spinal cord, producing experimental spinal cord injury. And Alexandra Kuryadaki went there for 6 months. He became an animal surgeon, very proud. She's a biologist, actually. He came back to Crete and helped us to test our neuroimplant in experimentally produced spinal cord injury mice. We produced our findings 3 years ago in a very good journal of Nature series in Generic Medicine, and we were surprised enough that the next year Nature Press selected this paper for their potential clinical relevance as one of the 30 leading research in neuroscience in the world, and that's how we became, from a small island in the middle of the Mediterranean Sea, known worldly, and there were people coming to us to ask for investments and collaboration. These are the data with the, you can find all this data and the videos online. So 12 weeks after the transplantation of our functional neuroimplant, the traumatized animals could walk on a horizontal lander. Imagine yourself trying to walk with hands and legs on a horizontal lander. You have to have the feeling of the space very well, the touch very well, and of course the movement of your legs and heads very well. So these animals were very effective, and in this very very important testing. And post-mortem, we found how this was happening in vivo. We did a trick. The human proteins that were used to form the scaffold were JFP, with JFP, so they were fluorescent. So once we transferred the neuroimplant in vivo to the animals, and post-mortem, the fluorized area was our neuroimplant and not the physiological spinal cord of their animals. And with very elaborate, you will see the paper, studies, cytochemical, molecular, and immunochemical, we found that indeed within the scaffold, 6 to 7 weeks after the transplantation, neurostem cells were increasing in numbers. They were differentiating into sensory and motor neurons and astroglia, and they were adapting themselves in the environment. Their new formed neuronal axes were getting out of the neuroimplant, communicated with the physiological ones, and that's how finally these animals were able to move. Now we are doing a series of experiments, proof of concept, with human neurostem cells using skid mice, mice that don't have the immune system, to not reject actually human neurostem cells. And we are hoping that by the end of this year we will have all this data to go in the next step for using the neuroimplant in paralyzed patients. Firstly, in Spaulding Rehabilitation Hospital in Harvard Medical School in Boston. A good friend of mine, Rose Fonte, a physiatrist, physical medicine, has a physical medicine specialization. With their neurosurgeons there, we are already advanced discussions and inclusion criteria of the patients, the 5-6 patients that will enter into the clinical trial. Wish us good luck, because I can't imagine my joy in the next 2 or 3 years to meet someone paralyzed for 5-10 years, a young guy, because most of them are because of accidents, getting up from the wheelchair, walking by him or herself with help of course, go to the refrigerator or to the bathroom, or going into the car and getting a brand new life. Medicine is not glory, it's not money. If you want glory and money, go elsewhere, because you're going to deal with the most bad things of our species, of our case. I mean, blood, tears, and questions and stress, which is really, you know very well what that means. So, these are the guys that did all this work. Dimitris Zeranis I met him in MIT. He was doing his PhD thesis with Yannis Giannas, a legendary figure of bioengineering. And now I convinced him to come in Crete. He is part of our team, and he was elected assistant professor of tissue bioengineering in the University of Crete. Alexandra is in New York. Hanumidou, she went to a very good lab in Germany for stem cell technologies. Magdalena Koch, I think she was invited once here, and came back as an assistant professor in our department. And I think it's all I had to say. Thank you very much for listening and coming. Yeah, I think we're... Okay, I'll be here tomorrow, so if you want to discuss with me, I'll be at your disposal. I will walk around here, so I'm yours, actually.
Can I ask a question?
Of course.
Is it possible to use a 3D printer and print a neuron in the milling machine using conductor as the inside part, the neuronal synapse and the actual neuron, and something with an insulator on the outside?
Yeah, one of the works we're doing in Emulate is the most advanced, actually, spin-off company of this Institute of Harvard Medical School, and the institute deals with human tissues on a chip. So we develop disease-specific chips, not organoids. That's the difference. Disease-specific chips. We developed, and this is already published. You can go in PubMed and find the papers for Parkinson's disease. And the difference between what Professor Kusparo said and our case is that when we are preparing our scaffold based not by chance, but based on the pathophysiology. So we don't self-organize like organoids, what we will have as an end product. So first of all, this is applied in the ex vivo studies. And secondly, we don't want to prepare a spinal cord tissue ex vivo. We want the spinal cord do this work depending upon what it needs. So that's why we have to go in a certain stage, but before having terminally differentiated neurons. This will happen in vivo, and the patient and then the spinal cord of the patient will decide which type of neurons will develop in situ, in vivo. Okay? All right. A pleasure.
Let me start by saying that your speech was very inspiring. I have a question. I would like to know what are the problems that we might face when we want to translate therapeutic therapies from mice to humans.
That's a very important question. when you develop medicines or therapeutics, dear, for CNS, you use animal models. 9 out of the 10 effective new therapies in mice or rats won't work in humans. And the reason is because we are completely different in terms of the structure of our brain and our behavior. That's why we need humanized models in vivo, as we did with the transgenic animals, or ex vivo, as we did with the human tissues on a chip. So it's not obvious that you have a very good publication on an animal model of a human disease, and you are sure, or 50% sure, that you will reproduce this data in humans. It won't happen. That's why we're struggling to replace bad, actually, animal models simulating human diseases, particularly for brain diseases. The last 20 years, the international pharmaceutical company, because of this flow, lost $200 billion. This is very important when we're discussing with physicians. Why? First of all, because all failures give higher prices, because the companies will increase the price of their medicines to sustain their presence in the market. The second one is that we lose time. And you know, when you are dealing with animals, you're experimenting in animals or in cells, it is okay, you have lots of time. But when you are a clinician and you have your patients and you feel every day the agony of these patients desperately because they don't have any treatment and you don't have any tools to help them, this is a quite different question. So in medicine, time counts very much. So that's why we develop, because of the involvement of brand new technologies, which of them? Cell biology, new materials, stem cell technologies, AI. We use AI to find the best optimal conditions to prepare our scaffolds. How many of these proteins will enter into the polymerization? What temperature? What type of additives we have to add? How long this scaffold will stay intact, so to preserve the presence in situ within the trauma of the transferred neurostem cells. How long it will keep their disintegration, because we don't want them there. We want the newly formed physiological neural tissue, and then they have to disappear. All this, we don't need, we need lots of time. So we don't have time. We use platforms, algorithmic platforms with AI to simulate what is happening in humans and to give them data from experimental animal models, and they propose us conditions. So this is a very complicated, actually, way of developing new therapies, and they are more complicated to develop a small, a cell or gene therapy, or a therapy with biological devices like I mentioned today, compared to the small animals. I'm sorry, to the small molecules. So it is very laborious, time-consuming, money-consuming, and people-consuming. So you have to be very, you have to seek for help. Medicine and research in medicine needs teammates, not egoisms. You go to the specialist, seek for help. And this is not only for the case of research. When you finish and you specialize yourself, you become a neurologist, and Achilles comes and asks you for help. If you don't recognize what Achilles has or suffers from, you have to pick up your phone and go to Aphrodite and ask her, hey, someone came with this symptomatology. Have you seen this case? Do you know what is this guy has? So every time you have to remember, medicine is a marathon of constant training. Read, please, the text I sent you, because it's all the discussion I had with many clinicians. I'm not a clinician. I've never done medicine. I didn't do specialization. I'm an educator and a researcher. But this is very important. Medicine is a team-made condition. Plus, medicine is not only for physicians. You will have around computer guys, technology guys, engineers, bioengineers, and that's how you're going to practice your modern medicine, more effective, less toxic, and potentially systematic and not symptomatic.
Thank you so much.
Sit down, I have to get a picture of you, because it's not so often that I have so many people in my audience. I have to remember you. Thank you.
Thank you.
Guys, thank you very much for joining. It's been really a pleasure to open CAMeSM this way. Please help yourselves to the cafeteria for wine and cheese as a small reward for coming to the ceremony. I hope you enjoyed the session, and we look forward to seeing you to the roundtables, workshops, and the other sessions that we have tomorrow. Thank you.
Kingdom.